Yes, madam. Shall we start the program? It's almost 5 to 6 minutes left for program.
When is the program starting?
Yes, within 5 minutes we are going to start. And
Okay.
yes, and Dr. Deep Majumdar from Institute of Physiology will be going to start the first presentation.
I will be sharing my screen.
Yes, no problem. Madam. So let me introduce myself. Good morning to everybody. My name is Madhu Bhupadya, the presenting Inovine Meetings. Inovine Meetings LLC. Welcome all the distinguished guests, dear doctors, scientists, educators, colleagues, friends, ladies and gentlemen. It's a great honor for me to welcome. We have started our face-to-face meeting in Paris, that is CDJ Airport. And today we are going to have the Zoom meeting through online presentation. I would like to express my most sincere gratitude for your presentation open ceremony as the gateway to initiate our scientific program. And once again, I'm especially thankful to Mr. Kevin, who has heavy burdens, duties, and responsibility to make this event happen today. I would also like to thank participants, especially those who are joined from different parts of the world and those who are now joining from different parts of the world through online presentation and sharing your valuable experience and ideas. With a good number of participants, I am sure this conference will be memorable, highly educational, and not to be missed event. We hope this conference will be help us better understand the concept of advance in physiotherapy, physical rehabilitation, and as well as sports medicine through new innovative approaches and obtain the knowledge on the prevention and treatment of it. We truly value your participation and support for this Congress. Thank you for so much for your attention. Once again, I'm requesting everybody, when the speaker is going to use delivery, going to deliver the talk, we ask all the others to be kept in the mute, either both audio as well as video. And if you have any queries related to this talk, to their topic, we ask you just you can raise your hand and you can chat in chat box by replying your questions. Yesterday we had done the face-to-face meeting in Paris at the CDG airport. I'm once again especially thankful to Dr. Ivana Khasi from Department of Physiotherapy from Howard University from USA, Dr. Silvio Di Rocco from MPR International School from Switzerland, and Dr. Mary Ellen Agner from Kinetic Institute of Physiotherapy from USA. These three are the keynote speakers, those who hand. They will be sharing their photos as well by end of this Congress. And also I'm especially thankful to Dr. Dairo Shah from Asia Physiotherapy and Rehabilitation Clinic from Mumbai, India, Dr. Joyce Chin from Taiwan, and Dr. Imido Lima from Unimia University from Brazil, and Dr. Jessica Obro from Serbia, and also Dr. Alexandria Afia, Dr. Chini Messenger, Dr. Sayed Al Utomi from King Abdullah Azizi from Saudi Arabia, and Dr. Madhusudan Reddy from National Institute of Technology from India, Dr. and moderator of the Congress is Dr. Ankit Bhargava. Thank you very much, sir, for helping us throughout the day for look after the sessions every minute. And also we request, we also thankful to Dr. Mahmoud Rafil from Bangladesh from Kumila Diabetes Center, Dr. Maria Emila of the Congress. So now, day 2, we are going to join with future more presentation. We request Dr. Deepti Majumdar from Defense Institute of Physiology and Allied Sciences from Delhi to start the program. The title will be Theoretical Impressions of Role in 3D Guidance in Physiotherapy. Yes, ma'am, you can start presenting by sharing your slide.
Just a minute.
No problem.
So, good morning, everybody. First of all, I must thank the organizers for giving me this opportunity to speak among this August gathering, especially Mr. Kevin Brown, who communicated with me. I am Dr. Dipti Majumdar, senior scientist in uh, with Defense R&D of Indian government, and I'm working for over 3 decades in the area of military ergonomics. So we are trying to find out the methods and improvisations to make soldiers' life a bit easier, at the same time making them retaining their combat fitness and enhancing their performance. So in this regards, I feel I'm one of the odd people out over there, because in defense, we always deal with the healthy soldiers. There is no place in armed forces for functionally challenged people. But actually, my interest, especially the academic interest and my interest in human biomechanics, made me think beyond this daily routine which we do. So, uh, as you can see, what I'm trying to tell here is about how we can use 3D gait analysis in physiotherapy. You can see this is actually the overview of the talk which I'm going to present here. That is physiotherapy, physical rehabilitation, and sports medicine. These are the main fields considered in this conference. So they always come into play when the human functionality is compromised. There is some pathology or there is some injury. So as per the, what do you call this, as per the theme of this conference, it is innovative physical therapy and rehabilitation approaches for better healthy living in modern era. So in doing this, while we are thinking about the human functionality that is compromised, the pathology, the injury, what we are considering the physiological function and biomechanics of the human body. So by measuring those parameters, we are measuring the outcome of the improvisation or the intervention. So exactly how we are measuring the outcomes? By evaluating the existing condition, giving the physiotherapy protocol, using the remedial measures. So I would suggest clinical gait analysis in today's world is a very important tool for outcome measures in such cases, whether it is 2D or 3D. So as I said, I'm an ergonomist, so I always look at everything through ergonomics viewpoint. So when we say about anthropometry, physiology, psychology, and engineering, when all these areas are balanced, we find that there is always improved work methods. By applying this, we can increase the efficiency. We have better tools, which causes less fatigue, fewer errors, less rework, and increased productivity. But this is what we want to happen. But this doesn't happen always. The incidents occur, whether it is occupational, whether it is leisure, and accidents occur like this. And you can see that when there is accident, what happens? We have to think about different issues which are involved in this. So why we think about the study of biomechanics? Because when there is an injury, when there is some loss of function, so we have to think how the biomechanics of the individual is compromised and where is the problem. So you can see here these postures. If a person is not having accident, even then, if he continues with these postures, he will definitely have biomechanical problems. Different joints will really react adversely. You can see the work postures. These are the postures normally we use in different occupations. So far, the outcome measures are done, whatever I have understood, because I am not a physiotherapist, neither I am a physical therapist. So I whatever I have gathered, it is through recording, through discussion, through observation. But in doing so, we sometimes miss different issues which are connected with the depth perception. And that is where the third dimension comes into being. So we apply 3D motion analysis in different, you can say in different spheres wherever these injuries are pertaining. So motion measurement can be done in this way, where the markers are put on the anatomical joints, and different softwares, they use the data to predict the motion scenario. So when we think about this, not being a physical therapist or not being a physiotherapist, I had no idea about how these movements are normally measured and how these movements are analyzed for giving physiotherapeutic interventions. But once what happened, one flight lieutenant Randhawa was sent to us. The person was a active flyer. He used to fly those combat aircrafts, and during such an exercise, he got injured. There was an accident, and he had to undergo hip replacement. So I will give the example using a case study, a couple of case studies. So this is the first case study, where Flight Lieutenant B.S. Randhawa, he was sent to us because, as I said earlier, armed forces does not entertain a person who will not have complete functionality. If he has lost functionality, he is out. But because of his past record, he was sent to us so that we could say something, whether he has, after the operation, after his hip replacement, whether he has recovered completely, and whether he could be again put into service. So we did the study. We did the clinical gait analysis. Actually, we do not do the clinical gait analysis. We do the biomechanics gait analysis, where we are not interpreting in terms of clinician, but as a researcher, we interpreted. And you can see the gait cycles were taken, and his different joints were analyzed. And you can see, I would just rush a little so that we can come to it. Then the vertical ground reaction forces, how they affected. So all these values, you can see his sway, the left and right. So as we did not have his original, you can say the data before his accident, so we could not compare it to that. But we compared to the normative data, and we found that he had reasonably recovered from the injury. So he was asked to continue with his different activities which he was undertaking, and after a few months he was taken back and he continued with it. So here we felt the requirement of having a person's normal gait, which is very important, because here we have to compare with the normative data. So next case study which I am going to speak about is about a lady who was actually an office lady, office goer, and she had normal daily routine like doing household chores, then coming to office and going back. In doing so, she got an injury. So this case study came to us, and already she had been given the intervention. So out of the academic interest, we did the gait analysis on this lady, and we repeated it twice. She was using the orthosis, and we repeated it first in 2016 and then 2017. So the case history, as you can see here, she had a corrective surgery. So how the surgery and the orthosis was working, that we wanted to follow, that we wanted to evaluate. Her values, whatever we got, the angle weight changes, everything was compared barefoot and with orthosis. And you can see here the hip joint angle. This hip joint angle in barefoot is so different than the hip joint when she is wearing the orthosis, which is with orthosis, it is coming very much near to the normal. Then similarly, ankle, knee, all those you can see with orthosis, it is coming near to the normal normative data. And that's why we can say that this is a very important issue, that just recording and just not the observational outcome measurement should be appreciated. It would be very widely appreciated if this gait analysis is done for each and every patient which a physiotherapist or physical therapist comes across. So this is my humble request, that this area should be very much investigated and should be used as a routine, not as just one of the things, but it should be used as a routine so that we can quantify the improvement. So that then only you can say that certain movements are making this improvisation better. So that can be used more. So I would suggest that this is taken as a important outcome measure protocol. And so if this is taken as an important issue further, so I would say every ending is really just a new beginning. And here we make a beginning for another improvised therapeutic interventions for physiotherapy. Thank you.
From Dr. Deepti Majumdar If you have any questions related to this topic, just you can raise your hand. You can ask the questions directly.
Pardon?
I am asking the audience, madam, if they have any kind of questions related to your topic.
Yeah. So I need to reply that, no?
Yes.
So let me see what are the questions.
If you are unable to type here, just you can mail us. We'll be asking behalf of you. We'll be sending this query to Dr.
Yeah, I
Dipti.
cannot find the queries here.
So this means there is no questions, madam.
Okay. So anyone wants to ask anything, then
Yes, we got a query from Dr. Tia. What is the program you using for 3D?
what?
You can see from chat box, madam. You can see the question from
It is there in the chat box, but in the
Yes.
chat box I could not find. Acha, acha, acha. Okay. We are using the Motion Analysis Corporation's Raptor Hawk cameras. Setup. We are having this 6 camera setup and Cortex 5.3 and OrthoTrack software. Yeah.
I think Dr. Tia also understood the answer. Any more questions? Any more questions to Dr. Dipti? Yes. Thank you so much, madam, for joining this online presentation. We'll be grateful to you, and we'll be sending the participation certificate with soft copy as well as booklet within a couple of days.
Thank you so much.
Thank you so much for joining. Uh, Next speaker will go with Dr. Neelam Tejani from Dr. D.Y. Patel College of Physiotherapy from Pune, India. The title of the talk will be Correlations between hand grip strength and discomfort in the continuation of bike riders. Yes. We asked Dr. Deep. Yes, madam. You can go ahead.
Hello, sir.
Yes, madam.
Is my screen visible?
Yes. You can enlarge. You can enlarge.
Yeah. Okay.
It's fine, madam.
My topic is correlation between hand grip strength and discomfort in continual bike riders. Now, what do you mean by continual bike riders? As we see in India, there are people who are mostly traveling with the bikes, and it's for 4 hours minimum. And those who are early drivers, we have targeted the early drivers who are coming to colleges, and you can say who are going for work only on the bike. Now, the two-wheelers are one of the most popular modes of urban transportation, and their popularity has grown significantly in last 10 years. Motorcycles are unstable, requires proper driving skills and control the vehicle. Now, here in India, or we can say while we are riding motorcycles, there is exposure to environment outside, roads are not proper, noises are there, vibration on your hands. So we have to cope up with all these factors and then we have to drive. Now, research on human factors which can affect us while riding is very limited. Only if you see, then we can see spine can be affected. But what about your hands? Because maximum controlling of your gear, of your brakes is done by your hands. Fatigue is greatest when riding with the bare hands, as we don't use gloves more, and poor road condition can cause a great fatigue for your hand muscles. Various hand muscles, the writer's palm, fingers, wrist, forearm may experience muscle fatigue. So our aim of study was to analyze hand grip strength and discomfort in continual bike riding. Now to correlate height grip strength, discomfort score in continual bike riding population, objectives were to assess cylindrical grip strength, pinch grip strength, and discomfort score in bike riding population. Now, materials and methodology. Study design was analytical study. Study setting was done in Dr. College of Physiotherapy, Pimpri, Pune. Target population, bike riding individuals. Now, sampling method is convenient and sample size was 85. Which bike riding people we took? Which population? The bike riders who who are riding bike for 2 to 4 hours for at least 5 to 6 days. And their age should be 18 to 24 because we took early bike riders so that we didn't have any other complication with it. If you see bike riders who are later in the state, they have another back problems and that also can cause issues. So we took early bike riders and two-wheelers only bikes. As in India, we have mopeds and bikes, we only took the bikes. Exclusion, any fractures, pathological conditions or any genetic conditions. Outcome measures which were used are Jamar dynamometer, Jamar pinch gauge dynamometer for pinch grip strength, and Cornell University's hand discomfort questionnaire were taken into consideration. Now, individuals were screened filling the inclusion criteria while participation and exclusion was seen and then consent was given. Then the discomfort score was taken by Coronal hand discomfort questionnaire. Respondents were asked to mark the discomfort they feel from 0, which is none, to 4, which was daily. And the discomfort severity was taken to 1 to 3. 1 is slightly uncomfortable and 3 is extremely uncomfortable, while 2 being the moderate. For cylindrical hand grip strength, the participant was asked to sit in proper position in the chair with back supported. Arm should be, shoulder should be in neutral position, forearm 90-degree flex and mid-roll position. Wrist should be at the end of the chair, so thumb is facing the upwards and hand in neutral position. Now this, we should ensure that dynamometer is at 0. And for pinch grip strength, measurement was done pulp pinch, that is tip to tip for 4 fingers, starting position sitting on the chair, same neutral with shoulders, elbow flex 90 degrees, palm facing downwards while pinching the gauge. Now results which showed that our mean age we took were 21.88. In this, you can see over here the dominance of right hand was more as compared to the left handers. Now here, this is the discomfort area. The maximum discomfort which we saw was in F right. Now, as I want to show you one F right here, around this area. Yeah, followed by F left and 40 D right. Now the correlation between power grip and discomfort were the most correlation which we found was B left area, followed by C left and followed by E left and A left. Whereas we can see pinch grip index, that is area left, area A right, and so on. The most correlation which we found for pinch grip was area A left and inversely with B right and D left. These are the same pinch grip strength for the middle finger. It is 0.128 followed by B right in inversely proportional. Now here you can see pinch grip strength for ring finger. In ring finger we found the, you can say not correlated because it's 0.08 in area A left and 0.06 in B left. Everything was inversely proportional where area F left was minus 0.16. Now pinch grip strength with little finger discomfort we found is area E right with maximum 0.32. So area E right was the maximum discomfort which we got around the correlation. Now discussion. Unfortunately, the increase of usage of two-wheeler has led to automotive accidents. It can be because of fatigue. Operating two-wheeler vehicle involves various hand movements and gestures, which can lead to muscle fatigue, discomfort in the palm, fingers, wrist, and forearm. Previous researches has highlighted the relation between muscle fatigue, discomfort, strength, and activities requiring the use of hands. Assessing grip strength and endurance has been found valuable screening in occupational injuries. As you can see that early bikers go for the colleges or you can say job with the bike. So we have to find out what is the injury and how they are getting fatigue, because maximum activities which are done at the workplace or in the college is done by our hands. It is important to examine circumstances and variation in hand strength during riding and understand the association between musculoskeletal. Motorcycle riding posture is significantly influenced factors by riders' physical attributes, that is anthropometric measurements. Now, if we see if riders' handle is very small, then whatever the strengths which are applying forces applied by our hand is very minimal, is very maximum. And when the area is large, the contact area becomes large, our force are not that much acting in the handle. Upon analyzing the data using corneal hand discomfort questionnaire, result indicated that area E was affected in power grip and which was correlated, followed by area B, which you can see here, and area C with the pinch grip values. A study conducted by the researchers, distribution of hand grip pressure in electromyography, they showed that maximum which pressure was there, it was during on the finger flexors. The findings showed that during static grip pressure, there was concentration of high contact pressure and finger grips index in middle fingers, as well as the base of the thumb, which was seen in our study as well. This result suggests that there can be fatigue of opponent's pollicis, adductor pollicis in dominant hand, and flexor digitorum profundus and flexor digitorum superficialis, along with flexor pollicis longus in non-dominant hand. So on basis of this, we can conclude that there is correlation between pinch grip strength and discomfort along the area of opponent's pollicis and adductor pollicis in dominant hand. These are my references. Thank you.
Yes.
Any questions?
Yes. Any questions? If you have any kind of questions, you can text in.
Yeah,
Yes.
I opened our mailbox, chat box. If anyone has the question, they can send.
I think there is no questions, madam.
Okay, sir.
Yes.
Thank you. Thank you for giving me such opportunity for presentation.
And you'll be getting the participation certificate with as well as the electronic booklet within a couple of days. And you're
Okay.
published after 2 to 3 months of the Congress.
Okay, sir.
And
Thank you.
and we have the same event in Dubai, madam. If you're willing to join in person face-to-face meeting, you can join. Conference is going to happen on December 4th and 5th this year. Yesterday,
Okay, sir. Definitely, I will look into it. Sir.
Yes, yesterday we have successfully completed face-to-face meeting. We'll be sharing.
Yes, sir.
We'll be sharing all the photos officially through website. You can go through it.
Yeah, definitely, sir. I will look into your website and I will let you know.
Yes, thank you so much, madam.
Thank you, sir.
Yes. Next speaker is Dr. Kiran Kamble from PS Modern College of Physiotherapy from Pune, India. The title of the talk will be the study of preferred choice of color among typical and atypical children. So we request Dr. Kiran Kamble to start presentation by sharing slides. Yes,
Hello.
madam. Yes, madam.
Yes, sir. Am I audible?
Yes.
Yeah, my screen is visible, sir.
No, not yet, madam.
Yeah, now?
No.
Yeah, actually, I have shared this.
If you are unable to share the screen, just you can immediately send us your PPT through WhatsApp, madam. I can share from here.
Sorry, sir.
If you are unable to share the screen, you can share your PPT to us. In bottom of the screen, you can find the with green color share screen option. You can share from there.
Hello.
Yes, madam.
Yes, sir. Actually, I am not able to share my screen.
So do one thing, madam. Do you have our WhatsApp number?
WhatsApp number of Kevin Brown.
Yes. You can.
Yeah, I have.
Yes, you can share your PPT immediately to that email, that WhatsApp number or email ID, so that we can send. We can share from here.
Okay, sir. I'll just share it on WhatsApp.
Yes. So just now, yes, just now I kept in chat box.
I'll just try one.
Yes, no problem. In bottom of the screen, you can find it with green color.
Sir, is it visible?
No, no, madam.
No.
Shall we go with alternate speaker? Meanwhile, you can ready with your PPT.
Sorry, sir.
Shall we go with alternate speaker? Meanwhile, after one speaker, next.
Yeah. After one more speaker, I'll try to adjust or I'll send it to you.
Yes,
Is it
it's
okay?
better.
Okay, sir. Okay. Thank you, sir.
Yes, yes. Next, we asked Dr. Shalaka Bhatia from Faculty of Physiotherapy and Rehabilitation from Assam, Downtown University from India. So actually, we are 10 minutes forward to actual timings, madam. You can adjust the timings. The title will be the effectiveness of rehabilitation on head and neck cancer patent, a literature review. You can start sharing your slide, madam. Yes.
Very good morning to everyone present here in today's conference. Thank you so much for giving me this opportunity to present a topic which is, I would say, which is the need of the hour to know, because depending upon the prevalence rate of head and neck cancer, also I thought that this particular topic is also one of the topic in which I am doing my PhD on, that is head and neck cancer patients. So I thought it would be a platform where I can put forward the available rehabilitation methods which we can approach whenever we have a case of head and neck cancer patients. Thank you so much. In a moment, I'll be sharing my screen. Thank you. Is my screen visible, sir?
Yes, madam. Just a little bit, you can somewhat enlarge. Little bit.
Okay. Yes, sir, I'm doing it.
It's fine.
Okay, thank you so much, sir. Okay, so the topic for today's talk, which I will be keeping forward, is the effectiveness of rehabilitation on head and neck cancer patient literature review. So head and neck squamous cell carcinomas, they are available from the mucosal epithelium in the oral cavity, pharynx, and larynx. And these are the most commonest problems or malignancies that begin in the head and neck. As we all know that cancers are a major worldwide public health problem, and it has an incidence rate of around 350 to 500 per 100,000 patients. In contrast, if I have to put forward the rate of India, it is much lower, estimated at around 100 to 10,000 or 1 lakh. So head and neck cancer patients are the most frequent cancers available in India and globally. And it is also the 6th most common cancer. As we all know, smoking tobacco, consuming other tobacco-related products, and alcohol are the known most causative agent for head and neck cancers. The immense majority are the squamous cell carcinomas, and these diseases are usually seen in the pharynx, oral cavity, hypopharynx, or larynx. So we all know the basic treatment for head and neck cancer is usually surgery followed by radiation therapy. As well, the definitive restricted mouth opening because of cancer has also an impact on the quality of life, because it hampers the eating, the oral hygiene, talking, and other social interactions which are being compromised at a greater level. So the most commonest symptoms or the most commonest available treatments would be chemotherapy, surgery, and radiations. Now, the most useful instrument or outcome measure which is useful for understanding the quality of life of head and neck cancer patients, according to International Conference on Quality of Life held in Virginia, USA in October 2002, are as follows. They are the Functional Assessment of Cancer Therapy Quality of Life Measurement System, the University of Washington Quality of Life Questionnaire, and the European Organization for Research and Treatment of Cancer Quality of Life Questionnaire. Along with that, you also have the European Organization for Research and Treatment of Cancer Quality of Life in Head and Neck Cancer module. So these are the available questionnaires which can direct us about the quality of life. As we all know, whenever we are dealing with a patient who is a cancer patient, irrespective of the site, one aspect which we often try to overlook is the quality of life. As a rehabilitation specialist or as a movement scientist, we play a very important role in resuming or presuming the quality of life of those patients. After the quality of life, one most important point is the follow-up. And follow-up is a standard method in which we usually follow after any kind of surgery or radiation or chemotherapy. The main aim of the follow-ups is to identify what are the possible reappearances of any problem or what is the prognosis of the treatment as well. Head and neck lymphedema, that an outcome from any therapies, is used in the treatment of head and neck cancer, okay, especially when we know whether there is any kind of heaviness or tightness and there is present of any permanent distress in the affected areas. So we play a very important role in the examining and managing these side effects which are coming from the treatment as well as from the incidence of the disease. Along with that, we also have to focus on the strength-based exercises and or range of your movement, then your strength, movement, and range of motion of various joints needs to also be acknowledged. The post-treatment period is normally characterized by slow recovery and improvement, but the main focus should be on the rehabilitation interventions, okay? And these evidence suggests that the interventions needs to be safe, feasible, cost-effective, and also needs to focus on the quality of life. Along with that, the general conditioning such as swallowing, muscle function, insomnia, pain, weakness, loss of appetite, shortness of breath, all these criteria needs to be fulfilled by the intervention. Rehabilitation helps in preventing or reducing the loss of function, increase the patient's quality of life so that he or she can be independent rather than dependent on the fellow members. There are various clinical training interventions such as rehabilitation centers, physiotherapy sessions which are available, which takes these concerns into action. So there are very limited evidences. There are very limited evidences to support the use of any kind of electrical stimulation for the treatment of dysphagia in any kind of head and neck cancer patients. Many patients also have a problem of saliva production due to the carcinoma. So principles of any kind of acupuncture also helps in reducing xerostomia in patients, and it also helps in providing long-lasting results. Neuromuscular plasticity from the field of physical rehabilitation, exercise science, and sports training are associated in helping the muscles of mastication and swallowing. So an exercise regime which includes all these various aspects under programming into a single umbrella helps in understanding the need and the desire of the intervention. Along with that, you also have a myofascial trigger point techniques, which helps in reducing any kind of fibrosis related dysphagia in the head and neck cancer patients. and increasing the benefit of myofascial trigger point. Along with that, there are also studies which shows that manual lymphatic drainage helps in increasing the range of motion and also helps in improving the lymphatic circulation. MET, also known as muscle energy technique, and myofascial release have also been useful in reducing pain and hence improving the quality of life. So the various exercises which we can sum up in the rehabilitation procedure of head and neck cancer patients are the various range of motion exercises, range of motion of our jaw muscles, our range of motion exercises of our tongue muscles, your laryngeal muscles range of exercises, your falsetto voice exercise helps in improving the range of motion of laryngeal motion. Mendelssohn is also a maneuver which helps in increasing the ability of laryngeal elevation and thus increasing the duration of your circopharyngeal opening. Then also we have the shaker exercise for higher laryngeal range of motion, which helps, is also known as the shaker exercise, which helps for making your hypolaryngeal complex in a less complex position. Next, you have the NMES, which is being used for stimulating your pharyngeal dysphagia patients, for stimulating your neck muscles. Then you have the laryngeal closure exercises. Then you have the tongue resistance or the resisting exercises for those muscles who have decrease in the muscle strength of the tongue muscles. Then you have tactile or thermal stimulation, which can be stimulated around your oral cavity where you have a shallow reflex of the tongue. And next, you have the intraoral prosthetics, which can help. These particular prosthetics are being developed by maxillofacial prosthodontist with input from the surgeon and speech pathologist for patients who are expected to undergo surgical resections in the oral cavity. So there are various varieties are there depending upon the need and the tailor-made based upon the swelling and the dysphagia. So based on all the available rehabilitation which we have for head and neck cancer patients, the present study which we had conducted shows that the various evidences have shown that various range of motion exercises, strengthening, NMES, tactile or thermal stimulation can be inclusively used in rehabilitation, but definitely with precaution, and also keeping in mind the advanced techniques such as MET, MFR can also be included in the rehabilitation of head and neck cancer patients. Thank you. Along with that, I would just like to add one point. A very crucial point which we try to miss is that in head and neck cancer patients, one of the most important part is also the sensory issues. That is the sensory processing issues which we try to overlook during our rehabilitation. As you have seen in the literature review which I have presented, nowhere did I mention anything about the cognitive issues or anything about the sensory processing issues. So when I say a rehabilitation method needs to be inclusive, I also mean to say that you also have to include the sensory issues as well in the rehabilitation when we have to improve the quality of life of the patient. So thank you so much for giving me this opportunity once again to present a talk on head and neck cancer patients and a literature review on that. Thank you so much, sir.
Yes. So this was a presentation from Dr. Neelam Tejani. Sorry, Dr. Shalaka Bhatta. Any questions to Dr. Shalaka? Just if you have any kind of questions, you can raise your hand or you can text in what's this chat box. Will be asking behalf of you. Even after the completion of the Congress, you can text us or you can mail us the questions you are having.
Okay, if there is any question, definitely I'm here to answer. Definitely.
Yes, madam. If we are getting any kind of questions related to your topic, definitely we'll forward to you.
Okay, definitely.
Yes. Thank you so much, madam, for joining this event. And you'll be getting the participation certificate as well, booklet within a couple of days. And we request to join in person, particularly for the upcoming years. if everything goes.
Definitely, sir. Definitely, I'll do that. Thank you so much.
Yesterday we have done more than 30 talks from face to face from different parts of the world. We'll be sharing all the photos after the completion of the conference. Hope you can go with either Europe or you can go with Dubai next year. We are having the conference. You can
Okay.
choose according to your budget. We'll be helping in all the way.
Okay. Thank you so much, sir. Thank you. I'll
Thank you
definitely
so
look
much,
into
madam.
it.
Have a nice day.
Thank you, sir. You too.
Next, we will ask Dr. Kiran Kamble will be playing behalf of Dr.
Hello.
Yes, we'll be playing behalf of you.
Yes, sir. Yes, sir.
So kindly note, madam, after completion of every slide, just to mention the slide change, I will share it from here.
Yeah. Yes, sir. Hello.
Yes, you can go ahead.
Okay. Should I start?
Yes.
Okay. So this is Dr. Kiran Kamble, Assistant Professor from PS Modern College of Physiotherapy, Pune, India. So my topic is the preferred choice of color in typical and atypical children. As you all know, typical children react to some other color as of their choice or as of their preference. But to which color atypical children react, that we need to know, and how they react. So color is one of the first concepts that we learn and we use to convey emotion, message, and meanings. And some researchers have already proven that some other individuals are more sensitive to color. So typical children of age group 2 to 4 years react to bright color and prefer to play with the toys of brighter color. As color is powerful design element that produce psychological reactions, there is strong relationship between color preference and performance in learning environment, as the color induces concentration and the learning abilities in the children. So researchers have investigated color preference of typically developing children. Some evidences suggest that atypical children perceive color differently in comparison with typically developing children. So there is difference between both the groups, typical as well as atypical. The difference that was the need for this study. So there is difference in color obsession in both typical and atypical children. Moving on to the next slide. So vision development and color perception. It is different in atypical children as compared to the typical children. While some atypical children are more sensitive to color due to increased sensory response, strong visual processing abilities. And atypical children prefer to use color sorting tasks rather than any other sorting task. And that can improve concentration and learning abilities in atypical children. Next. So, need for the study. Typical children differentiate color at the age of 2 years and react to the bright color choice. It is necessary to know which color the atypical children react first for the color preference, as color is the strongest stimulation for learning, behavior, and concentration. Hence, current study was conducted to find whether typical and atypical children react to the same color or to the different color. Next, so the aim of the study, it was to study the preferred choice of color in typical and atypical children. Objectives were to study the preferred choice of color in typical children, and the second objective was to study the preferred choice of color in atypical children. Yes, next. So moving on to the materials and the methodology. Type of study was analytical study. Sampling method was convenient sampling, and sample size was 60. Place of study was Krishna Hospital, Karaj. Next. Okay, the criteria for the selection was children of age group 2 to 6 years were selected. Atypical children and typical, both the children were included. Children with normal or corrected to the normal vision were included in the study. Children with recent head injury, children with other intellectual disabilities, children who have undergone recent surgery were excluded from this study. Next. So total 60 number of participants were included in the study. All the participants who were included were screened as per the inclusion and exclusion criteria. Informed consent was taken from each of the parents of the participant. Next. So 5 square shot cardboard colored yellow, red, green, and blue were taken for this study. Participants were tested for the study in quiet rooms with a full daylight. All colored cardboard squares are presented to the participants seated on the ground and asked to pick one of he or she liked, and the preference was noted for each participant. Next. So result was, so for the gender distribution, total among 60 subjects, there were 20 male and 10 female subjects were participated in a typical group, while in the typical group, 16 male and 14 female subjects were there for the typical group. Next. So this was the data to which typical male and atypical male reacted. So for the red color, from the typical group, 10 male were reacted. For yellow, 4, green, 4, blue, 2, and for the brown, only 1 child reacted. From the atypical male group, 1 child reacted for the red color, 8 reacted for the yellow, 3 reacted for green color, 3 reacted for blue, and 2 children reacted for the brown color. And this is the data for the atypical and typical male. Moving on to the next. So we have another chart for typical female and atypical female group. So from typical female group, 4 children reacted for the red, 2 reacted for the yellow, 3 reacted for green, 1 reacted for blue, and 0. No other child reacted for the brown color from the typical female group. So from a typical female group, 1 child reacted for the red, 7 reacted for the yellow, 2 reacted for the green, 2 reacted for blue, and 2 reacted for the brown. Yes, moving on to the next slide. So this is the chart combined for the atypical male, typical male, atypical female, typical female group. So among all the subjects, 60 subjects, total 16 subjects reacted for the red color from both the groups. So 3.3 male and 3.3 female of atypical group, while 33.3 male and 13.3 female of typical group reacted for the red color. Next. So for the green color, total 12 subjects reacted for the green color among 60 from both the groups. For blue color, total 6 subjects reacted for the blue color from both the groups. So among those, 10% from the atypical group, male 10% reacted for the blue color, 6.6 female from the atypical reacted for this color, 6.6% male and 3.3% female of typical group reacted for the blue color. In all, 6 subjects were there reacted for the blue color. Next. For yellow color, total 21 subjects reacted to the yellow color from both the groups. So from a typical group, 26.6% male, 23.3% female reacted for this color, yellow color, while 13.3 male and 6.6% female reacted from the typical group. So for brown color, total 5 subjects reacted to brown color from both the groups. Next. So moving on to the discussion. So there is marked difference in color preference of both the groups, at atypical as well as typical. So among all the 5 colors, yellow and the red color relatively held high preference in atypical and typical group. So all the children have emotional association with colors and have positive emotional reactions for brighter colors. Next. Atypical children were less accurate than typical developing children in differentiating colors. So this result will enhance the recovery as color has facilitation effect on atypical children. Use of preferred choice of color as a stimulus among atypical and typical children will improve the concentration, learning, and the behavior. So the result was red. Typical children reacted for the red color, while the atypical children reacted for the yellow color. Not all the typical and atypical, but majority of typical reacted for red, majority of atypical reacted for the yellow color. Next. Conclusion. So atypical and typical children reacted to the different colors. 70% of atypical children preferred yellow color as a color of choice, first preference, while 53.3 typical children preferred red color, while brown was the least preferred color. And as of giving ranking for each of the colors, yellow held first preference, red was the second, green third, blue was the fourth, and the least preferred color was brown. So the conclusion is both this group of children react to the brighter colors, but the color preference was different for both of the groups. Next. These are my references. Thank you.
Yes.
Any questions?
Any questions? Any questions related to this topic?
Yes.
Yes, we got a query from Dr.
Question, yeah.
Just you can read, madam. It was nice presentation. Having thought of quantifying the cognitive performance in terms of eye movement parameters.
Okay, I haven't included that thing. Yeah. So this cognitive kind of thing didn't included in my study. So I just worked on the color preference for both the groups. So it was just regarding to which color typical and typical children reacted, not in terms of eye movement.
Yes.
Any other question?
If you have any kind of questions, you can text directly. Chat box will be asking behalf of you.
Hello.
Yes, madam.
Any other question?
Yes. No more questions, madam. So
Okay.
we'll be sending you the participation certificate as well along with the booklet within a couple of days after the conclusion of the Congress, madam. Thank you so much once again for joining this event. Hope we expect next year or by end of this year in December 1st, we'll be having face-to-face meeting in Dubai. If you are willing, you can submit your abstract.
Yes, sir, definitely. Yes, sir. Thank you, sir, and thank you for this connectivity glitch. And
yes, thank you so much, madam. Thank you so much. Next, we ask Dr. Pratibha Gaikwad from Lokmanya Tilak Municipal General Hospital from Mumbai, India.
Yes, sir. Am I audible?
Yes, madam.
I'll share this screen.
Yes. The title of the topic will be comparative study of aerobic exercise versus relaxation therapy on anxiety and depression in asthmatic children.
Is my screen visible, sir?
Yes, madam. Just you can enlarge it little bit.
Okay. Is it? Hello?
Yes, madam. You can go to slide share, madam. Slideshow. Just you can show. From the beginning.
Is it visible now?
Yes, ma'am.
Okay. Good morning, everyone. I'm Mrs. Pratibha Gaikwad, working as Associate Professor from Lokmanya Tilak Municipal College, General Hospital, Mumbai, India. I would like to thank the Scientific Committee of it International Conference occurring at Paris for giving me opportunity to present my paper. The title of my paper is Comparative Study of Aerobic Exercises versus Relaxation Therapy on Anxiety and Depression in Asthmatic Children. As per WHO, asthma is a major non-communicable disease affecting both children and adults and is the most common disease among the children. It is often undiagnosed and untreated predominantly in low and middle income countries, and it has the impacts on quality of life. The prevalence of asthma among children in India is varied from 2 to 18.2%. As it is stated by Dr. Roy and Praveen that it is in urban area 7.9, rural area it is 6.8, and mixed area it is 7.6. As you all know, the asthma is an inflammatory disease that is characterized by airway obstruction and may cause episode of wheezing, coughing, and difficulty breathing. Difficulty in breathing, acute pain in the chest, and shortness of breath may affect their quality of life. This difficulty in performing regular daily activities also affect their psychosocial function. Almost 1/3 of all children with asthma meet the criteria for comorbid anxiety disorder, indicating that stress should be viewed as both trigger and consequences of this chronic disease. A study done by BMR found that asthmatic children had low self-esteem, social isolation, anxiety, depression compared to those with other chronic disorders. Studies have also stressed the negative impact of anxiety on the quality of life in asthma patients. Am I audible, sir? Hello? Hello?
Yes, madam, go ahead.
I'm what? Okay, I'll just proceed. These are the review of literature says that the prevalence of anxiety varies from 8.5% to 22.5%. And the depression is varies from 9% to 45%. So unable to attend the school, unable to play, and they prefer the indoor games. This gives an anxiety and depression with the asthmatic school. So it is a vicious cycle. Asthma can cause shortness of breath. It can cause decreased ADL activity, decreased inability to participate in the sports activity that can cause a social isolation, and this induces the anxiety and depression in the asthmatic patient. Asthma and anxiety together worsens their symptoms. So it is a need to address this psychosocial dysfunction in early phase of pulmonary rehab program. What are the common approaches to reduce anxiety and depression? There are a number of studies have given trial by using different relaxation therapy, which includes yoga, pranayama, guided imaginary, and relaxed breathing. These techniques improve psychological function but does not improve the exercise capacity. Most of these studies are performed in adults and very few in children. Hence, the need of studies that the aerobic exercises is the most effective part of pulmonary rehabilitation program. These programs have been proven to increase functional capacity, decrease symptoms, decrease dyspnea, and finally improve the quality of life. Both American College of Sports Medicine and American Thoracic Society guidelines recommend exercise for patients with asthma. So group aerobic exercises, group aerobics in dance style definitely plays a very important role to reduce the psychosocial function. The Jackie Sosin is the first founder member who has formulated aerobic exercises in dance form, in which she choreographed the dance steps and fully body movements along with the music. Asthmatic patient needs a structured exercise program which will increase their functional capacity as well as to reduce their anxiety and depression. As there is a lack of good quality evidence to assess the efficacy of aerobic training in the management of psychosocial function in asthmatic children, we thought it would be interesting to see the effects of aerobic training on psychosocial function. So we formulate the question that is there being any differences on psychosocial function with aerobic exercises versus relaxation therapy? These are my null hypotheses that there is no statistical significant difference on psychosocial function with aerobic exercises versus relaxation therapy in asthmatic children age 8 to 11 years. An alternative hypothesis can be there is a statistical significance between aerobic and relaxation. So aim is to study the 8 weeks of aerobic training versus relaxation therapy on anxiety and depression in asthmatic children age 8 to 11 years. These are my objectives: to assess the effect of pre and post 8 weeks of conventional breathing exercises on anxiety depression by using revised children anxiety depression scale. Objective 2 is to assess the effects of aerobic exercises to reduce the anxiety depression in asthmatic children. And group C is to assess the effect of Jacobson relaxation technique on anxiety depression by using revised children anxiety scale. This is my outcome measure. The RCAD is a self-report questionnaire with scales corresponding to the diagnostic and Statistical Manual of Mental Disorder Diagnostic Criteria for Anxiety and Depressive Disorder. It has been shown to be a reliable and valid instrument in the general population as well as school-based sample. The revised Child Anxiety Depression Scale is a 47-item self-repeat questionnaire with a subscale having separation anxiety disorder, social phobia, generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and major depressive disorder. It gives a total anxiety score as well as the anxiety and depression score. Items related on 4-point Likert scale from 0 to 3. This was a prospective comparative study. Convenient sampling is done. And the study conducted in physiotherapy department at tertiary healthcare hospital. Total sample size was 45, 15 each group as it is a pilot study. And total duration was 1 year. These are my inclusion criteria. We selected the children between the age group of 8 to 11 years from both the group gender. Children with mild to moderate asthma according to GINA guidelines. Children under the stable phase of disease without any recent disease exacerbation. These are the exclusion criteria. We excluded the children which are having a congenital musculoskeletal, neuromuscular, cardiopulmonary, and musculoskeletal disorder. Approval from the Departmental Review Board, Institutional Ethical Committee, and MUHS was sought. The permission was taken from the respective department for a data collection. The patients referred from physiotherapy OPD. The patient referred from pediatric OPD was screened for anxiety depression by using RCAD scale. The children with the score more than 65 included in the study as per inclusion-exclusion criteria. Informed consent taken and demographic data was recorded. A simple randomization by the card taking method was used. A sample divided into 3 groups. Group A, control, aerobic, and relaxation. And the outcome measure were measured at 0 week and at the 8 weeks post-it. These are the 3 different groups. For a group A, we have given the diaphragmatic breathing exercises along with pulsed breathing. The breathing exercise is given for 10 repetitions for 3 cycles along with pulsed breathing. In aerobic exercise training program, we have given a 5 dance steps. And in Jacobson relaxation technique is given starting from toe to head, in which we have asked them to hold the contraction for about 8 seconds and relax the muscle group about 30 seconds. These are the fast 5 dance steps program given for the kids to improve their aerobic capacity. The results and tables. The data analysis was done using SPSS software version 26. Intergroup analysis of RCAD score, pre and post intervention was done by Wilcoxon sign rank test. The intergroup analysis of RCAD score was done by Kruskal Wallis test. In the entire study, the p-value less than 0.5 is considered to be statistically significant. Table 1 shows that there are equal number of male and female patients in all 3 groups. This is the graph showing that mean age group between all the 3 groups. This is the group A. Group A shows that anxiety score was pre-intervention 72 and it has gone lower down to 62 after intervention. This is true with the depression score also. Pre-intervention it was 74 and post-intervention it has gone to 62. As per table 4, Wilcoxon sign rank test was applied to find out the significant effect from pre to post. There was a significant differences in median value of p-value of 0.00 for both anxiety and depression. This indicates that there is a statistical significance in control. Group B, again we have got a significant reduction in anxiety score and depression score with the aerobic training. So there is a statistical significant difference pre and post values in aerobic group also. Group C, again we have got a significant difference between control and relaxation group. The table 7 shows that group C, the median value of RCAD depression score pre-intervention was 75 and post-intervention was 58. As per the Wilcoxon sign rank test, p-value was 0.00, was found to be statistically significant in relaxation group. When we compare these 3 groups, at baseline 3 groups were comparable, which suggests no significant difference in anxiety score with the p-value 0.11, which is less than 0.05, which is more than 0.05. and observed difference is by chance. Post-intervention at 8 weeks, all three groups were significantly different with the p-value 0.01. As per the Kruskal-Wallis test, there was a significant difference between aerobic and relaxation with p-value 0.04. There was a significant difference between control and aerobic with the p-value 0.0. And there was no significant difference between relaxation and control with the p-value 0.98. So our study accepts the alternate hypothesis for anxiety score. Aerobic group shows more number of lowest win ranks, suggesting smaller anxiety score are more in aerobic group compared to relaxation and control. And there was a significant difference between aerobic and relaxation with p-value 0.04. When we compare the depression score along through the three groups, at baseline, three groups were comparable, which suggests no significant difference in depression score, that is 0.49. And post-intervention at 8 weeks, all three groups were significantly different with a p-value 0.00. So this says that there was, when we compare aerobic with relaxation, there was no significant difference with a p-value of 0.08. There was a significant difference with aerobic and control, and there was a significant difference between relaxation and control. So, study accept the null hypothesis for depression score. As we seen, there was no significant difference between aerobic and versus relaxation with p-value 0.08. Discussion. As per table 3 to 8, it is seen that there was a significant effect between pre to post in anxiety and depression score in all three groups, indicating p-value is less than 0.05. Intergroup assessment was done by using Wilcoxon sign rank test. Intergroup comparison for anxiety has shown significant effect between aerobic and relaxation with p-value 0.04. This means intervention by aerobic training has significant effect than relaxation therapy to reduce the anxiety. The reasons could be aerobic training was given in a dance style along with the music. The children enjoyed a lot while performing this activity and felt very happy. This has increased their exercise capacity. Improvement in exercise capacity enables them to perform the ADL as well as recreational activity, which might have led to increased their self-esteem and overall well-being. With increase in overall cardiorespiratory function, musculoskeletal function, patient is able to perform most of his ADL activities at ease and without hesitation. Patient felt safe, independent, and confidence, and hence we see this improvement in the aerobic group as compared to the relaxation. The similar result was found by Pelvic, that he had mentioned in the study that there is a moderate linear relationship between a baseline anxiety and depression score that improve after aerobic training. And similar result got found by Santorna on asthmatic adult promotes that from physical training in the form of circuit training about 45 minutes at the PRE 12 to 14 on the box scale decreases the anxiety. Intergroup comparison for the depression score did not show any significant result between the aerobic versus relaxation. So, this means that aerobic exercises were equally effective as relaxation in reducing depression. Several mechanisms can explain the mood of improvement in our patient. Exercise produces changes in the concentration of several biological active molecules such as adrenocorticotropic hormone, cortisol, opioids, peptides, cytokines, which have been reported to affect mood or involved in the pathophysiology of affective disorder. Moreover, some evidence suggests that exercise can modify the concentration of neuroactive substances in the central nervous system. However, factors such as motivation, expectancy, and human contact could also influence the mood of participants. Physical therapy guided aerobic exercises enhances the feeling of being alive, made them feel that they were doing something good for themselves. The antidepressant effect of exercise are to promote self-esteem, self-perception, self-efficacy, and can enhance the social support to create a buffer system against the depression. Aerobic training brings improvements in the cardiorespiratory function, musculoskeletal function, as I stated earlier, gives an overall well-being for the patients and makes the patient more independent. See, the student kids are happily performing the outdoor activity. To the best of our knowledge, this is the first study evaluating the effects of supervised indoor aerobic dance form program on anxiety depression in asthmatic children. The conclusion, the present study shows that an aerobic training program reduces anxiety depression level in asthmatic children aged 8 to 11 years. Aerobic group showed better result as compared to the relaxation to reduce the anxiety. Aerobic was equally effective to reduce the depression. The clinical implication is that aerobic program should be incorporated in early phase of pulmonary rehabilitation program. The study definitely adds to the literature suggesting that the physical aerobic activity can be routinely used in primary care of asthmatic kids to reduce their anxiety and depression. This improves not only the physical health but the mental health too. Ultimately, this would reduce the health burden of chronic health conditions such as asthma. We should plan a structured treatment protocol in such a manner that children must achieve the highest level of independence. Children with asthma should encourage to engage in sports, lifetime exercises in order to reduce the asthma-related anxiety and depression. These are my limitation and future scopes. These are my references. I would like to express my thanks to my guide, Dr. Bharti Asgaonkar, my HOD, Dr. Chaya Verma, Professor Rajeshri Naik, and all my asthmatic kids who actively participated in my study. I would like to thank the organizing committee of 8th Physiotherapy Conference Paris for allowing me to present my project.
Yes, thank you.
Thank you so much. Thank
you so much, madam. Any questions to Dr. Pratibha? If you have any kind of questions, you can raise your hand or you can text in WhatsApp or through our chat box. We can ask behalf of you.
Any questions, sir?
Yes, sir. Question from Dr. Tia Asalam. Yes, sir. You can go ahead. Oh, sorry. No questions.
No?
As of now.
Okay. Thank you, sir. Thank you so much.
Yes. Thank you so much, madam, for presenting. You'll be getting the participation certificate and electron booklet within a couple of days after the completion of the Congress. Thank you so much, madam. We request you to join in person next year if upcoming days if everything goes well.
Sure, sir. Sure. Thank you so much.
Thank you so much. So next, we ask Dr. Dara Shah from Gujarat University from Ahmedabad from India to start the presentation. Or else we can go with keynote presentation. Dr. Christopher Ambrox from Director of Education Digital from Nancy from France. Sir, if you are in online Zoom meeting, you can start sharing your slide. Actually, we are 40 minutes ahead of actual program.
Yes, I can start with my presentation.
Yes, sir. If you are ready, we can start sharing your slide.
Yeah, sure. Okay, you can see it?
Yes, sir, it's fine.
So I'm going to talk about physiotherapists as health promotion practitioners in primary health care in Riyadh City. First of all, good morning, everybody. My name is Deep Al Salim. I'm talking to you from Saudi Arabia. My presentation is talking about mainly primary health care and how we can add physical therapy to it. Primary health care is the care for all ages, which includes all the people who deserve the right care everywhere, right in their communities. In the health care system of any country, the role of physiotherapist is very important because they ensure that the patient and their families with the physiotherapist are concerned with facilitation of diagnosis, treatment, and the management of 30s of chronic and acute conditions. And this is also useful in the promotion of mobility and its function along with physical activity. A large number of people in the whole world are facing the problem of disability in any form. And approximately 15% of the people from the world population are facing this problem. The disability prevalence is higher in poor countries in terms of resources in comparison with the high income countries. At the global level, the estimation of disability has been increased because of the spread of the population along with the chronic disease, along with the improvement in the methodology that has been used to calculate the disabilities. Physiotherapists are the most important member of the collaborative professional teams because of their scope related to practice. The number of appropriate ways under which the physiotherapist can participate in global health, and they work beyond the patient care in direct way, which also includes the development of the program related to rehabilitation. Primary healthcare is the approach to health that ensures that the objective of the highest possible level of well-being and the level of health, that the primary healthcare is focused on equal distribution of needs and as early as possible, along with the health promotion and disease prevention as far as treatment and rehabilitation are concerned. Primary healthcare is directly related or rooted in the commitment to social justice, solidarity, equity, and participation. It's based on the enjoyment of the standard of health with respect of the highest attainable, because the standard of the health is one of the fundamental rights of all human beings without any distinction. A number of researchers have been found that health service in any country always play an important role in the development of the long-term health system. The willingness to work in the prevention of the disease and the promotion of health has been reported scientifically, and the role of physiotherapists has been playing a key role in assisting and advising the population for the purpose of using activity to keep the population active and healthy. The physiotherapists are always committed to combine the modality approach as far as the treatment of obesity and hypertension are concerned. Physiotherapy play an important role in improving education and advise the maintain of health of the population at all age, preventing disease and help patients to manage their pain. And so these health promotion practitioners are concerned with the development, planning, implementing, and the evaluation of policies related to health promotion. And the policies, with the help of using the variety strategies, health education, and the development of the community and the mass media, it's also concerned with the process of community engagement, the lobbying, advocacy, and the social strategies are also the part of the health promotion practitioners. The evidence to inform the policy related to health promotion and practice is very crucial for the purpose of achieving an outcome of the health. The role of physiotherapist is varied and rarely for 2 days at the same, and on the other hand, the physiotherapist has been assessing the condition of the patient for the purpose of diagnosing treatment plan and diagnosis of the problem. The role of education is scientific in physiotherapy because the physiotherapists have been spending a huge amount of time educating the patient communities to prevent injury and help the people to achieve a healthy lifestyle. Health promotion is the most important element in addressing this issue related to public health. And now this time is a global health condition, not good. As we seem to see, health promotion is political process at the moment and multi-faced social and have been aimed to improve the capability and individual skills. Health promotion is the process of helping the people to have more control as far as the determinant of health in terms of both individually and collectively are concerned with the respect to enhance the health, enhancing the health in general. The physiotherapist is very important in the promotion of healthcare and scientifically in wellness, disability, and disease prevention. The problem statement of this research I worked is the role of physiotherapy as the health promotion practitioner in primary healthcare is not clear, especially in Riyadh City. Riyadh City is the capital city of Saudi Arabia. And this research work was useful to fill the extensive gap in the available literature by providing in one city evidence. Most of the research work has been conducted in the past to best to examine physiotherapists as health promotion practitioners in different regions of the world. A number of research work have been conducted in Saudi Arabia about the role of physiotherapy in the primary healthcare sector in Riyadh. Most of this research work based on secondary data, but this research was working contributing scientifically by using primary data. So the statement of the problem is that the physiotherapy as health promotion practitioner in the primary healthcare is unclear. I want to explain that in the 1978 Alma-Ata Conference and Declaration was a landmark in defining and providing a direction for primary healthcare. Despite the initial enthusiasm for Alma-Ata, its impact appeared to have declined in the 90s. However, in recent years, there has been a revitalization of the primary healthcare. And Alma-Ata Declaration 1978 emerged as a major milestone of the 20th century in the field of public health. And it's identified primary healthcare as the key to the attainment of the goal for health for all. The principal primary healthcare are accessibilities, public participation, health promotion, appropriate technology, and intersectoral cooperation. And so research objective, the research question of this research work are as the follow. What's the role of physiotherapy as a health promotion practitioner in the primary healthcare sector, Riyadh City? What's the important physiotherapist in primary healthcare, Riyadh City? And what are the strategies used by primary healthcare organization and physiotherapists to increase the integration and mitigate the barriers? How can physiotherapists reduce avoidable admission to residential care and the hospital? And the main aim of this research work will be to find the role of physiotherapy as a health promotion practitioner in primary healthcare of Riyadh City. And the objective of achieving this aim are as follows: to determine the role of physiotherapy in health promotion practitioner in primary healthcare, to find the important physiotherapist in primary healthcare in Riyadh City among Riyadh City physiotherapists, to suggest the policy on the base of the findings of this study. And scientifically of this study, the scientific of this study research is that it will contribute scientifically to the available literature on this particular topic. Most of the previous research has worked conducting different researchers in the past and taken single or multiple countries as a shared of evidence. This research work is different from the previous study because of the single city model. This research work will consist only on Riyadh City, and the result of the study was applicable to the physiotherapist in Riyadh City only. A number of research work are available on this issue, but most of them are conducted on the base of secondary data. And so we contribute scientifically toward available literature by using this primary data. So will help us to make a policymaker in the primary healthcare for the Riyadh City, Saudi Arabia, and as far as the physiotherapist as health promotion practitioner are concerned. This research work is clear the picture associated with the role of physiotherapist in healthcare system. It's also finding this study helped to place the public to know that the importance of physiotherapy as a health promotion practitioner. Physiotherapy play a key role in primary healthcare. The role of physiotherapy and health promotion help to maximize the quality of life. Physiotherapists help in the rehabilitation and rehabilitation program because they can motivate the patient to recover faster. Physiotherapists play a key role in maximizing the physical potential and are also concerned with the human function in the primary healthcare sector. Physiotherapy help ensure and care for the patient and the family across the country. This also plays an important role in the management of the treatment of a number of acute chronic conditions, and which gonna promote physical activity and also increase function and mobility. To follow-up program and regular mentoring from the side of physiotherapist help to fight the chronic disease and to maintain physical health. These are the results is one of the results. There is about more than 20 result appears, but this one of the most important result I picked up. This research was working to health promotion and the primary healthcare in Saudi Arabia by taking the evidence of reality. The role of physiotherapist is very important, as we said. It focuses on healthcare improvement in the main concern from the last few years, which based on the primary healthcare data analyzing. We used a Google form method that we distributed as the questionnaires, which used to collect the data from it by the participant. There were more than 362 responding participants in this survey, and the participant rate of the participant in the survey has been changed with the changing in the questions that have been asked from the participant. The number of questions has been asked from the participant of the study, and the question are divided in two major parts, which include demographic variables and a question asking about the diffusion of the information. And the 7 question related top demographic information of the participants are included in the study, while the 24 questions have been included in survey that concern the finding impact of the physical therapist primarily in the primary healthcare sector. And we used the statistical packages for the social science program, which is the SPSS, and the Microsoft Excel have been used also for the analyzing of these data. And the help of the number of techniques, which include the distributive statistics and the correlation matrix, along with the dimension reduction technique, as well as the reliability test. These all are tests to be used for statistics about this research, and the frequency and the percentage analyzing are also included in this study, and to determine the frequency of appearing each option and the answer of asking a question. And deliberation, the major finding of this study is suggest that the physiotherapy have a key role in the primary healthcare sector in Saudi Arabia. The participant rate of the participant has been changing with each question, as we said, because participants aren't answering all the questions, and the number of respondents has been fluctuating for the change in the question. The first question asked from the participant about the age of the respondent, and the answer of are indicate that the large share of the participant in this survey has been in the age group of 18 to 25 years old, and the participant rate is indicated that 33.8 participants have an age of 26 to 35 as far as participants in this survey. With respect to age is concerned, the other age group have very limited share in the survey because their participant is decreasing with the increasing in the participant in this survey. This age show you that what people I can give for the survey to give them about it. On the other hand, the female physiotherapist share in the study is greater than the male participant in the study. And the compensation of the gender participants is indicate that the female share in survey is 54. It's more than 0.5%, while the share of the male was 45. It means that the share of the male participant is lower as compared to female, and indicate that female participant survey is more encouraged level. The survey share of married individual and greater than the other option because the data suggests that the share of married physiotherapists is 32% and it's not appear in the survey. This 42 share of the survey are consisting of the single individual that but it's 27% were divorced among them. Most of them were single who share their surveys with us. It showed that the single participants are greater than all other categories because they have a higher rate and compared to other categories of married and single. On the other hand, when we came to educational level participant, the survey find that participant with the education level baccalaureate is greater than all other education. Also, the people who were in government sector were more participating than in the other private sector, and the data of the nationality are indicated that they were 100% Saudis. The data of preference and are indicated rate that the large share of participants is coming from Riyadh only, and the 100% participant are belong to Riyadh city only. All these participants of the study are belong to Riyadh, and the composition of the participant rate has been changed with the question. Then the data of the nationality are indicated and the visit are indicated that the 100% are contributed in this survey belong to Saudi Arabia, and the physiotherapist has been educated in all the client about the exercise and the exercising, and they are the one who's doing physiotherapy and exercising only in Riyadh city. Here you can see the primary partitioner referral and how is it going in our system. Here it goes like somehow spinal assessment, orthopedic surgeon, and this is like how it used to be. And what we want next, we want it to be in the term like this, what World Health Organization have been asked for. It is like to have primary health care related in certain services, including health promotion and health promotion. We want by this research to conclude, after having primary data in one city, that we have health physiotherapist as health promotion is a key role. So these conclusion that the primary data analyzing and empirical finding of this study and the data analyzing has founded that physical therapy is playing a huge role, and agrees by physiotherapists all in Riyadh that we can play a major role in rather health in general, health like education and health promotion, and also prevention of the disease. And sometimes even we can add rehabilitation, like as continuously chronic case and so on. In the future, it could provide acute care from physiotherapy scope kind of a practice. Suggestion or recommendation in the managerial relevance of this research and the scientific application of the study, and our limitation of the work on this study was we need to apply it for different cities. We need to check more cities to see if it's also the same in Riyadh. We can also make it in domestic level or even international level, although some countries already having in primary health care physiotherapy as a service in the primary health care. This is my reference, and there is a lot of reference. I just pick up most of them. And thank you so much. This our main program. It's like everybody must know, I guess by now, by 2030 vision for Saudi Arabia, and a huge part of it is the health sector transformation program. We are already transforming to different and huge health sector transforming program. It's going to be near future. They are already working on it. Thank you so much. Is there any question?
Yes, any questions? Any questions to Dr. Tia Al-Salih from King Abdulaziz Medical City from Saudi Arabia? I would like
thank
yes, I would like to inform.
Thank you.
Yeah,
Thank you, Kevin. Thank you, Kevin, for having me time after time. Sorry if I'm making you a bit busy or so on, but thank you so much for your time that you providing this assist for us to have an international kind of meeting with all this group. Thank you so much.
Yes, thank you so much. I would like to inform Dr. Tia is joining our events since last 4 years. For every conference, Dr. Tia is joining, is delivering stock, he will be in physiotherapy from entire world in different way. Thank you so much, sir. Thank you so much for the support and cooperation.
Yeah. Anytime, you're welcome. Thank you.
Yes, you'll be getting the participation certificate and laptop booklet within a couple of days. Next, we ask Dr. Kiran Jeswani from PS Model College of Physiotherapy from Pune from India to join the Congress and starts sharing slides. The topic will be effect of graded motor imagery in patient with lateral epicondyle pilot study.
Hello. Hello.
Yes, madam.
Hello. My screen is visible?
Yes, madam. Just you can enlarge. You can go to
Yes.
slide
Yes.
show.
Yes.
Yeah, it's fine.
Hello, everyone. I'm Dr. Kiran Jaswani, Associate Professor from PS Modern College of Physiotherapy, Pune. And my topic is effect of graded motor imagery in patients with lateral epicondylgia, a pilot study. So what is lateral epicondylgia? It's a health condition characterized by acute or chronic pain at the lateral epicondyle of the humerus. The signs and symptoms are pain, tenderness, limited extension at the elbow joint, and weak grip strength. This is the fear avoidance model. It is a psychiatric model that shows how individuals develop chronic musculoskeletal pain because of avoidant behavior due to fear. So when there's pain, if there's no fear, there's no negative thoughts, the patient recovers. But if there is pain and if there is catastrophizing, that is, he views a situation worse than what it is, then there is negative thoughts and there is fear. So what is kinesophobia? The patient has an excessive, irrational, and debilitating fear of physical movement and activity resulting from a feeling of vulnerability to painful injury or re-injury. A person believes that movement can cause more injury and pain. So many studies have explored the effectiveness of fear beliefs and kinesophobia in patients with lateral epicondylgia has supported the fear avoidance model. Graded motor imagery retrains the brain through neuroplasticity. It suggests that the ongoing pain is often due to changes in the brain more than the changes in the body. It sequentially activates the cortical motor networks and improves the cortical organization. It works on the underlying mechanism that neural networks, which are normally involved in movement planning and execution, are also equally active during perception, perceptual reorganization, and imagined movement. There are 3 stages of GMI. The left-right discrimination, that is the implicit motor imagery, the explicit motor imagery, that is the imagined movement, and third is the mirror therapy. So the first one, that is the left-right discrimination, it reorganizes the brain's perception of your hand through understanding its spatial orientation. Research has shown that people in pain lose their ability to identify the left or the right image of their painful body parts. When viewing the pictures of body parts, they are slower or less accurate than somebody without pain at determining whether the image is of a left or a right side. So training the left-right hand discrimination can activate the parts of our brain associated with movement without firing off a pain response. The stage 2 is the mental imagery. Now, mental imagery of movement, that is the imagined movement, it can be hard work if you're in pain. Because 25% of the neurons in our brain are mirror neurons, and they start firing when you think of moving or even watch someone else move. So when we vividly imagine a movement, our brains are active in many areas as when we actually move. The third is the mirror therapy. During mirror therapy, the affected limb is behind the mirror, while the intact limb is in front of the mirror. The participants moves the non-affected limb slowly while watching the reflection in the mirror box to trick the brain into thinking that the affected body part is actually moving in a free way, pain-free way. So further progression will be moving the hidden limb within its pain-free range. So through exercises, there's a possibility of retraining the brain to communicate the correct signals to the affected body part. There's extensive literature which demonstrates the positive effects of graded motor imagery on motor function, muscle strength, range of motion, postural control. Chronic pain conditions such as phantom limb pain, low back pain, complex regional pain syndromes, elbow stiffness, shoulder pain have been treated with GMI, that is graded motor imagery. Now, fear of movement has been a strong indicator of chronic disability in patients suffering from pain. This has led to the development of holistic management strategies which incorporate biomedical, psychosocial, and neuroscience aspects of pain and dysfunction. Motor imagery is a new rehabilitation strategy for chronic pain conditions, though extensively used in athletes and neurorehabilitation in the past. In an article by Renard and Small, 2017 on lateral epicondylgia, treatment considerations added that taking a graded motor imagery may offer a novel way to retrain the cortical representation of the elbow and the movements of the wrist and lower arm, and no papers have included this as treatment. A pilot study is the first step of the entire research protocol and assists in planning and modification of the main study. One of the key reasons why this pilot study was needed was to obtain preliminary data for the calculation of sample size for the primary outcome. Thus, the objective of the study was to do a pilot study to find the effect of graded motor imagery on kinesiophobia, pain, grip strength, and function in patients with lateral epicondylgia. Study design was a single-blinded randomized controlled trial in patients having lateral epicondylgia. Sample size was 24 and per-person sampling was done. Inclusion criteria: age within 20 to 55 years, male and female, presenting with at least one of the following clinical tests, that is the Mills sign, Cozen sign, and the Modley's test. Unilateral lateral elbow pain, subacute to chronic condition. VAS was 5 mm to 74 mm and score more than 37 on the Tampa scale of kinesiophobia. Exclusion criteria was any radiculopathy, neurological signs, recent burns, infections, trauma to the upper extremity, surgery on the upper quadrant within the 6 months, local or generalized arthritis, patients undergoing any medical treatments providing pain relief such as acupuncture or any other pain medications, patients who were not willing to participate. Ethical clearance was done. Subjects were selected according to the inclusion and exclusion criteria. It was explained, the study was explained to the patient. Written consent was taken from the patient. The participants were randomly allocated to either the GMI group or the control group by JIT method. Pre-treatment assessment was taken by VAS, that is visual analog scale, patient rated tennis elbow evaluation scale, hand dynamometer, and Tampa scale. Group A received graded motor imagery and conventional treatment for 3 sessions for 6 weeks, and Group B received only conventional treatment, 3 sessions for 6 weeks. The graded motor imagery was done in 3 stages: 2 weeks of lateralization, that is left hand discrimination, 2 weeks of motor imagery, that is imagination, and 2 weeks of mirror therapy. Each stage lasted for 10 minutes. So this is a left hand discrimination, where they were given presented with stacks of photos and hands of various postures, and they had to separate the piles of right and left hand. The second was the mental imagery. The card which was representing the affected site was given, and the patient was asked to move the hand into such a posture. Just imagine to move and not move really. And the third one was mirror therapy. Conventional treatment, cryotherapy was given, conventional exercises, that active exercises, and if there was no pain, then it was progressed to strengthening exercises. According to the Delhome's technique, the strengthening exercises was progressed. Stretching exercises for the wrist extensor was given. Result: no group differences regarding the baseline characteristics was seen. So the mean age was 42.59 for the GMI group and 44.16 for the control group. According to the Kolmogorov-Smiron test, there was a normal distribution of data. Paired t-test was used to determine the mean differences between and at the beginning and at the end of the treatment. Within the group, analysis showed a significant decrease in pain, decrease in kinesiophobia, increase in grip strength, and improvement in functional status in both the groups. On comparison of both the groups, unpaired t-test was used to find the difference between the scores in the control and the GMI group, which was statistically significant. Between group comparisons revealed significantly greater improvement in pain at rest and during activity in the GMI group than in the control group. It also showed that the GMI group had better Tampa scores than the control group. And the GMI group also showed significant greater improvement in the PRTE scores and the grip strength than the control group. So discussion: the present study was done to study the effectiveness of graded motor imagery on kinesiophobia, pain, function, and grip strength in patients with lateral epicondylgia. There was significant effect of GMI in reducing pain, kinesiophobia, and thus improving the function and grip strength in both the groups. The effect was more significant in Group A than in Group B. Exercises play a crucial role in improving the muscle performance and preventing injuries. Stretching exercises help to enhance the flexibility by elongating the structures that have become hypermobile. Cryotherapy causes vasoconstriction and tissue blood flow, and also diminishes tissue metabolism, oxygen utilization, inflammation, and muscle spasm. A study suggested that motor cortex reorganization may contribute to the motor dysfunction and persistence of symptoms in lateral epicondylgia. So the conventional bottom-up approach, focusing on peripheral sources of pain, is being reevaluated due to recent findings on the cortical changes in chronic pain sufferers. Instead, the top-down perspective, that is using the central processing in the cortex, is gaining prominence. So GMI is a treatment technique derived from this new pattern, aiming to normalize the central processing and alleviate the chronic pain. GMI incorporates mirror visual feedback and uses neuroplasticity principles, addressing both the peripheral pain and restoring the cortical topography and sensitivity. No consensus exists about which stage of GMI has more potential, but the sequence of the program is essential for the cortical network organization. The multifactorial approach of GMI includes reduction of pain and the restoration of cortical topography and sensitivity. Therefore, GMI can be used as a complementary treatment along with conventional treatment in patients with lateral epicondylgia. This study concluded that adding graded motor imagery along with conventional exercises has significant effect in reducing pain, kinesiophobia, and thus improving function and grip strength in patients with lateral epicondylgia. Through the pilot study, feasibility and acceptability of the general experimental plan, as well as the potential for positive effects, was tested. The results will be used as a foundation to proceed with a full-scale randomized controlled study. These are the references. Thank you. Hello.
Yes, yes,
Thank you, sir.
yes. This was the presentation from Dr. Kiran. Just one. Any questions regarding this topic? If you have any kind of questions related to this topic, you can text in chat box. Will be asking behalf of you. Even after the completion of the Congress, will be asking you. Any questions? Yes, yes, madam. We got a question from Dr. Deepthi, madam.
Hello.
You can read from the chat box, madam. You can find.
Okay, okay, sir. Okay, sir. Yeah.
Are you audible, my voice, madam? The question is how the MVC was done.
Okay. Hello.
Yes,
Hello.
madam.
Am I audible, sir? Yeah. Hello. Yes, sir. MVC was not done. It can be added in the future study. Right now, the scope of study was not taking EMG measurement. It was just using VAS and the kinesiophobia scale.
And could you not had a EMG measurement as objective measurement?
Yes, we can. We can for maybe the next. This is just a pilot study. Maybe in the full-fledged study, we can add EMG measurement also as an objective.
Yes. Any other questions related to? Yes, thank you so much, madam. It was nice talking.
Thank you, sir.
Yes,
Thank you, sir.
Yes, you'll be getting the participant certificate electron within a couple of days. Thank you so much. Now, we request you again, ma'am, try to join for in person next year or also by end of this year. We are having 2 physiotherapy congress. One is in Europe and another was in Asia Pacific region. You can submit an abstract and book the slot. Next, we asked Dr. Urvisha from Lunagiria from Specialist Physiotherapy from London. So, if you, madam, if you are okay with presentation, you can start sharing your slide. Or else we can go with Dr. Yuthike Rao. Yes, madam. If you are okay with your PowerPoint, you can start sharing.
Yes, I'm ready. Should I share my screen?
Just to be online, madam. I'm going to make the co-host too. Yes, you can start sharing.
Just a minute. Is it visible?
Yes, yes. You can make some slideshow somewhere.
Yeah. Just a minute. It's okay?
Yeah, it's fine now. Continue. Yes.
Okay. So a very good morning to all of you. Myself, Dr. Yuthika Rao. I am an associate professor in Mahatma Gandhi Physiotherapy College from Jaipur. So today my topic, what I'll be taking is just a minute. This is not that slide. Just a minute. Okay. So my topic is effect of resistance exercises and aerobic exercises in diabetes mellitus type 2. So we all are aware that diabetes, it is a serial killer. Nowadays, it is increasing day by day. Until now, according to my knowledge, in our physiotherapy field, that is there is no set protocol for diabetes mellitus patients. So on this topic, I am doing my PhD also. So I'll be putting some light on this topic today. Diabetes, it is a metabolic disorder in which the body is unable to appropriately regulate the level of sugar, specifically glucose, in the blood, either by poor sensitivity to the protein insulin or due to inadequate production of insulin by the pancreas. Diabetes mellitus, it is of two types, type 1 and type 2, gestational diabetes, neonatal diabetes, and secondary causes due to endocrinopathies, steroid uses, and etc. So these are the causes which lead to diabetes mellitus. It can be due to physical inactivity, weight gain, high glucose, genetic factors. Then what is the incidence of diabetes in world? In 1980, it is 108 million people worldwide had diabetes. By 2014, the number increased to 422 million according to WHO. An estimated 700 million adults worldwide will have diabetes by 2045. This data is given by International Diabetes Federation 2020. China has the highest number of diabetic account worldwide with 116 million people with diabetes. Following China is India, 77 million people with diabetes. In United States, it's 31 million diabetes. Then prevalence according to the type. 34.2 million US adults with diabetes, approximately 7.3 million of those are undiagnosed. So please note some huge population now also are the persons, those who are not diagnosed with diabetes or they are ignoring their symptoms. An estimated 88 million adults have prediabetes, 34.5% of the US adult population, and rest, these are the data for various type of diabetes given here. This is the epidemiology. Mainly according to Indian Heart Association, India is being projected to home to 109 million individuals with diabetes by 2035. A study by American Diabetes Association reports that India will see the greatest increase in people diagnosed with diabetes by 2030. The high incidence is attributed to a combination of genetic susceptibility plus adoption of a high calorie, low activity lifestyle by India's growing middle class. Now, what are the risk factors for the cause of diabetes? First, overweight or high BMI, background of African Caribbean, Black African Chinese. Yes, diabetes can, the risk factor can be ethnicity also. High blood pressure, stroke or heart attack, family members have or had diabetes, history of polycystic ovaries, gestational diabetes, or given birth to baby less than 10 lbs. Sorry, it's more than 10 lbs, and large waist. Men and women parameters vary. So these are the symptoms of diabetes. Now comes the important point, HbA1c, which we take into consideration to rule out type 2 diabetes. So the hemoglobin HbA1c test tells you your average level of blood sugar over the past 2 to 3 months. It's also called HbA1c glycolated hemoglobin test or glycohemoglobin. The sugar in your blood is called glucose. When glucose builds up in your blood, it binds to hemoglobin in your red blood cells. The A1C test measures how much glucose is bound. Red blood cells live for about 3 months, so the tests show the average level of glucose in your blood for the past 3 months. So this test is basically to calculate your amount of glucose in the body for the past 3 months that is in your body. So this test is done after the 3 months, in every 3 months. Now, what is the limitation of this test? Conditions that prolong the life of erythrocytes or are associated with decreased erythrocyte turnover lead to increased exposure of cells to glucose and falsely high HbA1c results. Examples include iron deficiency anemia, B12 deficiency anemia, folate deficiency, chronic alcohol use, and asplenia. Conditions that shorten the life of erythrocytes or are associated with increased erythrocyte turnover lead to reduced exposure of cells to glucose and falsely low HbA1c results. Examples include acute and chronic blood loss, hemolytic anemia, splenomegaly, and pregnancy. These are the conditions in which we see inappropriate low HbA1c, high HbA1c, and variable effect on HbA1c plus. Now, this was the study which was done in USA versus US. American College of Physicians recommends that HbA1c level target in type 2 diabetes be eased to 7 to 8%. Indian doctors say 6.5 to 7% levels followed for decades, better suited for disease. Say any relaxation will lead to complications in patients. Also observe that the response of Indians to medicines and doses different due to our carbohydrate rich diet. Now, this is a device which we use, continuous glucose monitoring. This is the advancement as compared to HbA1c. As I already told that HbA1c, we can record the past 3 months data. So the advancement now it is done. It is a glucose monitoring machine. This is the machine which tracks each and every second of glucose monitoring can be done in your body with the exercises, without the exercises. So it is easy to apply, and now I am planning to use this in my study also. So what is its uses? We can just apply that tracker on the body, and this monitors each and every activity of the glucose monitoring going throughout your body, like during the meals also. And as we all know, after taking the meals, the glucose level increases. So once it is implied to the body, we can use it with the exercises to see the effects of exercises on diabetic people. This was the continuous glucose monitoring which was used earlier. Now that was the advanced machine which I showed you just now. Many continuous glucose monitorings have special features that work with information from your glucose readings. An alarm can sound when your glucose level goes too high or too low. You can note your meals, physical activity, and medicines in CGM device too, alongside your glucose levels. You can download data to a computer or a smart device to more easily see your glucose trends. Currently, one CGM model is approved for treatment decisions, that is the Dexcom G5 mobile. Now, the effects of exercise on insulin and glucose: decreased blood glucose, uptake of glucose into the muscles, stored as glycogen, decreased insulin level via use of insulin-dependent glucose transfer to muscle, increased insulin sensitivity. It may be blunted in type 1 diabetes dependent upon injection site, increased glucose via glycogenolysis and gluconeogenesis. The nation, this is the NIC team released 4 new guidelines relating to diabetes management by August 2015. Aerobic exercises involves repeated and continuous movements of large muscle groups. These are the exercises: resistance training, flexibility exercises, and balance exercises. Recent research, these are some articles that are supporting my topic: low thigh muscle stress relation to patients with type 2 diabetes mellitus. The thigh muscle is one of the largest and most important muscle groups in the human body, as it plays an important role in maintaining an upright posture, supporting body weight and walking. Type 2 diabetes mellitus patients can experience loss of muscle mass, strength, function, quality over time, particularly in lower extremities, which is associated with a deteriorating health status, reduced mobility, even sarcopenia, and falls related fractures. Effect of PNF stretching versus aerobic training on glycosylated hemoglobin in patients with type 2 diabetes mellitus. This study aimed to compare the effect of PNF stretching versus aerobic training in type 2 diabetes mellitus in patients with HbA1c levels. So the result of the study was that the both aerobic and PNF facilitation stretching induced decrease in blood glucose levels after the protocol. Effect, okay. What are the benefits of aerobics for diabetes? Cardiovascular conditioning will be improved, reduce the risk of heart disease, blood pressure will be maintained, it increases good cholesterol, controls blood sugar, maintains weight under control, it benefits lung function, and it reduces the resting heart rate. And lastly, I also want to mention that it has an effect on lipid profile parameters also. These are the aerobic exercises which we can give to our diabetes patients. Now, this is the research related to aerobic exercises. Immediate effect of aerobic exercises and resistance exercise on vital parameters in type 2 diabetes patients concluded that aerobic exercise is effective in reducing pulse rate, respiratory rate, blood pressure in type 2 diabetic patient. And this is the recent research done in 2023. These are the resistance exercises, and the effect of resistance exercises, it improves the glycemic control, insulin resistance, fat mass and lean body mass, it improves blood pressure, and it improves the strength also. These are the resistance exercises. These are also some articles supporting the resistance versus aerobic exercises in diabetic patients. And typical exercise schedule for diabetics, aerobic and resistance, it can be in aerobic, moderate exercises can be prescribed from 12 to 13 cycles of repetitions, 30 minutes per day, or vigorous 14 to cycle repetitions or 18 to 20 minutes per day, and resistance exercises. These are the references. Thank you for listening to me patiently.
Yes, this was a presentation. Any questions? Any questions to Dr. Yutika Rao? Effect of aerobic training systems and type 2 diabetes. If you have any questions related to this topic, you can text us. Yes, thank you so much, madam.
You're welcome.
And certificate and booklet within a couple of days.
I want to thank you also for giving me this opportunity to present on the international platform. Thank you very much for your assistance. Thank you.
Yeah, and the question is, just only one question from Dr. Dipti from chat box. Numbers always give you a better picture. Would you better output the measurement outside the electromyography and physiological parameters?
Just a minute, I'm not able to.
Just you can see from the chat box.
Yeah, I am going to chat box only. Wait.
Hello.
Hello.
Yeah, can you hear me?
Yeah, ma'am, I'm able to hear you, but I'm not able to.
I would first of all like to thank you for this nice presentation.
Thank you, ma'am.
Throughout the presentations I'm listening, the objective measurements I find are missing.
Actually, ma'am,
that numbers always give better pictures. So
if
you
ma'am.
measure the outcome in terms of electromyography and physiological parameters, I feel it will be giving you better picture of how your interventions are working. Isn't it so, ma'am?
Yes, ma'am, you are totally right. Actually, this I have prepared as a talk. I'm not included it as a study here. So I am doing my PhD study on this only. So my effect of concurrent exercises on type 2 diabetes, and that is also on Indian populations, because right now what I was going through was that there was not a set study done in Indian population. Uh, Outside India, there is lot of studies done, and they have prove the effect of exercises. But what I was going through was that ethnicity also affects the
Yeah,
diabetic
that's
parameters.
right.
So now I have included my outcome measures also in my study, and definitely I'll take care of these suggested parameters which you have told me.
Okay, thank you so much
Thank you, ma'am.
and good luck.
Thank you, ma'am.
Yes, thank you so much, madam. It was nice presentation.
Thank you.
And we request Dr. Dara Shah from Gujarat University of Ahmedabad to start presentation.
Hello,
You
good
can share your
afternoon.
slide.
Hello, good afternoon.
Yes, madam.
Shall I start my screen sharing, sir?
Yes, madam.
Okay, thank you, sir. I hope my screen is visible to all of you. This is Dr. Dhara. I'm working as a chief clinical instructor in WOW IP, that is International Institute of Pelvic Floor Research, Rehab and Education. And thank you very much for giving an opportunity to me to speak about the validity and reliability of head self-assessment for pelvic floor muscle examination. So when we talk about the pelvic floor muscles, as we all know that pelvic floor muscles are the group of muscles which are connected from the base of the spine, that is coccyx, to the symphysis pubis, and on both the sides the ischial, the right and the left ischial tuberosities. The pelvic floor muscles are generally known to function in order to maintain the sphincter control, to maintain the stability, to maintain the sexual well-being, as well as the lymphatic drainage. They do have a significant... Yes. Sorry, sir. So shall I continue?
तो सर ऐसे क्यों बोले थे?
So shall I continue? Is there any instruction for me?
Yes, sir. We are unable to see your PPT.
Oh, let me play it again, sir. Is it visible now, sir?
Yes, it's fine.
Yeah. So my today's topic is validity and reliability of head self-assessment for pelvic floor assessment. This is Dr. Dhara Shah. I'm working as a chief clinical instructor in WOW IP, that is International Institute of Pelvic Floor Research, Rehab and Education. And I'm a PhD scholar under Dr. Anjali Desai ma'am from Gujarat University. So my today's topic of title is, as I said, reliability and validity of head self-assessment. So when we talk about pelvic floor muscles, the pelvic floor muscles are the group of muscles which are present at the base of spine. And these are the muscles which play a very significant role when it comes to maintain the urinary, anal, fecal continence and closure. Also, it plays a significant role in supporting the viscera for sexual functioning as well as the lymphatic drainage. Pelvic floor are equally known to work for the supporting supporting the uterus during pregnancy, as well as to have and to facilitate a healthy and easy childbirth if trained properly in the antenatal period. But when these pelvic floor muscles can become weak or they become lax due to the conditions like pregnancy, obesity, childbirth, chronic constipation, increase intra-abdominal pressure, or sometimes if the person is involved in the occupation where they have to recurrently increase their intra-abdominal pressure and they don't know how to stabilize their spine. So all these conditions can lead to weakening or looseness of the pelvic floor muscles. And if these pelvic floor muscles, they become weak or they become loose, then they can result into conditions like urinary incontinence, which can be stress incontinence, urge incontinence, mixed incontinence, or it can even result into fecal incontinence. We may come across that fecal incontinence is not that common, but the research and the statistics says that 4 out of 10 mothers who had delivered through a perineal tear or a normal vaginal deliveries, they have a chance to end up into fecal incontinence. The only thing is it has been less spoken because it is still considered to be a taboo. The next can be the pelvic organ prolapse. Again, pelvic organ prolapse is a condition where the pelvic organs descend down from their position into the vagina. It can be an anterior compartmental prolapse, it can be a middle compartmental prolapse, or a posterior compartmental prolapse. Again, 80% of the females who have grade 1 prolapse are unaware of them having the prolapse. As well as there are more than enough evidences to support that once there is a prolapse and if there is any need to go for a reconstructive surgery, there are chances to go to, there are 50% chance to have the surgery again. Not in the last in the list, but not the least, that is the female sexual dysfunction. The female sexual dysfunction due to weak pelvic floor or legs pelvic floor can be it can be HSDD, that is hypoactive sexual desire disorder. It can be arousal disorder. It can be orgasmic disorder, or it can be an anorgasmia at all. So there are the females who do have a weak pelvic floor, or the females who have a vaginal laxity. They are reported to have higher number of sexual dysfunctions. And the pelvic floor, as it plays a significant role in maintaining the core stability, it is equally important for maintaining a healthy core. A weak pelvic floor can be associated with low back pain also. The study which was conducted to find the prevalence of pelvic floor dysfunction concluded that 36.3% female, they can have urinary incontinence, 22.1% can suffer due to vaginal laxity, and pelvic organ prolapse is as prevalent as around 23.4% women. Let me make a note here that this study was done in just one part of the world. Rest, the studies as well as the prevalences for pelvic floor dysfunctions are not very significant, because this is still considered to be a taboo, especially in the subcontinents or the continents of Asian countries like India, where the females are not quite aware about the dysfunctions as well as the dysfunctions as well as the rehab or the management. The pelvic floor examination can be done through a vaginal examination. Obviously, there are other tools like pereniometers or EMG, which do have their own limitations in terms of assessing the pelvic floor. But the digital examination can be done in order to examine the strength, endurance, power, repetitions of the pelvic floor muscles. Today, I have taken this topic to see the validity and reliability of Haig's self-assessment, that is strength, endurance, repetition, and fast twitch, and it has been compared with the perfect assessment scheme given by Laycock. Perfect is a power, endurance, repetitions, and every contraction timed. So, perfect assessment scale it assesses the pelvic floor muscles properties like strength, endurance, repetition, fast twitch, and every contraction timed. But when we take a perfect assessment, in that the P stands for power, and the power is analyzed by using the modified Oxford MMT. Now, when we talk about the modified Oxford MMT, its reliability and validity of modified Oxford MMT is low to moderate, which means the scale is not very reliable and valid. Secondly, when we talk about the modified Oxford MMT, it cannot give you the strength of the pelvic, it cannot give you the relaxation ability of the pelvic floor muscles, which is given by Haig's MMT. Also, the modified Oxford MMT do not give a proper strength, or do not give an subjective or an objective way that how much is the strength of the pelvic floor muscles. It gives you an idea whether it is weak, fair, moderate, but that weak, fair, moderate can vary according to the expertise and experience of the examiner who is doing the test. Also, when we talk about the endurance part of the perfect assessment, the endurance is to be considered to be 35% of maximum voluntary contraction on digital examination. The maximum voluntary contraction on digital examination is a qualitative measure and is not a quantitative measure. So to exactly grade the 35% of MVC becomes quite challenging for the newcomers when they are doing an examination. Plus, this reduces the inter-rater reliability of the tool itself. So these were the major limitations of perfect assessment. Though perfect assessment is considered to be a reliable and valid tool to do the pelvic floor muscle examination, but there was a need to develop a tool which can take care or which can bridge the limitations of the perfect assessment. And Haig's self-assessment was designed and developed to overcome the limitations of a perfect assessment. So the need of this study was to take the intra-rater, inter-rater reliability and validity of height self-assessment for pelvic floor muscles. The objective was to develop a tool which can overcome the limitations as well as to check its reliability and validity. It was a test, retest, as well as a validity study, which had the study duration was around 18 months, and it was conducted on the outpatients coming in the private hospitals in Ahmedabad. It was in convenience sampling, and around 367 participants of between 18 to 60 years of female who were coming to OPD with a significant complaint of pelvic floor dysfunction, like urinary incontinence, fecal incontinence, pelvic organ prolapse, female sexual dysfunctions, low back pain. All those were evaluated to find out whether they had a hypotonous pelvic floor or a hypertonous pelvic floor dysfunction. The exclusion, the patients who suffered through vaginismus, infections, inflammations, vestibulitis, vulvodynia, chronic pelvic pain, absence of consent, and other disorders which would limit their participations were excluded from this study. Let me give the reasons for excluding the vaginismus and all the other hypertonous pelvic floor, because when we are examining a pelvic floor transvaginally, we need to find out first whether the pelvic floor is eutonic or hypotonic or hypertonic. A hypertonic pelvic floor, for example, a vaginismus, which comes out to be -1 on Haights MMT, will not allow an intravaginal examination. So if in case an intravaginal examination is not done, it will be very difficult to find out its endurance and other parameters. So the first goal for an hypertonus would be to come them to eutonic and then to examine so that wasn't, these candidates, they would fall into a long-term study. So they were not excluded from the present study. The materials used were the glove, gel, sanitizer, and the tissues. The outcome measures taken were Haights self-assessment, perfect scheme, FSFI, that is female sexual function index, which is a 19 questionnaire index, which is used to measure the sexual well-being of a female. It encompasses the different sexual behaviors like desire, arousal, lubrication, orgasm, and pain. Also PFDI 20, which is a 20 question based pelvic floor distress inventory, which gives a measure on how much distress a patient feels while doing how much distress the patient feels due to a pelvic floor dysfunction was assessed to find out the subjective distress as well as the sexual dysfunction faced by the person. And perfect assessment and Haights assessment were analyzed to get the validity of the study. The study was been approved by ethical committee, and a written consent and a written consent form was taken. The participants were examined digitally by the first examiner on the first day, and after a gap of 15 minutes the second time. So two tests, test 1 and test 2 at a difference of 15 minutes were done by one examiner. The second examiner examined the pelvic floor muscles on the second day, again with the same first examination, and then after 15 minutes, the second examination. None of the participants were recruited in any of the pelvic floor rehab before completion of this study. So none of the participants were doing a pelvic floor rehab while they were a participant in the study. All the participants were evaluated for Haights self-assessment, Haights perfect assessment, and also the score of FSFI and PFDI 20 were collected for the validity study. The analysis was done using SPSS version 20, and the BMI was around the BMI of the participant was 20, the age was 35, and the parity were 2. The within test reliabilities for the examiner 1 showed all the individual examination SERF, strength, endurance, repetition, and fast twitch were analyzed for examiner 1 and then examiner 2, and the between session reliability for Haights of assessment by examiner 1 and 2 showed an ICC of again the validity study. In the validity study, all the measurement taken for the Haights self-assessment were analyzed with perfect assessment, FSFI, and PFDI 20, and which showed a significant positive correlation between the findings, which shows that the Haights self-assessment is a reliable as well as a valid tool when it comes to examine the pelvic floor muscles. The SERF strengths for strength, endurance, repetition, and fast twitch. The strength of the pelvic floor muscles for Haights self-assessment is taken by Haights MMT, which gives the objective strength of the pelvic floor muscles. according to HMMT, grade 0 is the baseline tone. If I have to, I will just short down the contraction component of the HMMT. The HMMT has contraction as well as the relaxation component. So the contraction component is 1, 2, and 3, where 1 shows a mild contraction from either side. Grade 2 shows a complete circumferential grip, and a grade 3 shows a strong upwards and inwards pull against resistance. So that is how the strength is evaluated. The endurance is evaluated by measuring how many seconds the patient can hold the pelvic floor contractions. So it is not we are taking a 30% of 35% or 50% of MVC, but as soon as on the command like take a deep breath in, breathe out, and squeeze as if you are trying to hold the urine. So when the patient is trying to hold the urine, that is when she is using her pelvic floor muscles, the endurance has been measured that for how many seconds could she hold the contractions with the same strength. So that is the endurance. Then is the repetition, that how many times she can repeat the same strength and endurance contraction, and the fast twitch activity. All these different parameters of pelvic floor muscle activities, the fast twitch, the slow twitch, the endurance and the strength are required to carry on the functional activities of the pelvic floor muscles, as well as to plan the rehab for the pelvic floor muscles. Whenever we are seeing the direct implication of taking the head surf assessment for evaluation is to find out the endurance and to get and to plan a customized or a tailor-made protocol for every individual. Because when we talk about the hypotonus dysfunction, or when we talk about the pelvic floor dysfunctions, when they are in which we need to train the pelvic floor muscles, we need to increase the strength of the pelvic floor muscles, we have to consider multiple aspects. That what is the endurance of the patient? Only by doing a singular assessment, for example, a strength assessment or just an MMT, won't give a detailed guide on how to carry out or how to plan the strength training or the endurance training for the patients. When we do a surf assessment, the head surf assessment enables a practitioner to develop a detailed examination tool, detailed assessment treatment plan for the patient. Also, it helps to measure the progression of the patient. So this study can conclude that the head surf assessment can be used as a detailed assessment tool to measure the pelvic floor muscles activity. Also, it can be helpful in planning a detailed and a structured plan of treatment for the patients who suffer from a hypotonus pelvic floor dysfunctions. These are my references. And I am from WOW IP, that is International Institute of Pelvic Floor Research, Rehab and Education, and we are the only government recognized institute for transvaginal transrectal pelvic floor rehabilitation. The founder and the chairman of WOW IP is Dr. Desai sir, who has innovated the HEADS surf assessment as well as many other intellectual properties like HEADS MMT, HEADS female sexual function skills, male sexual function skills, and we are been training pelvic floor rehab in 14 different countries. All these intellectual properties are being endorsed by many national and international dignitaries. Sir has also written a book on HEADS manual of pelvic floor rehabilitation, which is Amazon's bestseller #1 in neurology, Amazon's bestseller in gynecology and obstetrics, as well as physical therapy. It is also a recommended textbook for Masters of Physiotherapy in Women's Health in Gujarat University. The intellectual contributions are HEADS MMT, HEADS FMT, HEADS ring clock assessment, HEADS surf assessment, which I just presented, HEADS providers protection guidelines, reflexive result scale, and female and male sexual function scales. As well as there are multiple other innovation technologies. Thank you. This was from my side.
Yes, ma'am. This was a presentation from Dr. Darasha. Any questions related to this topic? Any questions? Just if you have any kind of questions, you can text in chat box. Will be asking behalf of you. Next keynote speaker of the day is Dr. Christopher M. Pollux, from Director of Education from Digital from Nancy from France, and the private clinical practice from USA. Sir, we ask you to share your slide if you are ready with your PowerPoint presentation.
All right. Can you hear me?
Yes, sir, it's fine.
Okay. And you can see my screen.
Yes.
Okay, we're ready to go?
Yes, sir. It's fine.
All right, here we go. Good morning or afternoon, depending on where you are. I'm in New Hampshire in the United States, so it's a little bit early, but thank you for listening. So this talk is really mostly an introduction based on the thought leadership aspect of implementing technology into the evaluation of movement disorders. So especially for those who are involved in conservative physical medicine, a physiotherapist, chiropractor, kinesiologist, some folks like that. So we don't have a lot of time, so that's why we're not going to get in too deep, but this is basically bringing to light maybe an introduction to some opportunities that people didn't realize existed in today's conservative physical medicine, adding new technology and sort of bringing together what's been going around for a long time in some areas such as artificial intelligence to utilizing movement-based analysis and integrating those things to improve our ability to understand what's going on with the patients, as well as explain to the patients and improve compliance and adherence. So the two key points that I really want to make is utilizing locomotion assessment, which historically we often use what are referred to as surrogate measures. So individual things like range of motion, strength. Many of us have been using performance-based outcome measures as the performance aspect, but we also have an opportunity to use a performance-based measure to also obtain some of these more surrogate measures. Because of today's technology, we do have some overall health implications or considerations in streamlining the process that we can use to evaluate. And we'll look at something really, really simple in terms of what is consistent among a lot of our patients and using that as an evaluation procedure to help dictate and direct some of our care. So we'll basically just go through an introduction. The main topic that we'll be discussing in terms of movement therapy is actually going to be gait or locomotion, specifically walking. I do get into a little bit of running because this is a sports medicine conference as well. A basic discussion on a couple of pathologies, definition of artificial intelligence, and then we will get into a conclusion. I like to begin with the state of affairs, which basically means what's going on in our healthcare world today. Obviously, I'm from the United States, and so I used a lot of this particular data. But what we find is a lot of the patients that come to see physical medicine specialist, a conservative physical medicine specialist, meaning not a primary care, not a surgeon, but the physical therapist, the chiropractor, and those of that similar background, is we find that many of the patients actually have more than one problem. Oftentimes they come in and we're forced to diagnose a specific problem and treat their specific problem because of the way that a lot of healthcare systems work, or it's time. We only have so much time to actually work with the patients. In the United States, so if we look at the number of comorbidities or the number of problems that people have, more than 65% actually have more than one comorbidity as far as females, and it's even a little bit less with males, but it's a really, really high number, and it's something that we need to take into consideration and potentially do a better job at looking at the interplay between these comorbidities, such as obesity. So we find that we're close to 60% with being sedentary in the United States, and again, this is different among different global aspects or different target markets. We have a very, very high obesity rate and a pre-diabetes rate over 50%. So basically what that says is the majority of people that are actually going to come in and see us are going to have at least one or two or more of these particular things. When we look at osteoarthritis alone, $350 billion a year with direct healthcare costs associated with that and loss of productivity, meaning that people are out of work. So therefore they have to take a workers' compensation or other form of payment, and then the facility that they work for, the organization, also has to hire somebody else. So there's a great amount of associated costs that are both direct and indirect, and it tends to grow even more and more with a lot of conditions that otherwise many of us would consider basically conservative, and many of these things that could actually be preventative. So low back pain and neck pain is a global problem, and it tends to be somewhere in the top 10 within the global markets. In the United States, consuming approximately $135 billion per year. And then we can also look at diabetes being another one of those that is highly associated with inactivity, being sedentary, and so on. Other conditions that also are related to movement disorders, such as heart disease, dementia, hypertension, those are a lot of things that we may see that are going to come across and are implicated to part of the problems. So these are the top 10 diagnosis codes that we see here in the United States, and they're very similar between physical therapists and chiropractors. And as you can see here, they are all of a neuromusculoskeletal nature, including low back pain being that number one. So as an introduction to artificial intelligence, it's become very popular, especially due to ChatGPT, and we've seen it take the world by storm and even created a lot of new legislation around that. If you're not familiar with artificial intelligence or what it really is, it's a algorithm-based process that actually thinks very similar to the way that we do as clinicians. In other words, when a patient comes in to see us, we take a history, we may run certain lab tests, we may do certain neuromusculoskeletal tests, and we have to aggregate that information and come up with a diagnosis or at least a pathology or a condition that we may want to investigate. So artificial intelligence works very, very similar to how a human thinks, but it aggregates that much more quickly. And it does that without the interpretation of emotion and other limitations that are associated with being human. So they're built on a lot of neural networks and mathematical models. And to give you a sort of an example that we may think about in terms of the physical medicine specialist is when, you know, we used to evaluate how we impacted a particular condition based on a single application, such as traction or shockwave or ultrasound. It wasn't until about 20 years ago that we actually had the mathematical statistical power to evaluate multiple or multimodal approaches, the way that we actually did that within practice. But now we actually have tools that will actually aggregate all of that information even within the clinical practice. And those are referred to as these performance-based outcome measures. Historically, we looked at performance-based outcome measures as sort of the ultimate test of how someone is doing, especially in sports or athletics with regards to return to play. We may eventually have someone run some sprints or do an endurance test. So motion analysis actually allows us to integrate that based on today's technology, because we don't have to look at singular points of aspect with regards to the movement. And I'll talk about that here in just a moment. I often use a lot of automobile analogies, and here I have an example of looking at just how a tire wears. And so you could certainly fix that tire, but it's not really going to fix the problem if it is related to an alignment, something that's mechanical at fault within the automobile system. It could be over or under inflation of air. It could be something that's broken inside of that. So driving is actually this performance-based outcome measure. So in the clinic setting, because we have better technology to evaluate that, instead of just performing a range of motion test and a strength test, all of these individual aspects, we can actually combine these into a single aspect that many of us were actually taught within our academic preparation, which is known as gait. And from now on out, I'm going to refer to gait as walking, because gait has a certain connotation that we really perform that mostly in a laboratory setting that required a lot of very expensive equipment and a lot of very specific and detailed space. And many of us kind of moved away from that in terms of practice. Many of us might do it as an observational method, but we're not able to capture a lot of that information that we can see with the use of technology. So when we look at gait, it's a timed execution. And the reason that understanding this is really important is it brings together a lot of the biomechanical and neuromuscular aspects of how the body integrates and creates a very specific movement pattern. And so we break it down into both the stance and the swing phase. The stance phase accounts for 60%. And within that stance phase, we have a lot of other issues going on, including absorbing that ground reaction force, transitioning from a braking and using this pendular activity to providing a movement forward. And then we go into the swing phase, while the other foot is now in its contact phase. So there's a lot of neuromuscular components that are involved in this process. It's highly reflexive. There is also a voluntary component to it. And what's interesting is we create a lot of strategies associated based on the efficiencies or inefficiencies with regards to a lot of the conditions that we have. With today's technology, we're actually able to pick up on that. So when I say that we can't just look at this with the naked eye, something as simple as symmetry. So symmetry is looking at ground contact time. And what we see is variability. Once it starts to approach approximately 5% difference between the right and the left, it actually becomes indicative of a pathological condition, at least a limitation with regards to improvement in performance. And so we can use that as a very simple basic, but a 5% difference in contact time when we're talking about something that only takes a half of a second, 400 to 600 milliseconds, that's real difficult to be able to establish. The other one is going to be speed. So speed is something that actually provides us a whole lot of information with regards to the overall health of a person. As soon as a person starts to walk less than 2.4 miles per hour, that's actually indicative of a higher rate of morbidity and mortality. So in other words, people that walk less than 2.4 miles per hour actually may die 10 years earlier than someone who can actually maintain that speed. A cadence is going to be the combination between their step and stride length and their speed. And that should also be relative to how far and is indicative of something associated with balance. So movement analysis and using walking as a basic pattern to evaluate, we can actually use it to evaluate many, many conditions. In fact, we can use it to evaluate the majority of conditions that walk through our office as the conservative physical medicine specialist. From behavior and cognition, studies have actually shown that we can evaluate depression. We can dictate and diagnose depression based on just movement patterns. Neurodegenerative disorders such as traumatic brain injury to Parkinson's and Alzheimer's, we can actually evaluate and determine the progression of Parkinson's disease 4 years earlier than we could without the use of technology. And it allows us an opportunity to maybe intervene more rapidly. And studies have shown that when we can do that, it limits the progressive nature of many of these conditions and disorders, and maybe, just maybe, we might actually decrease the progression of something like osteoarthritis and minimize the number of joint replacements. Obesity, I think, is natural, as we can see that that's going to change the gait pattern. But the difference is that for all of these, what it provides us for is a lot of output that we use within the clinic. So there's no one tool that we use to give us all of the information and then actually show the patient, because compliance and adherence are a very, very important aspect. We find here in the United States that only 30% of outpatient physical therapy patients actually complete the course of care, which means that they're not actually going to get full recovery, and they're going to have a very high reoccurrence rate of that particular problem. It's going to cost more money, and eventually that may lead to surgery. So one of my examples here is looking at spinal pain or low back pain. It's actually my prediction that with the use of artificial intelligence and gait analysis, because there's several studies that have actually shown the fact that just improving a walking pattern reduces low back pain, non-specific chronic low back pain. So we're going to be able to actually dictate and see exactly what is causing what we now refer to as non-specific low back pain that you may not be able to detect simply by watching from an observational method. So we do see a decrease in walking velocity. Some of these things we can actually pick up, but if you've never seen these patients before, you won't actually know. Step and stride reduction, changes in frontal plane action, really of all the joints and including the coordination patterns. Studies have shown people with low back pain have an atrophy with regards to both the intrinsic and the extrinsic musculature. Latency with regards to the movement patterns, which are going to also influence the overall stabilization within the core, which is then also going to influence the lower extremities with regards to their performance in their walking pattern. So being able to detect this can be very, very challenging, but we can get to it sooner. And as we see this as one of the global issues within the world, and one of the reasons it's really difficult to detect earlier on with the naked eye is because we tend to wait until pain. And pain is a metric utilized a lot in the research as a performance outcome measure when in fact it's not. The absence of pain does not necessarily dictate an overall good performance enhancement. And in fact, we have a lot of strategies that the body will automatically conduct as a result of minimizing the effects due to pain and trying to maximize the overall benefit with regards to any type of performance. And here we're talking about walking because that's going to be one of the most specific ways that we can evaluate that. And it's one of the most basic movement patterns that every single one of our patients is going to be involved in. And again, several studies have shown that if we can improve the gait pattern of people with chronic low back pain, we can actually reduce their chronic low back pain. Balance, we look at, as a critical movement with regards to how someone creates their overall level of stability. So we could actually measure that individually, and many of us do that using various types of aspect, but you have to have a form of balance to be able to ambulate. So we're able to detect a lot of that while someone is actually walking. And that gives us a dynamic assessment because that's going to be very important at looking at the interplay and the interaction between things like rate of force development. So we find that in older adult patients, rate of force development is very important. And we're not saying that it's the same as necessarily someone who's going to be weightlifting, but rate of force development means their ability to generate force rapidly. And so every time that you take a step, again, if a contact time, the initial phase is only approximately 20 to 150 milliseconds, the time frame at which someone needs to respond or react to that is very, very quickly. Now, take that a step further, and if someone is involved in losing their balance, rate of force development or power production becomes even more important. So it's their ability to regain their balance after they've potentially lost that balance. And that's actually one of the aspects when we look at gait mobility is we're constantly going through stages of balance and losing some of that balance. And so it's a natural process. So that pendulum effect that we find with walking. So that loss of stability gives us that inability to recover. And especially in the older adults, we need to be able to assess that. So for example, here is an older adult who has a history of falls. This is an overground walking speed. So we see that she has a 9% asymmetry, which is indicative of not being able to coordinate between the right and the left sides. Her self-selected walking speed is way below what's considered to be normal, as well as her overall cadence. We see here that her overall stride length is very low between the two, and her stance and swing phase are also representative of her slow walking speed. So what's interesting is when I do this analysis, the artificial intelligence aspect of systems give us an opportunity. It tells me whether or not it's abnormal or normal, and it tells me whether or not it's going to be high or low, and it tells me whether or not it's the right or the left. The best part of this is it allows me to have that communication aspect with my patients so they can really resonate and they can actually see this. So we see that the stride duration on both sides is very long at just over 1500 milliseconds for each one of those. Very short stride length. We see a swing time, especially long in the right and basically normal, or especially long in the left, basically normal in the right. And we see that she has a very, very long stance phase. So like I said, she has a risk of falls, and therefore what we want to be able to do is predict and convince this patient that we need to actually do something about this. So when we further evaluate her walking pattern, we see that these are some of her strategies that shows me that she tends to walk more so on the inside of her foot. She has osteoarthritis on that right knee, so she tends to use the foot progression angle that's a little bit higher. She uses a very short angle when she comes into strike pattern of the ground. So here's something for the sports medicine folks that we do what's called stress loading. So I can actually evaluate, and as I increase the stress by simply having either someone run or walk at an incline or run or walk at a faster pace. So it starts to tease out and show me the degree of asymmetry, and also gives me some of the increases of changes in the patterns with regards to their strike forces and their strike patterns. We should, by just having approximately 8 to 9% difference in speed, we should see some obvious increases such as their cadence, But what we're starting to see here is there's an increase in the asymmetry, which results in being problematic. The other advantage that we get by doing something using technology is I see a widening of the variation. So we see that this is a normal pattern here on the right, but we see that the left is actually transitioning and the person, and this is a ground contact phase, but we see that they have a very short heel strike pattern. And then they have a longer toe off. So this person actually has a cuboid syndrome, and we see that they have an inability to actually roll over to that side, which is indicative that they need a posting up on that particular area. So like I said, this was just a quick introduction, and now where do we go from here? We have opportunities to have low-cost devices that will provide us the opportunity to implement this within the clinical setting. We can do a much better job. We have moratoriums with regards to better return to play, better therapy, better compliance, and should reduce the overall healthcare costs. So thank you to Inovine and the Physiotherapy Congress meeting. Also special thanks to my colleague, Dr. Rana, who is impeccable at organizing things, as well as the rest of the colleagues that I work with, just make amazing stuff, do amazing work.
Yes, thank you so much, sir, for joining this event. And hope we expect your presence in person face-to-face meeting this year, or else by next year.
Thank you. Oops, lost my audio.
Yes, we request Dr. Urvisha Lunagiriya from Specialist Physiotherapist from London, UK, to start the presentation. The title will be role of healthcare professionals in encouraging and supporting health aging and promoting strategies for physical activities.
Yeah. Hi, Kevin. Sure, I'll just share in a moment.
Yes, sir.
So hello everyone, myself Urvisha Lunagaria. I'm a physiotherapist and I practiced in London. So today my topic of discussion is role of healthcare professional in encouraging and supporting healthy aging by promoting strategies for physical activity. So in this presentation, we're going to discuss about definition of healthy aging, the statistic, promoting physical activities in normal aging population, a case scenario of the patient diagnosed with chronic disabilities, and ways to promote healthy aging. What are the factors that affect it, strategies to overcome it, and little bit of conclusion. So before we start discussing about this topic, we need to know what actually it is. So healthy aging is an idea which is encouraged by WHO that undertakes the capability of an individual of all ages to live a socially engaged, safe, and healthy lifestyle. The most recent report published by WHO described that healthy aging as the process of maintaining and developing functional capabilities which enables an individual to live a physically fit and social life. However, the concept for healthy aging considers healthy aging in a biomedical aspect, suggesting the management and prevention of disabilities and illness associated with aging, thereby promoting healthy aging. The WHO's active aging policy framework recognized that regardless of the best strategies which emphasize in promoting and supporting subjective well-being for the aging population, the vulnerability to develop chronic diseases persists as the age advances. So the statistic, according to National Institute of Aging, 85% of older people end up with one long-term disease, 60% of them with two long-term diseases as age advances. This happens because of reluctance of an individual to change the behavior, including their diet, alcohol, and smoking. Therefore, it is essential to incorporate behavioral change strategies to enhance overall physical, mental, and social well-being. A healthy lifestyle can be supported and encouraged through different mechanisms, ranging from counseling and educational programs to financial support for better quality of life. Therefore, the key challenge for healthcare professionals is not only to provide good information and awareness about community services, but also to implement various behavioral change strategies addressing risk factors which further causes development of long-term diseases in older age. One of the ways to support this concept is through behavioral change strategies. What is actually the behavioral change strategy? So it includes taking part in the education program, involving in the community, physical activity, smoking cessation, and limiting alcohol access. All these behavioral change strategies leads to delayed development of many chronic illnesses, preventing loss of capability to participate physically, thus lengthening the life capacity and improving quality of life. However, behavioral change strategies alone is not sufficient to promote and enhance healthy aging. There are psychological factors also which needs equal emphasis. 13% of men and 18% of women experiences psychological problem age 65 years above. So let's see evidences to support what biopsychosocial model carries out a holistic approach for care. One of the longitudinal study conducted by this author focused on biopsychosocial well-being of elderly individuals. To promote healthy aging, considering psychological and physical aspects, this study performed 2 exercise programs of adapted physical activity for older adults, including PolyFit and OsteoFit. A PolyFit was for overall healthy aging people, whereas OsteoFit program included osteoporotic people with special emphasis for fall prevention, considering balance exercises. This study used adapted physical activity as an opportunity for socialization and biopsychosocial well-being promotion. Thus, healthcare professionals should also emphasize the psychological well-being in older people and consider family into aspect for supporting healthy aging in older people by involving family and providing education about this concept. A study conducted by another author suggested that regular physical exercise contributes to healthy aging in older people by improving social connectedness, enjoyment, physical function, mutual support, as well as expanding community participation. Therefore, older people should be encouraged to participate in regular group exercise in order to understand their perception of the social, physical, and mental well-being because of physical activity. To support all this above, it is important to introduce what is actually the healthy aging concept in this population. So according to NHS 2015, they proposed some of the headlines in their paper which suggest that by taking life too easy can actually speed up the slowing down process of later life. It is never too late to start being more active or begin an exercise program. Keeping active is the key to staying fit, mobile, and independent. One of the ways to add to this is by contacting your local leisure community center or Age UK to see what they have gone on, or if possible, to see if you can find an activity to do with friends or other people, such as walking and dancing. If you haven't been active very, you should aim to minimize the amount of time spent sitting down for extended period. You can do this by reducing the time you spend watching TV, taking regular walks around the garden or a street, or swapping a bus or a car journey for walking part of the way. Example of some sort of activity that improve or maintain health includes brisk walking, ballroom dancing, climbing stairs, and swimming. So physical activity is a key ingredient in healthy aging because it is a critical strategy in increasing health span because it can effectively prevent chronic non-communicable diseases such as diabetes, cardiovascular disease, and dementia. Exercise is a subtype of physical activity that has a specific parameters and is done with the intention of improving or maintaining physical or health outcomes. Reducing physical inactivity by 25% could prevent 1 million cases of dementia annually worldwide. Furthermore, physical activities is a first-line secondary prevention strategy in osteoarthritis, which affects 33% of men, 40% of women over age 65 in Canada. Yet nearly a third of adults in developed countries are physically inactive. Fall prevention is an area in which physiotherapists have played a key role in promoting healthy aging. Ample evidence indicates that OTICO exercise program, a home-based strength and balance exercise training program that physiotherapists can deliver, is effective in the primary and secondary prevention of falls. Furthermore, regular exercises have positive benefits on mood and its dimension, including self-esteem, self-efficacy, mental health, and positive mood. Physical activity often triggers positive behavior changes in the aging people by making them more active, independent, and enjoying their life. So what is the ideal amount of exercise? According to Department of Health, it recommends 150 minutes of moderately strenuous physical activity per week and 30 minutes of activity per day, at least 5 days a week. This is about a normal criteria, like how we can promote healthy aging in a population who are not diagnosed with any chronic illnesses, but how to manage and support healthy lifestyle in patients who are already diagnosed with chronic illnesses. So let's understand this by considering the case study scenario. So a patient is a 50-year-old librarian who lives with 55-year-old husband. Her hobby is to be an active volunteer in the local church, flower arranging and visiting older members of congregation. Her journey started in March 2022 when she became worried because she was having problems turning in bed at night. Even her husband noticed that she wasn't walking well and slowed down recently. Over the next few weeks, she noticed that her right hand was shaking when she was resting in armchair. She consulted neurologist and was diagnosed with Parkinson's disease. In December, she encountered fall whilst in the garden, and on further diagnosis, she scored mild frail on clinical frailty scale. So question to healthcare professionals: how can we help patients? What does good care and support look like? How do we integrate teamwork to treat such patients? So asking patient what she actually wants. So she wants prevention of fall and balance issues, on-call hospital service at home, and she wants thorough care and support from team. So considering patient's journey, in 2017, NHS proposed one model which includes involve, assess, respond, and care. So in this one, we need to involve people, carer, and family, consider patient's choice, assess the care, and provide a specific tailored support to patients with supportive self-management for falls, immobility, polypharmacy, and mental health, and connect the patient to community and plan support and care for her. Thus, to implement the formal protocol, adherence to the treatment plays a very important role because it helps in improving health outcome for the patient who requires prolonged medical attention and suffering from chronic condition. However, increasing percentages of non-adherence has been a concern and is associated with adverse health outcome, increased morbidity and mortality rate, and increased healthcare costs. Therefore, before considering the role of physiotherapists and healthcare professional in healthy aging, we need to evaluate the factor non-adherence which can affect this. Non-adherence to treatment in healthcare has cost the NHS an estimated £300 million. Furthermore, over 50% of patients are non-compliant to take prescribed medicines for a duration of time, thereby not experiencing beneficial effects of the therapy or treatment, which ultimately results in unnecessary complication or cost and leading to poor health outcomes. One of the effective ways to tackle the increasing burden of healthcare cost is to invest a fraction of healthcare cost into patients' adherence plan, compliance program, and intervention strategies. Ways to adhere patients to treatment protocol. According to these authors, there is no single intervention strategy that can help to improve collaboration of patients to rehab pathway. Moreover, decades of research study agree that successful attempts to improve patient adherence depends upon a set of key factors, which includes realistic assessment of patient knowledge, understanding of regime, effective and clear communication between patients and their health professionals, building of trust in the therapeutic relationships. Therefore, an opportunity needs to be given to the patient to explain their symptoms and problem which is affecting their functions in daily life. Knowing patient's perspective as a person helps healthcare professionals to understand factors that are crucial to their patient's adherence beliefs, their attitudes, subjective norms, cultural context, social support, and emotional health changes. Thus, providing triage and integrated care is the role and responsibility of the multidisciplinary team to encourage and support healthy aging and delays the consequence of it. However, there are certain barriers to implement MDT multidisciplinary team into practice. Thus, to overcome this barrier, authors have suggested that professionals from different backgrounds are invited for team meeting as well as communication between medical specialists and other professionals should be promoted. Thus, overall, the assessment and treatment by MDT plays a crucial role in making patients independent in their activities of daily living in order to support and promote healthy aging. So, conclusion, biopsychosocial model of care plays a very crucial role in overall well-being of aging population. Overall support and care from healthcare professionals leads to increasing or maintaining patients' functional independence and delays the consequences of developing chronic diseases and disabilities. Thank you.
Yes. Any questions to Dr. Urvisha? This is a presentation from Dr. Urvisha. Any questions? Just if you have any kind of questions, you can text in chat box. We'll be asking behalf of you, even after the completion of the Congress. Yes, thank you so much, madam, for joining this event.
No worries. Thank you, Kevin, for giving this opportunity. I highly appreciate it.
Yes.
It's amazing.
Unfortunately, you missed the face-to-face meeting yesterday.
I know. I wanted to come face to face because I'm very near to Paris, but couldn't able to manage it. Probably next year.
Yes, no, definitely, madam. Just we'll be expecting your presentation new topic with new topic in face-to-face meeting.
Yeah, sure, of course. Yeah. Thank you, Kevin. Thank you, everyone, for listening this presentation. I highly appreciate.
Yes. Next, we ask Dr. J. Arun Joseph Arun from KG College of Physiotherapy from India. The topic will be efficacy of multimodal exercise from cancer-related fatigue, a meta-analysis. Yes, sir. You can go ahead by sharing your slide. Hello, Dr. Joseph Arun. Yes, sir. Hello, sir. We are not audible your voice. Hello, sir. We are not audible your voice. Hello, sir. We asked you. We are not audible your voice. We asked Dr. So next, we asked Dr. Elizabeth Romova from MIT University of Skopje, from Republic of North Macedonia. Yes, madam, if you are ready with your PowerPoint presentation, you will start sharing your slide. If you are okay with sharing your slide, you can start sharing your slide. Actually, we are 1 hour ahead of actual program. So if any of you are ready with the PowerPoint presentation, you can start sharing. Okay. Sir, actually, we are not audible your voice, sir. Just to make settings in your make some settings. Hello. Hello. Sir, we are not audible your voice. We request you to unmute yourself. So, or else we'll go with alternate speaker. That is Dr. Anadi Mathur Al-Hatri from King Saudi Medical City from Saudi Arabia. The topic will be association between cognitive and motor dysfunction in the patient with multisclerosis. Yes, madam, you can start sharing your slide.
Good afternoon, everybody.
Yes, thank you so much.
Okay. Good afternoon, everybody, and welcome to my presentation. My name is Hanad Al-Harti, and I am a physical therapist at King Saud University. The topic of my presentation is association between cognitive impairment and motor dysfunction among patients with multiple sclerosis. I would like to begin with the introduction. Let's start with the definition of multiple sclerosis. It is an inflammatory immune-mediated disease affecting the central nervous system, and it is common in young adults, in females more than males, approximately 2 to 1 around the world, including Saudi Arabia. Prevalence of multiple sclerosis, it affects about 2.8 million people worldwide, and about 40.4 per 100,000 in 2018 at KSA. Clinical manifestations of multiple sclerosis. The neurodegenerative nature of the disease contributes to various signs and symptoms that result from sensory, motor, and autonomic dysfunctions. Motor and cognitive problems are the most common primary symptoms in patients with multiple sclerosis that negatively impact their quality of life. Motor dysfunctions, motor symptoms include mobility problems and muscle weakness, spasticity in coordination, and balance dysfunction. Muscle weakness is the most prevalent complaint among multiple sclerosis and occurs in approximately 88% during the course of the disease. About 41% of patients with multiple sclerosis have walking difficulties that increase the full risk and affect their daily living. The prevalence of cognitive impairment is ranging between 43% to 70% in patients with multiple sclerosis. The most affected domains of cognition are executive function, attention, memory, and information processing. Both motor and cognitive functions are controlled by brain areas such as frontal lobe, cerebellum, and basal ganglia. Motor actions implicitly involve various integrated cognitive functions that allow successful motor performance. Statement of research problem. While most studies focus on cognitive impairment as a predictor of the risk of fall, walking speed, gait variability, and postural control, it remains unclear whether muscle strength, motor coordination, balance, gait, and/or risk of fall can be considered as predictors of cognitive impairment in adults with multiple sclerosis. Aims of this study. First aim is to investigate the association between cognitive impairment and muscle weakness, motor incoordination, poor balance, gait abnormality, and high risk of fall in patients with multiple sclerosis. The second aim is to examine if any of these variables can be adopted as the best indicator of cognitive impairment in patients with multiple sclerosis. Significance of the study to understand the relationship between motor and cognitive impairment, which is crucial to design appropriate treatment plans that consider the patient's unique symptom profile and that provides holistic care relevant to the success of physical therapy. Now let's move to the methods. Study design is a cross-sectional study. Participants, a total of 70 patients with multiple sclerosis. Sample size was estimated based on the G-Power3 analysis program. Inclusion criteria, age between 18 to 65 years, both genders, male and females. Diagnosis, multiple sclerosis regardless the type, able to read and write, patients who are able to walk with or without assistive device. Exclusion criteria were patients with communication difficulties, severe muscle weakness and spasticity, visual and hearing impairments, individuals with other neurological disease rather than multiple sclerosis, individuals with a history of psychiatric illnesses. Outcome measures for cognitive assessment, I used Montreal Cognitive Assessment Scale, Arabic version. For muscle strength, hand grip dynamometer for the hand grip strength and handheld dynamometer for knee extension strength. Motor coordination, I used timed alternate heel to knee test for the lower extremity and timed rapid alternating movement for the upper extremity. For balance, gait, and risk of fall, I used Tinnitus Performance Oriented Mobility Assessment Scale. Ethical considerations, ethical approvals were obtained from Health Sciences Institutional Review Board at King Saud University and Sultan bin Abdulaziz Humanitarian City area, and the consent form was filled by the participants. Data was collected by trained physical therapists. Screening sheet was used for eligibility and together participants' demographic data. For data management and analysis, all statistical analysis was performed by using SPSS. Participants' characteristics were presented by descriptive analysis. Correlation coefficient test was used to assess the correlation between MoCA and motor variables. Correlation coefficient test was used to assess the correlation between MoCA domains and all motor variables. Motor variables that significantly correlated with MoCA were used in a multiple linear regression. All data were expressed as mean and standard deviation p-value was less than 0.05 with 95% of confidence interval. Results, subjects and demographic data. This table illustrated the subjects and demographic data of participants. We have here 88.6% were right-handed, 78.6% were female, 92.9% had relapse-remitting multiple sclerosis. The age at onset of symptoms was about 26. Disease duration about 10 years. 47% were normal body mass index. 65.7% hold bachelor degree. This chart illustrated the percentages of MoCA levels. As we see, 27.1% have normal cognitive function. About 67.1% have mild cognitive impairment, and 5.7% have moderate cognitive impairment. This chart illustrated the affected MoCA domains. As we see here, memory was the most affected domain, about 84.3%. Followed by executive function and visuospatial skills, 74 and 71.4% respectively. And language was the least affected domain, about 26%. This table illustrated the correlation between MoCA and motor variables. As we see here, muscle strength was not correlated with MoCA. Coordination variables, supination and pronation and heel to knee test were correlated with the MoCA variable. Balance, gait, and risk of fall were significantly have a positive moderate correlation with cognitive function. Multiple linear regression, motor variables which reveal significant correlation with MoCA were used in multiple linear regression to determine the predictor variables. Balance and gait were excluded from linear regression because they showed high correlation with each other. Muscle strength of hand grip and knee extension were excluded because they showed no significant correlation with MoCA. Risk of fall, upper and lower limbs coordination variables were entered in the regression analysis as independent variables, and MoCA was entered as a dependent variable. Using stepwise method, a significant first model emerged with an R-square of 0.172. In model 2, also 22.7% of the variance in MoCA was predictable from the risk of fall and coordination of upper extremity. This is the statistical equation that describes the best fit of the regression line, which means a 1 unit increase in a total POMA score increased the MoCA score by 0.147, which was significantly associated with MoCA. In addition, a 1 unit increase in the supination pronation score decreased the MoCA score by 0.539, which was also significant. This scatter plot of MoCA on the risk of fall and upper extremity coordination with regression line and 95% in individual confidence interval. Now let's move to discussion part. The analysis showed that cognitive impairment is significantly associated with motor incoordination of the upper and lower extremities, balance deficits, gait abnormalities, and risk of fall. The result confirmed that the mean total MoCA score indicated mild cognitive impairment and in about 2/3 of patients with cognitive impairment, consistent with previous studies. We found that memory, visual spatial skills, executive functions, attention, and language were affected domains among patients who had cognitive impairment, which is in line with previous studies. Regarding muscle strength and cognitive impairment, similar to other studies, there was no correlation between hand grip strength and cognitive impairment as measured by the total MoCA score. But there was a significant correlation between hand grip strength and the language and attention domains. This study found no correlation between lower extremity strength and cognitive impairment, whilst a recent study found a positive low correlation between cognitive impairment and the extension strength in the MS individuals. Valentino et al. In 2009 reported that relapse-remitting multiple sclerosis patients with cerebellar symptoms exhibit poor performance on attention and verbal fluency tests than relapse-remitting multiple sclerosis patients without cerebellar symptoms, which is in line with our results. Our findings show that a balanced component of POMA has shown a significant moderate correlation with cognitive impairment. In 2017, Pirochon et al. Found that working memory, attention, and executive functions were associated with postural control in the upright position with an unstable platform among MS patients. G-POMA scale was significantly correlated with cognitive impairment, consistent with previous studies demonstrating a significant association between gait abnormalities and cognitive decline in people with MS. It is interesting to know that no study used POMA gait scale for the assessment of gait and its correlation with cognition in MS individuals. The findings of the study show that risk of fall has a significant correlation with a cognitive impairment and predicted cognitive impairment in patients with multiple sclerosis, which is in line with previous studies. Fall frequency has been shown to be significantly correlated with general intelligence, processing speed, and executive functioning, while verbal memory was found to be a significant predictor of falls in patients with MS. Limitations and implications. Sample size is small and further studies are required with a larger sample size. Most of participants had relapse-remitting multiple sclerosis, and future studies should involve all MS subtypes. The POMA gait scale used in this study is based on the examiner's observation. Therefore, future studies using advanced gait analysis systems are now needed to better detect temporal and visual spatial parameters. Conclusion: to sum up, cognitive impairment is significantly associated with motor incoordination, poor balance, gait abnormalities, and increased fall risk. The fall risk and upper extremity incoordination were the best indicators of cognitive impairment in patients with multiple sclerosis. Thus, motor assessment can provide physical therapists with clues about the presence of cognitive impairment in patients with multiple sclerosis. In addition, incorporating coordination and balance training into the rehabilitation program may enhance cognitive functions in patients with multiple sclerosis, although this requires empirical testing. Thank you for your listening, and I would like to acknowledge and thank King Salman Center for Disability Research, Sultan bin Abdulaziz Humanitarian City, King Saud University, and King Saud University Medical City, Saad and Mu'in team societies, and all multiple sclerosis patients who participated in the studies. Thank you, and I would be happy to answer your questions.
Yes. Any questions for Dr. Anadi? Any questions? If you have any questions related to the topic, you can text in this chat box. Will be asked on behalf of you, even after the completion of the Congress. Yes, thank you so much, madam, for joining this event.
And thank you.
Yes, it was a nice presentation. Hope we expect you face-to-face meeting next year if everything goes well in 2024. And we request Dr. J. Harun Joseph Farun from KG College of Physiotherapy. So do one thing, just you can start sharing your slide in from laptop and your audio from the mobile. If you are confusing, you can start sharing your slide from the laptop. Hello. So do you hear me? Hello, sir.
I am here only, sir. I am trying to share.
Okay, no problem.
Able to view, sir?
It's fine, sir.
You are able to.
Yes.
Good afternoon, sir. First, initially, I used to thank the Inovine Scientific Committee for giving me chance to participate in this presentation. My topic is efficacy of multimodal exercise on cancer-related fatigue meta-analysis. Myself, Arun Joseph Farun, research scholar from KG College of Physiotherapy, Coimbatore, Tamil Nadu. The keywords related to this topic are cancer survivor, cancer fatigue, brief fatigue inventory, aerobic exercise, and meta-analysis. The authors declare that they have no competing interests. Cancer-related fatigue is defined by the National Comprehensive Cancer Network as a distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness related to cancer or cancer treatment that is not proposal to recent activity and interferes with usual functioning. Cancer-related fatigue is the most common and distressing symptom in cancer survivors. Cancer-related fatigue is different from tiredness, which is usually short-term, and patients feel better after they stop, sleep, or rest. Cancer fatigue doesn't usually go away with sleep or rest. It can be severe and last a long time. Fatigue can last for different amounts of time, depending on what causing it. Approximately 40 to 80% of cancer patients who are undergoing active treatment suffer from cancer-related fatigue. Exercise improves the overall quality of life and cancer-related fatigue. However, the specific effects of the training modalities are not well understood. The need of the study to address a common problem. Cancer-related fatigue is a prevalent and distressing symptom experienced by many cancer patients undergoing treatment. Can significantly impact their quality of life and daily functions. Exploring interventions such as multimodal exercises, the researchers thought that it can effectively manage cancer-related fatigue, which is essential to improve the patient outcomes. Existing evidence is limited. There is some research suggesting that exercise interventions can help alleviate cancer-related fatigue. The current body of evidence is still relatively limited and inconclusive. Conducting a meta-analysis, the researchers thought that it would provide a comprehensive review of the available studies and help establish a more robust understanding of the efficacy of multimodal exercises. Evaluating multimodal approaches. Multimodal exercises typically involves a combination of different exercise modalities, such as aerobic exercise, resistance training, and mind body exercises like yoga types. However, the specific combination of optimal doses of these modalities for managing cancer-related fatigue remain uncertain. Hence, the researcher thought that a meta-analysis can help identify which multimodal exercise interventions are most effective in reducing the fatigue levels.
Excuse me, sir. Sir.
Yes, sir.
Sir, we are just to start sharing your slides, sir. You are kept on first slide only. You need to start sharing the slide. You need to change the slide, then only. On which slide you are showing, just you can start delivering your talk. We are seeing since last 5 minutes, we are seeing only first slide. Yeah, it's fine.
Is it changing, sir?
Yes, it's fine, sir.
The need of the study is to enhance the clinical practice. If the study demonstrates the efficacy of multimodal exercises in managing cancer-related fatigue, it can inform the clinical practice guidelines and recommendations for healthcare providers. Having evidence-based guidelines will enable the healthcare professionals to provide more effective and tailored exercise prescriptions to cancer patients, helping them to better manage their fatigue and improve their overall well-being. So, conducting a meta-analysis on the efficacy of the multimodal exercise for cancer-related fatigue, the researcher thought that it would help address the limited evidence, provide insights into optimal exercise approach, and improve the clinical practice and potentially lead to cost savings. Objectives for this study are to determine the overall effect size, to assess the heterogeneity and the source of variation, to identify the optimal exercise modalities, and to investigate the subgroup effects. Along with that, to evaluate publication bias and to provide recommendations for clinical practice. By addressing these objectives, a meta-analysis on the efficacy of multimodal exercise for cancer-related fatigue can provide valuable insights into the effectiveness of this intervention and inform clinical decision-making and future research directions. This meta-analysis was conducted to determine the effectiveness of multimodal exercise interventions on cancer-related fatigue. Databases of PubMed, Google Scholar, ResearchGate, along with other great literature were searched between 2008 and 2021 to retrieve the randomized controlled trials. Studies with the randomized controlled trial were included in the analysis. Cancer survivors with cancer-related fatigue were included in the study, and the participants in the experimental group were in different types of exercise like aerobic exercise, progressive resisted exercise, Tai Chi, and yoga. And the participants in the control group were in routine care. Studies comparing experimental group and control group were included in the analysis. And our primary endpoint was cancer-specific fatigue, which was measured by brief fatigue inventory. Researchers used the random effect model to estimate the pooled mean difference, and 95% confidence interval between the study group and the control group was set, and heterogeneity was evaluated by chi-square of heterogeneity and I-squared statistics. Researchers considered a p-value of less than 0.10, the chi-square test, as an indication of significant heterogeneity, while I-squared was used to quantify the degree of heterogeneity ranging from 0 to 100%. Researchers tested for publication bias using a Gauss test and by visually inspecting the funnel plots. A p-value of less than 0.10 with a Gauss test was considered as an indication of potential publication bias. Sensitivity analysis were conducted to test whether the overall association was explained by a study with an intervention. The researcher included 10 studies in this meta-analysis, and pooled sample size intervention was 728 in the intervention group, and it was 594 in the control group. Researchers have found heterogeneity among studies. The I-squared is equal to 93%. Hence, the researcher concluded the meta findings with the random effect model. The pooled standardized difference was 0.02 with 95% confidence interval of 0.48 to 0.45, which indicates there is no difference between study group and control group in order to reduce fatigue. These are the results. Funnel plot showed symmetry, and hence there is no publication bias. Additionally, the researcher used Edgar's method to test the publication bias, and the p-value is 0.987, which is more than 0.10, which indicates there is no publication bias with included studies. This is the funnel plot which was followed out of the study. This is the result of the sensitivity analysis. And in this overview, researchers assessed the methodology and the evidence quality of the included randomized controlled trial, and additional meta-analysis were performed for the 10 reviews to review the effects of exercise on the cancer-related fatigue in cancer patients. Findings from this study suggested that there is no much difference between exercise group and control group in alleviating fatigue in cancer patients. But based on the individual studies, exercise could be introduced as an effective intervention for cancer-related fatigue management in cancer patients. For exercise group, the referred study findings suggested that aerobic exercise and yoga are commonly recommended as a promising approach to improve the cancer-related fatigue, which is consistent with the CJAM study indicating that yoga can relieve patients' tension and anxiety and help decrease their fatigue. Yoga is a convenient, easy to practice, and a safe exercise modality. It has been recommended as grade 1 evidence by the US National Comprehensive Cancer Network guidelines. Researchers' study findings showed that exercising more than 3 times per week for 30 to 60 minutes per session was beneficial for cancer-related fatigue alleviation. And the included randomized control trial also indicated that patients should be encouraged to participate in a supervised exercise and conditions permitted, which might lead to a better cancer-related fatigue outcome. For future studies, a list of excluded studies should be provided as an independent appendix to journals to facilitate readers' understanding of the data selection process and further improve the reliability of the review findings. To achieve a comprehensive literature search, future systematic reviews are suggested to identify potential studies by searching not only the commonly used databases, but also lay literature retrieval websites to minimize the publication bias. And in order to further improve the level of evidence of the included systematic reviews, more original studies with rigorous study designs and detailed descriptions of the intervention protocols are necessary. The main limitation of the study is that the number of trials was small, and the trials included in the review have different time frames, and there is a need for a randomized controlled trial of better quality in this field. Furthermore, most patients in researchers' sample are early cancer survivors, and it is unclear if researchers' recommendations for exercise are valid for long-term cancer survivors. Research with the long-term survivors and longer follow-up is clearly needed. Exercise has a moderate effect on reducing fatigue compared with controlled interventions. Exercise also improves depression and sleep disturbance. Type of exercise did not significantly influence the effect on fatigue, and the results of major studies suggest that exercise is effective for the management of cancer-related fatigue. Different types of interventions did not significantly influence the effect on fatigue, And this analysis revealed that there was no much improvement in fatigue for cancer patients. This is and further research is warranted to examine the effect of exercise intervention with more homogeneous samples of cancer patients. In future, apart from fatigue, other outcome measures like depression, quality of life can be considered, and the observed heterogeneity in reporting procedures leads researchers to recommend that further clinical trials be conducted in a more uniform way in order to achieve strong consensus about the effects of exercise training for overcoming fatigue in cancer survivors. These are my references. Thank you, sir.
Yes. This was a presentation from Dr. Arun Joseph Arun. Any questions related to this topic? Any questions? Thank you so much, sir, for joining this event. It was a nice presentation. And we'll be getting the participation certificate along with booklet within a couple of days after the completion of the Congress. And we request you to join for next year, 2024, face-to-face meeting that is going to happen in Europe or USA. Thank you so much, sir. Just you can, yes, just you can unmute yourself. We are getting some more sound from your system. And we request Dr. Steve, the keynote speaker of the Congress, and keynote speaker Dr. Steve Bailey from Steve Bailey Acupuncture of CPD Academy from UK. The title will be Effects of Acupuncture of Enhancing Muscle Strength, a Systematic Review.
Press on mute.
Hello.
Okay. How do I go about sharing my screen?
Yeah, sir, that's right.
So just share my screen. Okay, hopefully everybody can hear me. My name's Steve Bailey. I'm a chartered physiotherapist, practicing podiatrist and acupuncture practitioner. I generally utilize acupuncture mainly on a rehabilitation basis and also to enhance sports performance, primarily in athletes. So one of the key areas that I have utilized acupuncture and done quite a lot of research is enhancing muscle strength. So what I'd like to present to you today is a systematic review in which I undertook looking at the use of acupuncture to enhance muscle strength. So mainly it was to investigate the use of acupuncture enhancing muscle strength primarily in humans. We looked at the database from conception right the way through to 2021. The risk of bias was undertaken by myself and a colleague, and we mainly used what you call the Pedro scale to assess the methodological qualities of each of the studies. Now, the standards for reporting intervention in clinical trials of acupuncture, better known as the stricter, was used mainly to look at the acupuncture intervention. And this is where we found a lot of the drawbacks in many of the studies that was actually included, because many of the studies didn't actually utilize the stricter. Now, the inclusion criteria was mainly looking at any study that actually looked at acupuncture enhancing muscle strength. There was no language restriction that was actually in place. Any studies that we actually found that was in a different language, we looked to get them translated. Now, published and unpublished randomized controlled trials was actually included as long as it was in English. But however, if it was a single controlled trial looking at a case study, or it was just a clinical controlled trial, particularly if it didn't utilize humans, they was actually excluded. And again, it was only studies that actually utilized classical acupuncture points. Now, the characteristics of the studies, mainly from 2000 and 2001 was when each of the studies was published, mainly involved 737 participants with an age range of 17 to 85 in age. Majority of studies had 30 or more participants, otherwise it ranged between 17 and 73. Now, what we basically find is the majority of studies was actually single treatment sessions, which did pose a problem because most studies indicate that for acupuncture to be effective, it does need to be multiple sessions, particularly if you're looking at treating depression or something like that. Normally what you tend to see is more of a clinical effect after around about 6 to 8 sessions. Now, 7 studies applied several treatments, which range between 2 days up to 8 days. Now, there was the key one, 6 studies didn't actually state what gender they're actually utilized, but however, overall, majority of participants was male as opposed to female. 7 studies use healthy subjects, but however, there was a number of studies that use post-stroke patients or patients suffering from sarcopenia. Now, 8 studies compared the effects of acupuncture with a control group. 9 studies compared the effects of acupuncture with a control and a sham intervention. 3 studies compared the effects of acupuncture with just purely a sham group in itself. So that brings us on to the quality of the actual study. Now, as I said, we use a PEDRO. Anything that scored below 5 was classified as low. Anything that scored above 5 was classified as high. Overall, the results from the studies, majority of them scored moderate to high. The main drawbacks, which you're going to find in quite a few acupuncture studies, is going to be blinding of participants, blinding of the therapist, and also blinding of the assessor. So they were the key drawbacks that we actually found once we was looking at the methodology that was actually undertaken. Now, the biggest drawbacks within the studies was the actual acupuncture intervention itself. None of the studies actually claim that they actually utilise the stricter. And the biggest thing that we're actually finding is the majority of studies was the choice of points. Now, there are key points that are known to enhance muscle strength, and many studies didn't even consider utilising those points, and also the justification for those points. Number of points that was actually used, there was a study that only used 1 point. And again, it's been demonstrated that for acupuncture to be effective, several points need to be combined in order to get an effective overall result. The frequency and number of treatment sessions, as we mentioned before, many studies or majority of studies only used a single treatment sessions, and acupuncture assessed immediately after the actual treatment session itself. So that does pose an effect in there. Now, if you look at a study by Zane and Sosa, they chose points based on their location. The location that they were actually choosing are points that's actually located within the muscle under investigation. Now, if you're using the sham points, that's also in the same muscle, then they have been known techniques to enhance muscle strength. So in other words, using a sham technique, which isn't necessarily a sham, it is a known technique to improve muscle strength on a short-term basis. Hubska chose points based on their earlier study, and Damasceno analysed the effects of tonification points. Again, I've not found any literature that has demonstrated tonification points to be effective in enhancing muscle strength. Now, it has been pointed out by Birch that if you're going to do any kind of study, it is important, particularly if you're looking at a sham intervention, to assess that sham intervention to ensure that it's going to be inert in its effect. So if you look at a study by Tuff, for example, they actually chose points, classical acupuncture points, based on their segmental innervation and not necessarily on their effect on enhancing muscle strength. But however, the sham points was also located in the same innervation. So again, it was no surprise that there was no difference in the treatment outcome between the true acupuncture and the sham acupuncture, purely based on the choice of sham and also the classical acupuncture points. What they would actually find is even both groups would actually find an improvement in muscle strength. It will be the effect that they'll actually be doing is the post-activation performance enhancement, which has been demonstrated in a number of studies that if you needle directly into the muscle, then you'll get a delayed effect of around about 10 minutes, but then the effect of enhancing the muscle strength would last for around about 30 minutes once it actually comes into effect. 2 other studies did pretty much the same, was to utilize classical acupuncture points located in the muscle, but also using sham points located in the same muscle. And again, there was also utilizing electroacupuncture at 40 hertz. So again, 40 hertz has been demonstrated. You stimulate a muscle at 40 hertz, you will find an improvement in muscle performance. So again, it's a technique that's used for rehabilitation. So therefore, you can't classify it as a true sham effect. Coming on to the delay, if we look at the overall studies, what we're finding is many of the studies, at least 13 studies, actually assess the effect of acupuncture immediately following the acupuncture intervention. Now, I've utilized acupuncture on many athletes to enhance performance, particularly prior to an event. So if I was to utilize it on the day, I would ensure that I apply the acupuncture at least an hour prior to the event to ensure that by the time the participant was to partake in the event, then the acupuncture will have sufficient time to take effect. It has been demonstrated by Price and colleague that if you're looking at pain, it can take up to an hour before acupuncture starts to have an effect. And that once it starts to have an effect, it will last anything between 10 and 14 days. Previous study in which I undertook looking at delayed onset muscle soreness, what we basically found that there was a delay effect in acupuncture, and he saw the peak effect of acupuncture was anything between 48 and 72 hours. So these are some of the key drawbacks that we was actually finding based on some of the techniques and sham techniques that was actually employed. Wang et al., if you look at the, they demonstrated the delayed technique in 2 studies where they utilized acupuncture, chose classical acupuncture points based on the muscles surrounding the shoulder. And following needling that, what they basically found was there was a 10-minute delay before they started to see any effect of acupuncture. Once the acupuncture had in its effect, that lasted anything between 23 and 33 minutes. So just purely from that study alone, you can see that there's a delay in the effect. So if you assess the effect immediately after, then you may well get a false negative in the results in itself. One of the other key drawbacks that we found was a loss to follow-up. One particular study by Damasceno, where they started off with 53 subjects and ended up with 26. So their methodology should have been tested in a pilot study before they went out and did the main study to ensure to reduce the number of loss to follow-up. So if we look at the overall results that was actually presented, just bearing some of what I've just gone through in mind, based on some of the techniques that was actually employed and some of the sham techniques that was employed. Overall, 17 studies compared the effects of acupuncture with control group and show that 12 of the studies found that acupuncture was significantly more effective than the control. 12 studies compared the effects of acupuncture with sham. Out of those 12, 7 studies found that acupuncture was significantly more effective than the sham acupuncture. 5 studies found no significant difference between the acupuncture and the sham intervention. If you was to actually, those of you who's actually employing acupuncture, if you want to go and utilize acupuncture to enhance muscle strength, there is numerous literature that will demonstrate that stomach 36 is the main point for achieving that goal. Stomach 36, if you was to put the head into a functional MRI scan and needle that point, what you'll basically find, it will have a direct effect on the somatosensory cortex and also on the motor cortex. And that's one of the key effects that stomach 36 will actually have. In addition to that, that particular point has been demonstrated in a number of studies to release 2 components into the blood that has a direct effect on mitochondrial cells. So if you start to look at stomach 36, you stimulate that, it releases carnitine and glucothione, and they will have the effect they will have on the mitochondrial cells is it makes it more permeable to the uptake of glucose. Once the glucose is into mitochondrial cells, it allows it to burn it more efficiently. In other words, it's more or less taking the muscle and making it more eco-friendly and allowing it to work harder, longer, reduce the number of the amount of lactate buildup, and also reduce the number of free radicals within the muscles. So that's one of the key effects. It has been demonstrated in a number of studies to actually achieve that. So if we start to look at the overall results, we can find that majority of studies that looked at the upper body they was the ones that failed to use stomach 36 within those studies. Only maybe one or two actually utilized stomach 36. But however, the overall findings, 2 studies found no significant difference between the acupuncture intervention and the sham intervention. Only 1 study found acupuncture to be more effective. Effects of acupuncture on the wrist, both studies found no significant difference, but again, you need to look at what these studies have actually done, where they've either only used 1 or 2 points. And again, the points that they've actually chosen are not points to be known points to enhance muscle strength. They're mainly chosen because they're actually located in the muscle, but then the sham points are located in the same muscle. So it's no surprise, there's no difference there. Hand grip strength, again, 2 studies. One showed a significant difference in favor of acupuncture. The other one found no significant difference. But again, if you look more closely at the studies, the one by Damasceno started off with 26 subjects, 53 subjects, and finished off with 26. The majority of them actually dropped out of the actual study. Same again, no justification given for choice of points. However, the one that did show a positive outcome chose stomach 36 and gallbladder 34, mainly based on their effects of muscle and tendon strength. So if you look at the effects of acupuncture and trapezius, overall, there's only 1 study, so we can't make a true comparison. More studies would actually need to be done, but overall, what we basically find is a significant difference there. Once we look at the rectus femoris and the effect of acupuncture on the rectus femoris, you're going to find majority of these studies actually chose stomach 36 and also utilize points such as gallbladder 34. What we did find is overall, when compared to the control group, acupuncture was shown to be more effective. However, when compared to sham, only 1 study found no significant difference. Even though acupuncture score, there was an 8% in favor of acupuncture, only 5% in favor of the sham, but however, overall, there were no significant difference. So out of 6, 5 studies demonstrated that benefit. With regards to the effects on ankle dorsiflexion, what we basically find out of 6 studies, 4 found in favor of acupuncture and only 2 found no significant difference. But we did mention the study by Zhou and Ho, Huang earlier in regards to the techniques in which they actually employed, where you're finding both the true acupuncture points and the classical acupuncture points was also located in the same muscle that was under investigation. So based on that, if we look at the conclusion, the overall finding indicates that there is strong evidence that supports the use of acupuncture with regards to when compared with control. However, there is inconclusive evidence that supports the use of acupuncture in enhancing muscle strength when comparing it to a sham. However, further evidence is going to be needed, particularly with regards to the sham itself and also utilizing stricter. So that's where we're going to need more studies to look at utilizing stricter in its in the actual studies. Okay, so we just come to an end. Stop share.
Yes.
Okay.
This is the presentation from Dr. Stu Bailey. Sir is joining our event since last 2 years for online presentation. Sir, we are this time for next year. We are expecting your presence as a workshop presenter for.
Okay.
Next year, we are expecting your presence in person.
Okay. Yeah.
Any questions? Any questions related to this topic? If you have any questions related to this topic, you can text in WhatsApp or chat box, or you can mail us. We'll be asking the question on behalf of you, even after the completion of the Congress. Thank you so much, sir, for your patience. It was nice.
Okay, you're welcome.
It was a nice presentation. Request you and again to join in face-to-face meeting next year. Either it may be in USA or Europe. We will let you know the new schedule of the upcoming Congress. You can join as a workshop presenter.
Yeah, that's okay.
Yes, thank you so much, sir. Have a
You're
nice
welcome. You too.
And next speaker will be another keynote speaker, Dr. Elizabeth Romowa from MIT University, Skopje from Republic of North Macedonia. You can start sharing your slide, madam. PowerPoint presentation if you are ready with your PPT.
Hi, everybody.
Yes, madam.
I was included in Alpha Clock and I listened to presentation, very nice. Special this last from Barley, Steve Barley, very nice, very support with his research. I shall make now my presentation share screen.
Yes.
It is about my experience with nutrition in rehabilitation process. I work with this in the last 15 years, and I shall explain this today. Nutrition was always been important for improving people's health and was used both during and after illness, like a special diet for disease. In our practice, using the new research, we noticed that patients who are in the rehab department can improve their physical abilities if a specific diet and supplements are included for the disease for which they came to rehabilitation. We are showing our experience. In our practice of nutrition during rehabilitation, we present several protocols that we use to improve the motor and other abilities of the musculoskeletal system as a guide in rehabilitation. We have protocols for nutrition together with rehabilitation. We follow disease. We have for more disease, but today I shall present for 7 disease. Osteoporotic patient with degenerative joint disease, children with spinal deformities, stroke survivors, patient with Parkinson disease and sclerosis multiplex, patient with sport injuries, and patient with diabetes undergoing rehabilitation from another disease. Osteoporotic patient. Assessment of the nutritional status in osteoporotic patient we make with Frank's questionnaire with our modification who included assessment of nutrition and physical activity. Assessment of nutrition is consisting from positive and negative nutrition habits, daily consumption of products rich of calcium and D vitamins. Assessment of bone mass, assessment of daily and week physical activity. Physical therapy was included from physical procedures that stimulate bone mass, like low-level laser and magnetic field, and exercise program to increase bone mass. Herbal supplement, including turmeric and ashwagandha, who increase bone mass. In these pictures, for a management of osteoporotic patient, we can see that all in the world, worldwide, the people use physical activity and nutrition therapy to increase bone mass by patient with osteoporosis. Patient with degenerative joint disease. We first assess the bone mass index. Increased body weight is a risk for congressive joint loading. Educational program for reduced body weight with diet and physical activity. Physical procedures with analgesic and trophy effect, aquatic and exercise therapy was included. Diet contains intake of collagen with nutrition, herbal supplements, and with supplements and herbal therapy with analgesic effect locally on skin or oral, like turmeric, ginger, capsaicin, arnica, and Schnell extract, and also Boswellia serrata. Here we can see the positive effects of Boswellia serrata for joint disease. Children with spinal deformities. Children and adolescents with scoliosis have a lower bone mass with biomechanically unequal load on the spine. The treatment is complex and multidimensional, lead from a spine specialist. Children with postural deformities can increase their curve by 50% in 6 months during rapid growth. Bone mass is built with proper nutrition and physical activity in the period up to the age of 21. The assessment of food intake rich in calcium, vitamins, and adequate physical activity will give a healthy bone mass, which is less prone to external pressures and deformities. In this picture, left side, we can see that feeding problems and micronutrient deficit and osteopenia are one of the external factors for to become children with bad posture or spine deformity. In some studies, research find that increased values of zinc and copper and decreased levels of selenium were found in children with adolescent idiopathic scoliosis. In our personal experience, I always access the nutrition and physical activity postural bed by children with postural bed position in front of the video terminals and cells by a child with a deformity, also postural or structural. I always make assessment of nutrition. Patient after stroke. In post-stroke patient, correcting the diet by reducing saturated fats, refined sugars, and sodium is part of a healthy lifestyle. When patient ongoing on the therapy, we should also pay attention, anticoagulant therapy, we should also pay attention to foods that reduce or increase coagulation. Nutrition with fruits and vegetables or Mediterranean diet decrease blood pressure. Food rich in vitamin C, A, potassium and magnesium and polyphenols can mobilize calcium from calcified blood vessels. To improve the physical performance of muscles contraction in elderly people, supplements like creatine, L-carnitine, and coenzyme Q-decis is necessary. Building strong muscles must with protein food, vitamin C, B12 and B9 and enough iron are a requirement for improving muscle mass. Energy, mental and physical is crucial for rehabilitation. In process of this patient for rehabilitation, energy is crucial because patient with fatigue cannot make exactly exercises. It also support cognitive health and support energy production. Sarcopenia is an enemy in rehabilitation, a major obstacle to muscle strength as a factor in mobility. Reasons of sarcopenia can be a few. First, activity associated with sarcopenia is the result of prolonged bed rest, a sedentary lifestyle, or a beautification. Second, diet-related sarcopenia is the result of inadequate energy and/or protein intake. Disease-related sarcopenia results from invasion in acute disease or injury and/or cachexia in chronic disease. Age, activity, diet, and sarcopenia are disease-related and may overlap in hospitalized patient, resulting in recumbent and sarcopenia dysphagia. Here in this slide, we can see the multifactorial reasons to come sarcopenia, who is a big problem in muscle stretching, like a cruciate organ for rehabilitation. In this second picture, a slide, we can see that muscle mass and function loss can be stimulated or be the reason can be sarcopenia, and this sarcopenia in muscles must be early recognized, and make correction with some nutrition and supplements. Patients with Parkinson's disease and multiple sclerosis have a secondary iatrogenic osteoporosis, impaired balance with a high risk of falling and substantiating a fracture. In them, a diet for the treatment of osteoporosis should be applied. Calcium, mostly of plant origin, supplement of vitamin D3 in larger quantities. Food with an anti-inflammatory effect reduce pain and prevent the progression of the disease. Diet, food with a liver protective effect, alkaline in composition, and a lot of omega-3 and polyphenols. Stimulating of bone mass with physical therapy procedures should be applied. Energizing healthy food to reduce fatigue should be in the diet. Patients with Parkinson's disease and liver changes have a lack of energy, but even with this kind of liver function, the individuals must not put extreme physical strain before introducing a dietary regime to restore the function of the liver. Patient with multiple sclerosis multiplex. New research suggested that the autoimmune process that occurs in this disease is a reaction to some food or some substances still in the intestines during the resorption. This leads us to think of food as the initiator of an autoimmune reaction. Patients have iatrogenic osteoporosis, fatigue, pain of central origin, and difficulties with mobility, increasing tone and reflexes. Food and supplements are divided into following: those who will provide a good immune system, exclusion of high protein food of animal origin as a potential allergen, vitamin A, C, and D, intake of calcium from plant origin, preservation of bone mass through inhibition of osteoclast activity, is substances that will reduce fatigue. Patient after sport injuries. Health lifestyle promote physical activity. Protocol for injuries treatment is consisting of physical therapy, aqua exercises, and exercises. In the acute phase, should be consumed food that has an anti-inflammatory effect, alkaline food rich in potassium, sulfur, and magnesium. Any athletes can get injured or want to increase their physical abilities. There are a group of drugs that must not be taken because they are subject to doping control. Since ancient times, different foods and herbal extracts were used to increase psychological abilities and reduce pain. Lactic acid can be eliminated faster with juice that have basic content, lemon, pineapple, sherry, without added sugar. Hydrolyzed collagen given in a drink gave positive effects on the structure of the soft tissue. Patient with diabetes undergoing rehabilitation from another disease. During exercises, the consumption of oxygen in the whole body can increase as much as 20 times in the working muscles. To preserve the function of the central nervous system, the level of glucose in the blood is incredibly good to be maintained during exercises. Hypoglycemia during exercises rarely occurs in non-diabetic individuals. Metabolic adjustment to maintain normal glycemic during exercises are largely hormonally mediated by glucagon, catecholamines, and insulin. These hormonal adaptations are essentially lost in insulin deficit patients with type 1 diabetes. Consequently, when such individuals have too little insulin in their circulation due to inadequate therapy, excessive release of counter-insulin hormone during exercises can increase already high levels of glucose and ketones and even cause diabetic ketoacidosis. And vice versa, the presence of high levels of insulin due to exogenous administration of insulin can weaken or even prevent the increase of mobilization of glucose and other substrates caused by exercise, and hypoglycemia can occur. Similar difficulties exist in patients with type 2 diabetes on insulin or sulfonylurea therapy. However, hypoglycemia during exercises tend to be less of a problem in this population. In patients with type 2 diabetes, exercise can improve insulin sensitivity and help lower elevated blood glucose levels into the normal range. Exercises can be a therapeutic tool in a variety of patients with or at risk of diabetes, but that, like any therapy, its effect must be thoroughly understood. Protocol is consisting of analyzing the risk and benefits of exercises in given patient, detailed medical evaluation, medicament intake, and comorbidity, carefully screen for the presence of macro and microvascular complications that may be exacerbated by the exercises program. The duration of the exercise should be 30 minutes at the beginning, starting with a 5 to 10 minutes warm-up and always ending with recovery exercises. Frequency 3 times a week. Exercise programs of low intensity and duration are considered most appropriate and safe. Subjective perception of fatigue and continually accessed throughout exercise. Other important parameters to access during an exercise session: blood glucose levels before and during exercises, type of food and pre-exercise time spent, time and point of insulin administration. It is best to be the injection to 1 hour before start with exercise. This is the references and conclusion. The inclusion of appropriate nutrition for patients in the rehabilitation process can have several benefits: better mental and physical function, reduction of fatigue and pain as a non-pharmacological intervention, improvement of muscle contraction strength and greater stability, shortening the time needing for condition or for rehabilitation. The included specific diet during rehabilitation today is proven to be effective, and its application requires special education by patient. It is not so simple. I'm a doctor of specialty of physical medicine and rehabilitation, doctor of medical science, certificate nutrition and food safe, 22 years experience. And I'm a member of Training Implementation Center in Bitola, where we have 3 times for a year educational program for rehabilitation, for nutrition and safety food, and where I participate with lectures for nutrition in rehabilitation process. That's all for me.
Yes, yes, madam.
It was clear because
Yes.
my English is not so good.
No problem, madam. Any questions? Any questions to Dr. Elizabeth regarding the topic? Regarding this topic, if you have any kind of questions, you can raise your hand and ask the questions. Even after the completion of the Congress, you can text us or you can mail us. We'll be asking the questions related to this topic even after the completion of the Congress.
If somebody like to contact me, I have noted my email. Can we write and we can collaborate?
Yes, definitely, madam. Will be. Thank you so much, madam, for your nice presentation.
Thank you.
Yes, we may expect your presence for next year in face-to-face meeting.
What?
We may expect your presence in face-to-face meeting next year.
Okay.
Yes,
I accept.
Yes, thank you so much.
Thank you for organizing committee to invite me.
Yes, thank you so much, madam. You will be getting the participation certificate along with electronic booklet within a couple of days after the completion of the Congress. Thank you so much once again. Yes, next speaker, we request Dr. Rana Al Rashid from Cardiff University of School of Healthcare Science from UK. The topic will be mixed method study, evaluating functional abilities and experience of people with the Parkinson's disease after participating in a community-based table tennis program.
Hello, everyone.
Yes, madam.
Can you see my screen?
Yes, just you can enlarge your screen.
Yes.
Yes, that's fine. Thank you, sir. You can continue.
I am Rana Rashid, a postgraduate student at Cardiff University, and I am here to present my study, which is me and my colleague Kasabari, which is a mixed method study evaluating the functional abilities and experiences of people with Parkinson's disease. After participating in a community-based table tennis program, our study is supervised by Dr. Katie Hamana in the School of Healthcare Science at Cardiff University. So first of all, I wanted to introduce the Parkinson's disease. Parkinson's disease is a progressive neurodegenerative disease, which is due to neural loss in the substantia nigra and the degenerative of the dopaminic pathway in the basal ganglia. And this neurodegenerative disease produce both motor and non-motor symptoms. And the cranial and motor symptoms was the bradykinesia, posture instability, tremor, bradykinesia, postural instability, tremor, and rigidity as well. And the prevalence of Parkinson's disease has doubled worldwide over the past 25 years, as the global estimate in 2019 revealed that over 8.5 million people suffer from the Parkinson's disease, and these motor and non-motor symptoms, especially the motor symptoms, making the patient face difficulties in their activities of daily living, and this consequently lead to the greater dependence and social isolation, which adversely impact their quality of life. And according to a lot of studies, that the optimum treatment for Parkinson's should combine both pharmacological medication and physical therapy, as some symptoms such as gait abnormalities and posture instability are resistant to medications, and the medication lose its effectiveness over time. Moreover, the exercise has a positive physiological effect, such as on Parkinson's disease, such as enhancing the antioxidant activity, reducing inflammation, enhancing the synaptogenesis, which prevent or delay the death of dopamine-producing cell, and that subsequently lead to prevent or delay the progression of the disease. In addition to that, exercise enhance motor, cognitive, and sensory abilities to help patients to function independently by improving walking skills, reduce the risk of falls, improving muscle strength, and the many social and psychological benefits for patients with Parkinson. And according to the American College of Sport and the NICE guidelines, that physical activity is safe and recommended in the management of Parkinson's disease. However, the compliance and long-term participation in these structured exercise programs is still a significant challenge for people with Parkinson due to the deteriorating symptoms of Parkinson, and also the stigma surrounding the symptoms surrounding the Parkinson. Therefore, participating in the non-traditional group fitness program in the community can encourage the prolonged adherence. And many trials have been conducted in people with Parkinson's disease, such as Tai Chi, Tango, dance, Nordic walking, boxing as well. And this trial revealed that they have physical, psychological, and social benefits after participating in these trials. The table tennis is part of the non-traditional group programs, and it has many benefits for the general population, included the improving of the eye-hand coordination, the arm strength, leg strength, core strength, as well as reflexes, and many mental and social benefits. The table tennis for Parkinson has been gaining popularity in the recent several years. However, when it comes to the research on the effect of the table tennis intervention in people with Parkinson, still the research at the initial stages. There's only 2 studies to data that confirm the safety and feasibility of table tennis intervention, and none of them explored the experiences of patients after participating in these table tennis programs. Therefore, high quality with more challenging outcome measures for the balance and functional mobility, as well as quantitative studies to explore the experiences of people and facilitators and barriers to participate in these programs. Therefore, our study aims is to evaluate the functional abilities and experiences of people with Parkinson after participating in a community-based table tennis program. So the first objective for the quantitative part is to identify whether participating in a community table tennis program improve the functional outcomes related to balance, mobility, and upper body strength for people with Parkinson. However, the second objective is for the quantitative study to identify the perceived facilitators and barriers to participation in the table tennis program. So the research method, the research design is a mixed method study, which is a quantitative and qualitative study. For the qualitative is a descriptive study. However, for the quantitative is one group pre and post design. And because this study is a collaboration between Cardiff University and Cardiff City Community Table Tennis, the recruitment was from the Cardiff City Community Table Tennis Club, and the ethical approval was received from the School of Healthcare Science Research Ethics Committee at Cardiff University. And these are our inclusion and exclusion criteria. The age must be over 18 years old, confirmed diagnosis of Parkinson, ambulatory or using assistive device. However, the exclusion criteria is unwilling, unable to provide informed consent, and unable to follow functional assessment instructions, because we need to understand our instructions during the functional assessment. And we exclude also the neurological condition other than Parkinson's disease. So for the table tennis intervention, there was a protocol for the session was followed. And in general, it includes warm-up, low agility circuit training, pattern ball exercises, and explanation of the rules of the game and how to play the game as well. And the location was the Cardiff City Community Table Tennis Club. The frequency was once a week, and it was for 1 hour for 8 weeks. So for the quantitative data collection, the assessment carried out at baseline before starting the program. Then we repeat the measurements after 8 weeks of completing the table tennis programs. And the outcome measures that used for the quantitative data was the time up and go, which measured the functional mobility and the risk of falls, in addition to the 5 times sit to stand, which measure the lower limb strength of participants, in addition to the balance control. And also we use the hand grip strength measurement by using the hand dynamometer. And finally, the activity-specific balance confidence scale, which is a self-administrated questionnaire, and it measured the balance confidence of participants in different situations, starting from within home to more challenging situations, such as walking on an icy sidewalk, ascending and descending a ramp, and this stuff. For the quantitative, it was a semi-structured individual online interviews for about 20 to 25 minutes. And for each participant, and all the outcome measures have a good interoperability in Parkinson's disease. And for the data analysis, we used the t-test and Wilcoxon sign rank test for the quantitative. However, the interviews were thematically analyzed. For the results our demographic data, that the age of the participants from 40 to 79, whereas the majority of them from 70 to 79, with a percentage of 50.5, and the gender was were more for male than female, with a percentage of 75, and the mobility level, most of them was independent in their mobility. However, 2 participant use came for mobility. And these the results for the quantitative data. For the time up and go, there is a positive improvement in the time required and positive reduction in the time required to complete the time up and go from 10.93 until 8.81. And the statistical test showed that it's a significant change. Although it's significantly changed, it doesn't reach the minimal detectable change, which is 3.5 seconds. And that because of the heterogeneous presentation of the participants, and some participants exceed the minimal detectable change. In contrast to the time up and go, the 5 times sit to stand, there is a positive reduction in the time required to complete the test from 11.176 to 10.86. However, the statistical test show that it's not statistically significant, and that might be because of the initial score of the participants of an average of 11.76, which is lower than the mean time required to complete the 5 times to sit to stand for people with Parkinson, as the some study revealed that the time required from 14 to 20 seconds, irrespective to the disease severity, and that might explain the non-significant improvement in this test. And doesn't exceed the minimal detectable change as well, which is 3.6 seconds. And similar to the 5 times sit to stand, the ABC, this intervention seemed to improve the balance confidence in terms of ABC for participants from 69.76 to 75.5. However, the statistical test showed that is not significantly changed. In spite of that, this intervention have removed the participant from the risk for range, which is as the 69 is a predictive score for recurrent fall in patient with Parkinson disease. However, that change is not significant. And for the left hand strength, it's improved from 30.62 kg to 32.45. However, the statistical test as well doesn't show a significant improvement. And clinically, some study revealed that a change as small as 0.92, it's considered to be an true improvement in the hand grip strength in people with Parkinson's disease. And for the finally, in contrast to the left hand, the right hand strength, which is the dominant hand, slightly decreased, which is unexpected. And this decrease is insignificant. However, that might be due to the neuromuscular fatigue, as the participant most of the time they use their right hand, the dominant hand, during playing, which lead to neuromuscular fatigue as the physical exertion increase, and the fatigue of the upper extremity lead to decrease in the grip strength. So that's our results for quantitative data. For the qualitative data, 5 themes were identified. First of all, the physical impact of the program. The participants reported that they improved their physical. They found that physical improvement in their general fitness, and some participants reported that they improved the hand-eye coordination, and they appreciate the involvement of upper and lower extremity in this sport. However, some participants were uncertain of the effect of the table tennis on daily functioning, owing that to the fact that it had only 8 weeks since they started playing the table tennis, and they hopeful for a future improvement. For the psychological impact of the program, a positive mental improvement found for all the participants. All of them report that they enjoy playing the table tennis. Also, they enjoy playing table tennis, and willing to attend these sessions for every week. Also, they wanted to they willing to attend it for a long term. Also, the participants reported that increased alertness while playing and increased concentration while playing, that helped them to forget about the Parkinson disease symptoms. Also, they motivated to improve their skills of playing table tennis. However, for the psychological impact of the program, some participants reported that attending the program and meeting new people was a challenge for them. When it comes to the table tennis, the third theme, that table tennis is a way to reduce social isolation. The participants report a social benefit of the program as a motivating factor to participate in these programs. And they feel that meeting people, other people with Parkinson's disease, and help them to get help them to get an ideas and about the progression of the disease and about other programs that for Parkinson's disease. And also they appreciate the meeting of the partner of the participants and support each other as a motivating factor for participation. And for the fourth sorry, I couldn't understand it. And for the fourth, sorry, I can't hear you. And before themes, inclusive and group participation, participants prefer to play with peers with shared diagnosis as they believe they understand their limitation and the mental struggles, and they hesitate to play with non-PD players because they believe they didn't understand their limitations. For the environmental aspects of the program, they think that the opportunity to include other family members and friends is an opportunity and it's motivating factor for participation. However, the lack of publicity of the program is a challenge for them. And finally, they reported that if they shift the program to the afternoon instead of evening and to have more sessions per week, it could be a recommendation for the program. Hi. Hi. Hi.
Hello.
Yeah.
Yep.
Yeah, I will continue my. So for the discussion, the TUG score improved significantly. However, the other outcome measures improved in the main values, but not statistically significant, and that is due to short intervention period. And we have motivating factors for the quantitative, such as the enjoyment and meeting other people, while the challenging was relying on others and the anxiety of meeting others with increased disease severity. And the recommendations such as pairing of pliers and organized tournaments were made by participants. Limitations of the study. Also, it's filled a gap in the literature. It has some limitations, such as that most of the participants are male and most of them older adults and the small sample size and the short intervention period. The future study to overcome this limitation should be large sample size with the participants from wider range and genders and different culture, and modifying the intervention to include more frequent sessions. And the future should consider testing whether table tennis improve the hand dexterity of people with Parkinson's disease due to the coordinated actions that developed during this intervention, and also the automation of that intervention, the table tennis, and the clinical evidence that program is feasible and safe with potential surgical benefits and could potentially be a switch from the conventional therapy. And physiotherapy should consider promoting programs such community-based programs, and the longer time frame and greater frequency of this session per week may have greater benefits, and that's need further research. We acknowledge and we thank the participants of our research, the Cardiff City Table Tennis Club, and Dr. Katie Hamana, our supervisor, for her encouragement and the School of Healthcare Science at Cardiff University. Feel free if you have any question.
Yes. Any questions? Any questions to Dr. Donna? Actually, you are supposed to be in face-to-face meeting, madam. Unfortunately, you are missed.
Sorry?
You are supposed to be face-to-face meeting yesterday.
Yeah. Thank you.
Yes. Any questions related to this topic? If you have any questions related to the just you can raise your hand or you can text in chat box. We'll be asking behalf of you. Yes, thank you so much, madam. It was nice.
Thank you.
Whereas
Yeah.
you'll be getting the participant certificate along with the booklets. We copy within a couple of days. Thank you so much. Hope we expect this conference is going to happen in USA as well as this Asia Pacific region, that's Dubai. Hope we expect your presence for this upcoming congress. Thank you so much once again. Have a nice day. Yes. Next. Next, we'll go with video presentation by Dr. Millie NG, inventor of medical technology, MCSP chartered physiotherapist from UK, registered physiotherapist of UK, Australia, and Hong Kong. We are going to play the presentation.
So let us know when you, open and close again,
Okay.
please. Yeah.
Yeah, that's good. That's a sharp needle right there, but that's good.
Yeah, let us know when you start to hear better. Open much wider. Yes.
Yes.
You hear better?
Uh-huh.
Oh, good. So
what is the scale now? 8 point something?
This is well, because we turned it down, it's I'm hearing it a little bit louder, but it's muffled.
Still.
And I'm feeling a pain.
Oh?
Nothing's too bad. It's just I'm sharing this with you because I think you might find it interesting. But I'm feeling a pain going.
Oh, it's the first time I have patient telling me that.
It's not. It's not bad.
Don't worry. Yeah, I know. But what sort of pain it is?
It's like a
dull pain or sharp pain?
It's sort of a sharp pain.
A sharp pain.
Yeah.
Oh, okay.
It's not bad.
That's interesting.
Yeah.
Yeah.
Because I didn't have that on this side.
Yeah. But do you still have the pain now?
It's going away.
Okay.
Huh?
Yeah.
Interesting.
But otherwise, do you usually have pain here?
No.
Okay. So let's continue.
Wow. That's so painful.
This is a sharp point. But is it a good point for your hearing?
It's louder. Yes, I can hear it's louder.
Okay.
Oh.
I do 5.
Oh, wow.
1, 2, 3, 4, 5. Do you still have the pain over the here?
I'm feeling it right where you're pressing, but I'm also now feeling it in the upper part of my skull. At the, if you could stick your fingers in your own throat.
As if the needle going through.
It's starting to ache back there.
Oh.
So none of this is bad. I'm fine with it. But just to let you know, I have the pain here when you're pressing. But then as we were going, it felt like it started to go across. Yeah, radiate on the inside of my mouth.
Okay.
From one side to the other. That's really interesting.
Yes, it is.
Huh.
It actually is the first time I have patient, describing this to me.
Well, maybe they don't realize that they're feeling it, but
because
I know what to look for.
Yeah, because you're a medical practitioner that you know. Okay, let's continue with the second point, okay?
Okay.
Yeah, keep open, close.
Yes, you're on it. Whoa, are you on it?
This usually is very intense. So how's it?
Sorry, I can't hear you.
Oh, okay.
Oh, that's so right on the spot.
Tell me to stop if you can't take it.
I think I can handle it a little bit longer.
Okay, let's do 5.
Okay.
1, 2, 3, 4, 5.
Oh,
okay.
Man.
Yeah.
Is that still in? Okay. Yeah, he's still talking.
Is it better? Clearer?
It's not clearer, but it's a little bit louder.
Oh, okay. So let us continue the third point, huh?
Yeah, that's a good spot.
Hearing wise?
I'm not hearing, I'm hearing the the tool.
Oh,
It's squeaking.
oh, okay, okay.
Oh.
That's an intense point.
Oh man. Okay. Oh. Let's see. No, it's louder, but it's still muffled.
Okay, let's stop. Thank you. Good. Okay.
The noise that I was listening in my head, I don't hear it in my head right now. It's just like it's coming out of my ear, very smooth.
So originally it's in the middle of your head.
Yeah, that's what
Now
it is.
it's as if it's coming out.
Yes, coming out right here in this ear.
That's
Not this
very
ear.
good.
Not the left, right
Okay.
here.
Yeah, because it's only over the right side.
Yeah.
Yeah. Okay, good.
It feels a lot better. It's a lot better. Is it fixed 100%? No, but it feels a lot better.
80%?
Yeah, maybe. Percentages, your idea of percentage and mine might be a little bit differently, but I think that 70 to 80%. I mean, I only hear ringing right now in my left ear for the most part.
Yeah.
Or someplace in the center of my head. Feels like it's coming from my left ear.
Okay, good.
Yeah.
So let's continue the left ear as well.
Okay.
Yeah, we just treat the right side.
ACE International Conference of Physiotherapy, Physical Rehab, and Sports Medicine.
Yes. This was a presentation, video presentation from Dr. Millie. And any questions related to this topic? Madam is in Zoom meeting. You can directly ask the questions related to this topic. Even after the completion of the Congress, we'll be mailing you if you have any kind of questions related to this topic. Thank you so much, madam. It was a great video presentation. And hope we expect your presence for next year in face-to-face meeting. Thank you once again. Next, we'll ask Dr. Basima Kimia, or also no, we'll go with Dr. Rajana Balhere from Sanchez Institute of Orthopedic and Rehabilitation Center of Physiotherapy from India. Sir, if you are ready with the PowerPoint presentation, you can start sharing your slide.
Hello, can you hear me?
Yes, sir.
Okay.
Fine.
So, myself, Gajanan Bhalera, I'm a physiotherapist working in Neuro Rehabilitation Center. Today, I'm going to talk about the mobile device. It is a revolutionary device for post-stroke rehabilitation. Usually in stroke rehab, we have multiple approaches like now what we know is entity boomstorm, motor learning or task-specific training. But out of these approaches, the most effective treatment which were proved to be shown effective is the concepts based on motor learning, motor control, and out of that also the more important emphasis is given by research is on intensity, repetition, practice, and frequency and opportunity to practice at home. So based on that perspective, we have to think about this. So let me make you understand what is a machine. Basically, machine is anything that reduces human effort is a machine. So whenever we are in rehabilitation center, we wanted to give a lot of repetition and high intensity by the therapist, but sometimes giving more repetition and giving more resistance can be very tiring and more extensive for the therapist and may not able to do a lot of repetition. By research, it has been shown that to produce a good motor learning effect, we need to do 10,000 repetitions to show a good change. And if you in our routine practice, we do only 10-20 repetition for each exercise. But usually I recommend mainly 100 to 200 repetition at least for one exercises. So for that, we require some solution. So if you have something which can, a device which will do the repetition and can control our high intensity, that way it will reduce effort and that the energy required by the therapist. So it's better we get some machine. Like the robotic assisted devices, they can assist us in giving high repetition, high intensity, and more practice also. This also helps in solving our progress report. Like whenever we are treating, we want to measure a progress, but we try to measure in our regular scale. Sometimes they are not, they vary from person to person and they may not be accurate. Whereas a electronic device or some machine device which will give an exact measurement of progress and we can compare pre-post. So that way also robotic is helping us. And exercises are very boring because you are doing same thing again and again. So if we add some entertainment or engagement or some virtual reality, that way robotics can help us in reducing the boringness. And this is where the importance of continuous audio visual feedback by the robotics helps in giving us the feedback and make it engaging and keeps the patient more interesting in the exercises. And these devices require less space and less manpower. So even if you have few therapists, if you put on somebody on robotics, they can help you and get you better repetition, practice, measurement of your progress, and keep the person engaging in your therapeutic rehab. So there are different robotic devices are available in the market. If you look at below the line, all these devices, they are very expensive. They cost us around from 1 crore to around 5 crores, which may not be feasible to be used in developing countries. So we need some solutions which can be more effective plus at low cost. So this is where the RIMO come into picture, where they started with the more simpler and effective device with low cost, with all the additional feature which we can, some of them which can you see in the previous, the devices which can use see in the line below the this line. So what mobility device? This provides robotic assisted devices. It facilitates mobility and strength recovery, and it saves 25% of therapist time, and it also reduces the cost up to 50%. So the mobile has a different program like assisted mode, then assessment mode, active assisted mode. Active assisted mode means basically if hemiplegic has a bicep control but tricep is weak, so the mobile will help you doing elbow flexion, and if elbow extension is not possible, then the machine can assist you. Or if you set the elbow flexion up to 60 degrees and patient is able to do up to 30 degrees, the last 30 degrees is assisted by the machine. So that way it can be assisted also, or it can be active mode where the patient is completely doing on his own without any assistance. Or if you want to do resistance training, then you can add resistance also. And it also has a lot of game modes, so keep it more patient engaging and interesting in the repetition and practice because daily exercise can be boring. And there are a lot of ideal modes also based on the personality. Like you can have ideal games for cooking, football, or driving. So based on the patient's interest, we can keep different the ideal game also. Like you can see, these are the ideal game: driving, opening a doorknob, pouring water from the crap, and grip and release, opening a key. And there are these extensions. There are upper limb attachment like wrist, elbow, shoulder attachment, and then for ankle knee and hip. So basically, whole body has been covered in this training, upper limb as well as lower limb in a single machine. So this is the upper limb training component. Like these are the attachment. This is for the shoulder, elbow. And then this is supination, pronation. This is for your wrist extension and flexion, and this is for radial and ulnar deviation. Here you can see that how it has been used for elbow flexion, shoulder, or supination, pronation here, and here we are doing for wrist elbow extension. Or this is again elbow attachment with some gaming zones. So this is how you can use upper limb exercises. And in this, these are the lower limb attachment and ideal training knobs. Like this is a driving knob, then door opening closing knob. This is ankle attachment. This is for the knee and hip elbow. This knee and hip, and this is a key pinch. So this is where you can see that how we can apply the same single device with different attachment for upper limb and lower limb and all the joints of the upper and lower limb. And along with that, we can give them ideal exercise training also. This is how the example of cooking training. So the animation will be like a person is cooking, and she can keep rotating the hand, and it will be shown in the animation, and it will also count how many repetitions you have done. So you can see this animation now, how the person is doing rotatory movement, and you can see that in the animation, the person is seeing that she is able to steer the spoon in the during some cooking of soup or some liquid material. Here, this is the animation for the driving. Here, the person is actually doing rotation in the wheel, and you can see the changes happening in the screen. And this is like you are doing gardening, and you are doing supination, pronation. That way you can pour water. This is for key pinch or doorknob. And here you can see that the person has to come in the center and go laterally. And that is how you get a good animation also to get a good feedback. This is the video will show you how we can use this for different devices, different joints. Like this is for elbow flexion extension. Here you can see that there are two flags been seen. So the person is given target that you have to move to this flag. From there, you need to move to other flag. And this blue bottle which shows that how much force the person is applying. Okay. This is for assistive elbow flexion extension. Again, you can see the flags here. And the moment the person touches the flag, then only the machine will count that as a single repetition. Otherwise, the person has to keep doing elbow extension. This is assisted mode. Like this guy has a elbow flexion control, but elbow extension is assisted by the machine because he's a hemi with spastic hemiplegia. So elbow extension is a little bit difficult. Here you can see that there is a orange and blue. So whenever the person is applying force, that blue percentage shows the human effort. This is your human effort, and right side what you can see the machine effort. So you can see the feedback also, how much you are doing, how much is the machine is also doing. So whenever the hemiplegic patient is unable to produce force or unable to bend the elbow, the machine will going to guide you. So this is a very good feedback for patients also and for therapists also, that how much the patient is doing and how much the machine is doing. Again, this is ideal game. Like here we are using elbow attachment for ideal games where he's learning how to drive a car through the passes, and there are different challenges are coming in between. So he has to collect the coins, and if he gets some cars in the road, so he has to dodge that and go ahead. Like here you can see that here the person has to pass through the passage precisely based on the timing and collect the coin. If he touches the blue pipe, then there will be minus scoring. This is for again supination, pronation attachment. Here you can see that he's bombing on the spider and he has to kill. So again, this is a very good feedback, more interactive for the patient also, not boring, and he has a targeted movement. So he just he's not just doing just supination, pronation, but it is more engaging also. Now here it is this guy has a weakness in the supination, pronation. So the machine is doing assisted rotation. Like supination is done by the machine and pronation patient can do it. So here you can see that the orange and blue section where the patient and therapist force can be measured, and that the bottle filling will show how much the pressure he is applying. again, there are different games. Like you can see that there are different games here. Here the person has to move slowly and not to touch the birds and collect the coins. So this is for again wrist extension and flexion, where the helicopter is moving up and down, and he has to collect the coin without touching the birds. If you touch the birds, then there will be minus point, and if you collect coins, then it will be plus points. Here for boys, especially they like football, so you can see that you can use football as a game for interactive games training, and here we are using this for wrist flexion extension control. So again, this is a common game we have played in our childhood, where the ball is going to bounce on this bar here, and then it will bounce back and it will break the bricks. So here we are using this for pinch grasp, and with the pinch grasp, he is supposed to move the lower bar sideways, and the ball will bounce and go back and hit the bricks, and you will get the feedback. And in this, there are different levels also, like level 1 to 10, there are levels. So initially the speed will be slow, the ball will be coming slow, and as the level improve with the speed and the bricks movement also will change. Again, this is jumping jack, which is going upward. So here we are using a doorknob as an attachment, and with this rotation, he has to keep moving that jumping jack, and he has to land on the different steps, and from there you can use the boosters and go up. So again, this is very good example for how to engage the patient in the exercises and get better result. This we are using for ankle. This is for dorsiflexion and plantar flexion attachment. Usually our all hemiplegic has very poor ankle control. So this way we can use assisted ankle training as well as passive training also, and active registered training also. So this is the space game we are using here. Here we have to shoot the object and get the points. So here this is the quadriplegic patient who is using this for elbow flexion extension, and you can see that she is using the irradiation from her shoulder into the elbow and then getting the movement. Again, this is also another quadriplegic patient. Here we are using for wrist flexion extension movement. So this way, this device can be used for upper limb training or as well as lower limb training, strength training, and you will get good result. This device is developed by this company called as Rimo. These are the just fresh graduate engineer students. 2 years back, they started with this product and came up with a low cost. And now they are in production and selling this product throughout the India. So this is how the device will look like, and this is how we can attach the device to the stand. And this stand has a capability to go upward. The device can be moved upward or downward based on your requirement, like you are using for upper limb or lower limb or patient side. You can change. There are different mode, like there is passive mode, assisted mode, passive trigger mode, and these are the different attachment which are being used in different patients. And you can change that attachment for the knee or hip also. And like you can see that here the person is working like a football. This is aerial training game. This we are using for shoulder flexion. And this is where the more she goes down, the laser will shoot the ball. This is a very simple game where the person has to cut the pineapples. And this we are using for radial and ulnar deviation. You can see the attachment here. This is again for supination pronation. So you can see that in the end, we can get the report like this. Sorry. In the end, you will get a report where how much movement is done by the patient, how much range he's moved, how much torque he has generated, and what was the time duration also. This is how it works. So the common mistake which is being used when you are using robotic is that usually robotic is supposed to be adjunct, not a substitute. So make sure that we should use that adjunct and supportive device and not as a completely passive device where you put the patient on the machine and the patient will keep doing that. So it has to be more engaging. Thank you, sir.
Yes. This was a presentation from Dr. Gajanan Balhero. Any questions related to this topic? Any questions? Just you can raise your hand if you're having any questions, or you can text in chat box. Yes, thank you so much, sir.
Thank you, sir.
This event. And we expect your presence for next year for face-to-face event. Save this same topic.
Thank you, sir.
Thank you so much. You'll be getting the first page along with booklet within a couple of days. Thank you so much, sir, for joining this event once again.
Thank you.
And next we ask Dr. Basima Timhe from Exercise and Rehabilitation Science from University of Birmingham from UK.
Yes. Yeah. You see my screen? Hello?
Yes, ma'am.
Yes.
So today I'm here to present my study on exploring the needs of a stroke patient after discharge from rehabilitation centers in Saudi Arabia. There are around 29 strokes per 100,000 annually in Saudi Arabia. And the rationale for doing this study is there are very limited services in Saudi Arabia for those patients. In fact, there are only 3 stroke units and were located in the capital city. So the other 95 of a stroke patient were treated in non-specialized stroke hospitals. So they did not receive proper treatment. And the second thing for doing this study is assessment of needs post-discharge for the patient is vital to evaluate the effectiveness of rehabilitation services given for them. And additionally, there is no research has done this before. What do I mean by needs? So needs has been defined differently in literature. Some authors has defined it as just rehabilitation needs or psychological needs, but here we define it as any expressed need that is not satisfied by the current services. So the aim of my study is to explore their needs post-discharge from rehabilitation centers and to see what factor can influence their adaptation from rehabilitation centers. I used IBA as a methodological or design for this study. IBA is an approach or methodological approach, qualitative approach that investigates lived experience. And it is the most relevant for our study as I said, explore lived experience. And IBA incorporates ideas and concepts that has been existed from long term, such as phenomenology, hermeneutics, and ideography. The participants for our study were stroke patient, adult or over 18 years old, discharged within 3 years. Why 3 years? To minimize recall bias and to ensure that their experience are relevant to the current practice. The patients were excluded if they have any cognitive disorder, and this was assisted by MMSE, and if they have any communication deficient. Ethical approval sought from two sides, and rehabilitation specialists helped us in the recruitment process, and they helped us in recruiting patients from the existing database of the two hospitals. Data were collected using semi-structured interviews. The interview guide was developed based on previous literature review has been published, and the interviews were done online. The analysis tool was IPA, Interpretive Phenomenological Analysis. The analysis was done by me and other 3 additional analysts. This helped in improving or enhancing the rigor. Other things to enhance the rigor, that after we finished the analysis, it was sent to 2 senior reviewers, and 1 transcript has been sent back to 1 participant for checking. In addition to notes were taken during the interviews. So we managed to recruit 24 participants, and we felt this number is sufficient. And as we reached to the data saturation, the participants were 15 males and 9 females. The age ranged from 29 to 65, and time since stroke ranged from 7 months to 11 years old. Our finding shows 3 major themes, including their experience with the current therapy, and their coping post-discharge, and their need for adequate services. So the first theme was their experience with the therapy or the services. The first sub-theme was their perception of care. Participants were not satisfied with the intensity of rehabilitation, as they felt 2 days per week were not sufficient to regain their function. Also, they were not satisfied because they experienced delay in starting PT. Their experience post-discharge involved very limited services, as there no community services post-discharge, and loneliness. COVID-19 had an effect on them, as they were not able to access services, so their case was progressed. And if the participant was able to pay for a therapy, so they sought private care. If not, so they not. The second major theme was coping post-discharge. Coping facilitators involved faith. Participants felt that faith and prayer helped them in achieving inner peace. Recovery rate, they compared their recovery rates from the onset of a stroke and at the time of the interview, and they compare their recovery with other participants. Social support like family support and leisure also helped them to cope. The barrier involved medical, such as physical weakness, psychological, such as depression, feeling hopeless, useless, and social. Not all places were designed for disabled patients, and lack of transportation as well. Financial, most participants either retired or took sick leave, and lack of guidance. Participants wanted more information on what services are available for them, and how to do self-management as well. The last major theme was their need for adequate services, which involve intervention needs such as rehabilitation program. Participants wanted more services in psychological therapy. Also, they experienced a staff shortage as most of or the two hospitals were relying on these trainees, but the participant wanted to be treated by experts, not a trainee. Not all patients were able to access services. Some of them had to travel to join a clinic, and some hospital equipment were too old. The second sub-theme was care continuity. Participants wanted to extend their therapy as much as they want because there is no community services for them. Communication, they wanted a clear channel to communicate in case if they have any query, and follow up for psychological relief. This is the summary of the major themes and sub-themes, and we have already explained each theme. So after examining or exploring the needs of a participant, we reached to a finding that the main need for them is to continue therapy post-discharge as much as they want. So we suggested some approaches to improve long-term care, such as self-management, and self-management mostly involves setting goals and monitoring the progress. Family training was one potential approach and was suggested by similar community context in Malaysia. For the next step for us was to explore to find approaches on care continuity. So we will explore approaches from therapist perceptions, and we will design a program to train them on how to provide the best plan for self-management and family training. I reached to the end of my presentation. If you have any questions.
Yes. Any questions? Any questions to Dr. Basima?
Thank you so much.
Yes. If you have any kind of questions related to this topic, we ask you to text in chat box, or else you can mail us after the completion of the Congress. Yes, thank you so much, madam, once again. Thank you for your patience. And we'll be sending the booklet as well as this participation certificate within a couple of days. Thank you once again. Hope we expect your presence for next year face-to-face meeting.
Inshallah.
Thank you so much.
Thank you.
And next speaker will be Dr. Danita Jadoo from MCGME Comprehensive and Thalassemia Care, Pediatric Hematology Oncology and PPT Center from India. You can start sharing your slide.
Hello.
If you are unable to share the slide, please let me know so that I can share from here.
So 150.
Shall I share? We have received your PPT, madam. Shall I share from here?
Sure.
Shall I share from here? If you are yes, I can share from here.
Sure, sir. Please.
Okay. As soon as you complete your slide, just let me know. Just you can let me know the slide change. I'll be changing from here.
Oh, okay. So good evening, everyone. I am Dr. Dhanita Jadhav, consultant physiotherapist at MCGM Comprehensive Thalassemia Care, Pediatric Hematology, Oncology, Bone Marrow Transplantation Center, Borivali, Mumbai, India. So we'll be going through the impact of physiotherapy and starting with the introduction. So we'll revise the basic physiology of hemoglobin molecule. So hemoglobin is basically it transfers O2 from lungs to tissues by highly specialized protein molecule, which is known as hemoglobin. So, and which is located in a red blood cell. Each hemoglobin molecule have two pairs of identical subunits, the globin chain, alpha and beta. So now here I will come to the topic. So that the term thalassemia refers to the group of blood diseases which is characterized by decrease or absence of synthesis of one or more of the normal globin chain. So basically, the synthesis, it is a synthetic defect which leads to the formation of fragile abnormal red blood cells, which can be easily hemolyzed, leading to the chronic anemia. And the diagnosis is established by HPLC method. So according to the clinical and hematologic conditions, the severity of disease is classified into three, like trait or minor, thalassemia intermedia, and thalassemia major. So phenotypically, it is divided into two groups, transfusion dependent thalassemia and non-transfusion dependent thalassemia. Please change the slide. Introduction will be continuing with the clinical features or the complications of thalassemia or patients who are diagnosed with the thalassemia. So it's basically a chronic disease and present with a wide range of serious clinical and psychological challenges. The effect of thalassemia on physical health can lead to physical deformities, growth retardation, and delayed puberty. Severe complications such as heart failure, cardiac arrhythmias, liver, endocrine complications, infections are common among the thalassemia patients. Children with thalassemia are less active than their healthy peers and generally have decreased muscle strength and flexibility. And the main thing, the pain has become increasingly common and an emergent complication of thalassemia. The exact mechanism of pain in the thalassemia has not yet been clarified. However, iron overload, low hemoglobin levels, and low bone mass have been suggested as a possible cause. Please change. So here I've come with the study from my center. It is a retrospective study. In previous slide I spoke that patients with thalassemia have often complain of pain, fatigue, and breathlessness, and there is a lack of studies on the thalassemia, and or the studies which I've done was the observational studies, and it shows that these patients have reduced bone mass, high risk of osteoporosis, engaged significantly less in physical activity. They have significantly high iron overload.
Under construction.
Further decreases.
Physiotherapy.
However, there of the literature of studying the of this type of studies. So here we came with the study which shows the impact of physiotherapy on the health of individuals with thalassemia. So material and methods were the record of 160 patients reporting the center from June 2017 to June 2018 were retrospectively analyzed. 145 of these were transfusion-dependent thalassemia patients and 15 were non-transfusion-dependent thalassemia patients from 15 to 30 years of age. They underwent systematic examination of range of motion, muscle tightness, manual muscle testing, followed by management for their respective complaints like pain management, strengthening exercises, aerobic exercises, pulmonary rehab, as per their complaints I said. The assessment was done using visual analog scale for pain and fatigue as well. Symptoms of breathlessness were assessed by New York Heart Association, that is NYHA grade. So the result came like this. Out of this 160 patients, 97 were males, 63 were females. So among the symptomatic patients, 92 had bony pain, 21 had dyspnea, 31 complained of fatigue, and 16 were asymptomatic. So after physiotherapy, there was significant improvement in pain, that is p-value was less than 0.001 for dyspnea as well, and fatigue too, in transfusion-dependent thalassemia patients. Though the number of non-transfusion-dependent thalassemia patients was small, but NTDT patients too showed significant improvement in pain, dyspnea, and fatigue as well. So I have shared the results in the statistical objective data, which shows the improvement in pain, improvement in dyspnea, and improvement in fatigue. Then the conclusion was that the inclusion of physiotherapy management in the protocol of patients with thalassemia significantly improves their health and well-being. Hence, we recommend ongoing physiotherapy regime as an essential part of a comprehensive thalassemia care. Can you please change? So basically, from this slide onwards, I'm sharing with you the physiotherapy management of thalassemia, the complaint profile of thalassemia. So what are the bone diseases in thalassemia? These are like reduced bone density, bone deformity, joint pain, bone marrow expansion, fractures due to the osteoporosis. And their complaint profile will remain like back pain is more common, calf cramps, knee or ankle pain, breathlessness, that is dyspnea, and tiredness, that is fatigue. Please change the slide. I'm continuing this slide for the bone diseases in thalassemia. So the patients with thalassemia, they undergo DEXA scan annually, and which is like a dual energy X-ray absorptiometry. It is a non-invasive technique and can be performed on the hip, spine, and radius. And the gold standard for the measurement of bone marrow density were used. And based on this DEXA, osteoporosis can be defined as the T-score. T-score basically compare your result to the healthy young adults in the age group of 20 to 35. So when T-score indicates less than minus 2.5, which shows osteoporosis. If the patient's T-score is between -1 to -2.5, which means the condition is osteopenia. And if the T-score is more than 1, which is like a normal bone density range. And the lumbar spine and femoral neck area are the two most common sites for the measurement of BMD are used for the DEXA scan. You can change the slide. So here come with the pathogenesis of bone diseases. This is basically for the thalassemia. The primary thing is it is like a bone, it is a blood disorder. So the anemia is common. So if they don't get an adequate transfusion, they do have an alteration in a marrow metabolism due to iron overload. They do have hormonal alterations. They do have hypogonadism, hypothyroidism, hypoparathyroidism. They have ineffective erythropoiesis. They have nutritional imbalance in terms of calcium absorption or vitamin D absorption. You can change the slide. So physiotherapy management is divided into pain management, exercise prescription with respect to thalassemia, and fall prevention in view of osteoporosis. You can change, go to next slide. So the pain management starts with like pain has been reported in thalassemia in multiple publications over past 2 decades. The most frequent pain trigger was a low hemoglobin level, and the relief was reported after a blood transfusion. which is the backbone of the thalassemia treatment. The pain significantly increases with age. The pain is chronic. Pain primarily site is the back, followed by calf, knee, ankle as well. Pain etiology is elusive. 47% reported decreases pain with the blood transfusion. This the result is basically from our center, and 43% reported decreased pain with rest. Physiotherapy is targeted to reduce pain, improve mobility, and muscle strength. So, physiotherapy could play a large role in education, treatment, and possible prevention of exacerbation. And modalities may be helpful during acute pain. And the aim of the physiotherapy in thalassemia basically to conserve bone mass, to reduce the risk of fall, promote extended posture, reduce pain, improve mobility and function. You can change the slide, please. So exercise prescription goes with a fixed principle, that is frequency, how frequently you should be exercising, intensity, how much or how intensify your exercise, in the time and the type. You can change the slide, please. So exercise prescription will be continuing for aerobic, resistance and bone strengthening diet. The frequency for aerobic will be 5 days per week. Intensity will be moderate and vigorous. Time will be 30 to 40 minutes with rest periods, of course. Type is like brisk walking, running, cycling, swimming. For resistance exercise, the frequency will be 3 days per week. It could be body weight or lightweight exercises of 8 to 12 repetition, 30 to 40 minutes. And the type will be lifting of weight or resistance band or body weight. Bone strengthening, this is specifically for osteoporosis and fall prevention. It goes for 3 days per week. Intensity is not applicable for this type of exercises. Time is 30 to 40 minutes. And the type is running, rope skipping, outdoor games, etc. Especially for outdoor games, they are not allowed to play contact sports, because they are already suffering for osteoporosis, and the contact sports which lead to more kind of injuries, which can be like serious injuries like fractures. So they are supposed to play with the safety precautions. You can change the slide, please. So what are the benefits of exercises with respect to thalassemia? It reduces the bone loss. Conservation of remaining bone tissue will happen when you continue with exercises. It improves physical fitness, which is really required as they have exercise tolerance and fatigue, which is common complaint. Which improves mobility. It gives better sense of balance and coordination, so which prevents which reduces risk of fall. Obviously it reduces the bone fracture caused by osteoporosis. It reduces pain. It improves fatigue. It reduces respiratory stress, which generally gives by pulmonary hypertension or severe cardiac iron overloading. You can change the slide. So the exercise precaution should be taken while prescribing the exercise to thalassemia patients are like prior to resistance exercises or aerobic exercise, perform warm-up activities for 5 to 10 minutes. Move through available and pain-free range. Like some of the thalassemia patients, they do have arthropathies because of some drug-related like chronic complication. Cool down after completion of exercise, it needs to be performed. Avoid combination of flexion, rotation of trunk to avoid stress of the vertebrae and vertebral disc. When performing resistance exercise, it is important to increase the intensity progressively, but within the structural capacity of the bone. You can change the slide. And the last part of the physiotherapy treatment is the fall prevention. So basically, it's a 5 steps. There are 5 steps to fall prevention. First is the encourage annual eye exam. The second is the encourage annual hearing exam. These two are very important for thalassemia patients, as like I said, the backbone of the thalassemia treatment is the blood transfusion and iron chelation, which reduces the iron overload from the organs. But the complication of this chelators is like ototoxicity and eye problems. So they should go for the annual eye exams and annual hearing exams. Then the third is the offer activities that can improve balance. So balance training is important. Then the fourth will be like focusing on with respect to the indoor and outdoor safety tips. So indoor tips will be like place items used most often within the early reach. Then the second will be like if you live alone, have a cell phone or cordless phone to take from your from the room to room, so that you can call for the help whenever if you unfortunately if you fall. With respect to floors, like remove all the loose wires, cords. It should be free from clutters. Be sure that all carpets, areas, rugs have skid-proof backing. Do not use slippery footwear. Keep furniture in its usual place. So that if the condition like blackout or if the light the load shedding will happen, or if suddenly the light offing happens, you should be knowing the area for escape. Then for the bathrooms, install grab bars. If you have unsteady, if you are unsteady, like if you have volleyball, install use chairs for a bath. Hand shower, you can use a hand shower. Clean up spills so that as soon as it happens. For the outdoor categories, the last point of this fall prevention slide is a replace shoes that shows the sign of wear. It means wear low heel shoes with rubber soles. Use handrails, as you can go up and down when you're using chairs or escalators. Look carefully at the floor surface in public areas. And generally use shoulder bag or backpack so that you can easily move out. Stay alert and focus in public places. So these are the fall prevention tips we generally share for the thalassemia patient. So you can change the slide. So these are the references for my presentation. And I will be thanking to the authority for giving me this opportunity. You are free to ask any questions with respect to thalassemia management. Thank you so much, sir. Thank you, everyone.
Yes, any questions related to this topic? Any questions related to this topic? Please let me know. Yes, thank you so much, madam, for joining this event. Hope we expect your presence for next year in face-to-face meeting, if everything goes well in 2024. And within a couple of days, you'll be getting the participation certificate, both electronic booklet as well as certificate. And your abstract will be published after 2 to 3 months of completion of the Congress book proceedings. Thank you so much once again. Thank you so much once.
Thank you.
So next we will go. Next we will go with Dr. Robert Livesey from New Westminster from BC from Canada. The topic will be a review of the ligamentous articular tissue pain referral patterns, implication of musculoskeletal rehabilitation. This is the video presentation from Dr. Robert.
Okay, everybody, thank you so much for being here today with me. I am greatly appreciative of the time that you are taking out of your personal and professional lives to be with me here today to watch this presentation. Thank you to the World Congress on Physiotherapy, Physical Rehabilitation, and Sports Medicine. This is my third time presenting for this group, so I am incredibly appreciative of their interest in my work and for requesting me to present to you once again today. So let's get into the presentation. We're here today to go over a review of the ligamentous articular pain referral patterns and implication for musculoskeletal rehabilitation. I teach ligamentous articular strain techniques. I also research anatomy and physiology pertaining to ligament joint capsule tissues. And I also am a clinician, so I work at a very busy clinic in Vancouver, British Columbia and Pro Health Clinics. I've run a practice for over 29 years that treats patients in pain, discomfort, and dysfunction. I'm biased towards a evidence science-based practice and biologically plausible explanations. I treat from a structure of neurocentric, biopsychosocial, and biotensegral perspective. I have online courses, posters, and a book that I have created and published that accumulates all of this research that we'll be discussing today. I live with chronic discomfort, so I'm not just a clinician, but I'm also a patient. Again, this is where you can go to purchase the book or the posters. It is an accumulation of all the research that we'll be discussing today. I need to send out a big, huge thank you to Dr. Omar Abashadi. He assisted me in acquiring the data and going through the research for this information. He is an immense amount of knowledge and just an incredibly nice gentleman that was generous to lend his expert and skills and expertise to these projects. So I'm currently in Vancouver, British Columbia. You are in Paris, France. I wish that I could be there in person with you, but unfortunately life circumstances have provided me the opportunity to just be virtual with you, but hopefully at some point in the future I will be there live with you. This is where I'm at in Vancouver. It's in the spring, early springtime. It is gorgeous outside. This is the winter that we just had. These are the Golden Ears Mountains that are about 5 minutes away from my house, and some nice river images that are again about 5 minutes away from my house also. So we don't really have anybody that ever comes to us feeling awesome. They typically come to us seeking relief from any type of discomfort or pain. And there's so many different types and qualities and experiences of pain that come through our practices that it can actually be quite daunting. It can be quite stressful. It can cause a lot of stress on the practitioner depending on what their level of education is and what their biases are. And the information that I provide to you today hopefully will calm everyone down and just realize that the information that I provide you today is just a small piece of the pain puzzle that we are all educating, self-educating, and working towards in order to improve our outcomes with our patients. So we're going to go through a little bit of my history into this subject matter. So when I started my practice back in 1994, we had these really ugly trigger point pain referral charts that were everywhere. They were in all of our treatment rooms, they were in physio clinics, they were in massage therapy, chiropractic clinics, they were everywhere. And my patients that were coming to see me at the time, they were looking at these images and they were saying, that's not me. This isn't how I'm experiencing the discomfort that I'm currently going through with my ankle sprain or my shoulder dislocation or my AC separation or my current fracture or whatever. So what I did is I gave them a marker and I made them go to the trigger point charts and draw on their personal pain referral patterns that they were experiencing. And then over the course of about a decade, I committed these pain referral patterns to memory so that when someone came in with a medial collateral sprain of type 1, 2, or 3, I would automatically sort of recognize what the pain referral pattern is. But I wanted to know more about what these pain referral patterns were because they were not included in my curriculum. So I went on a search. Part of my search led me to George Hackett and Gustav Hemswell. They were medical physicians in the States. They were the pioneers of prolotherapy. They did a ton of research into the joint pain referral patterns of the axial skeleton, but as you can see, their images are quite terrible to try and decipher. I searched for other images and found more that were quite, they were a little bit better than the Hackett referral patterns, but these were really kind of, they were wanting more for an image. I went searching to see what else I could find. I was very honored to present at the 5th World Congress that was in May of 2022. And at that conference, I presented on the neurological innervations for the joint capsules and ligamentous tissue for the axial and for the peripheral joint capsule tissues. And what that research did is it consolidated the information about the afferent nerve fibers from the dorsal roots of any spinal nerves that mainly supplied detailing the joint capsule ligamentous tissues in the humans into a central database. And the reason why I did this project was because the neurological innervations for axial and peripheral joint capsule tissues was relatively unknown by a number of my colleagues, physios, massage therapists, occupational therapists, kinesiologists. And to be honest, the only people that really got this information were some chiropractors or any of my colleagues that were regional anesthesiologists. So based on all of that research, we created new images based on the research that documented which nerves supplied which parts of the joint capsule and ligamentous tissues. In November of 2022, I then was very honored to present at the 6th World Congress of the Physiotherapy, Physical Rehabilitation Sports Medicine, where I presented research documenting the ligamentomuscular reflexes. Because we know that when we have patients that have had joint injuries or post-surgery, for ACL reconstructions or glenohumeral joint reconstructions, that they do tend to have some type of either inhibition or stimulation that occurs in the musculature. So this protective mechanism got me interested. So I went through and did the research and was able to accumulate the information that discussed the muscle coordination for the functional joint stability. It requires a delicate balance of either an inhibition and an excitation or a co-contraction of the muscles that cross the joints based on what they were linked to for the joint capsule ligamentous tissues. Again, most of my colleagues were unaware that that was actually a reflex that existed. So today we're going to talk about the pain referral patterns that come from these ligamentous and joint tissues. So why is there a need for this knowledge? Well, we know that the ligamentous articular tissues continue to be an under-recognized source of dysfunction and nociception. Traumas and pathologies interrupt afferent impulses from the capsulo-ligamentous structures, resulting in an altered somatosensory perceptions, movement dysfunctions, discomfort, and or pain. So knowledge of these capsulo-ligamentous articular tissue pain referral patterns are relatively lacking amongst medical physicians and orthopedic rehabilitation professionals. So the purpose was again to consolidate this research, documenting the pain referral patterns into a central database. We did a literature review, was done by myself from 96 until 2010, and then we did a more in-depth literature search through July 23rd of 2022 to August, and we were able to find quite a bit of research. But first we need to go back and do a little physiological review for you guys. I need you to understand that we no longer look at these joint tissues, ligamentous structures as separate entities from every other anatomy surrounding. These are different densities with specific functions. So you can attune them to a cotton ball. So there's different densities with specific functions between a cotton ball, a toning cloth, or a cotton pad. So they're really kind of like cotton balls that get sort of pulled apart. We know that the ligamentous joint tissues have sensory properties. We also know that they have mechanical properties. And how they typically get injured is they go into a failure zone through the stress strain curve that actually causes permanent deformation and tissue rupture. Where we like to sit is we like to sit in this Goldilocks zone between the yield point and the failure point, where we can break down a little bit of tissue, but then we provide the opportunity to build back up a little bit stronger, and then we can continue on. But it's when this tissue rupture beyond a failure point happens that typically we tend to see quite a bit of patients coming through our clinic doors. So we know that injuries happen through either a repetitive loading or through a fast stretch. So repetitive loading would be a repetitive activity. A fast stretch would be sort of attuned to an ankle sprain. We know that there's a creep formation, there's tissue damage, there's release of chemical irritants. We know that it causes an increase in muscle stiffness. That's where that excitation or inhibition of that ligamentomuscular reflex occurs. And then we have connections through the spinal cord all the way through that can cause the perception of pain and referred pain. So then the question is, well, then how does referred pain occur? And what we know from the neurophysiological model for referred pain is that it happens at the dorsal root ganglions. Typically, we have a primary dorsal root ganglion that gets sensitized with inflammatory mediators, and that inflammatory mediator soup can actually migrate anywhere between 3 to 6 levels. Now, if you have a primary dorsal root ganglion that innervates the AC joint, and then that neuroinflammatory mediator soup migrates down to a 6th level below it, that's going to innervate into the wrist and into the thumb. So there is a key features for referred pain. It's typically felt distal to the local pain. It's semi-directional. It's a deeper sensation. It needs a higher stimulus than the local pain, which basically means that you can go down to the wrist, you can palpate the wrist, and you can treat the wrist, but it's not going to help because it's being referred from the shoulder. It's a delayed onset compared to the local pain because it takes time for that inflammatory mediator soup to expand and generate. It diminishes before the local pain as we heal, and then inflammation diminishes, then the pain referral pattern is going to diminish also. And the stimulus at the referred pain site isn't needed, for example, with phantom limb pain. So the review of all of this research consolidates the information detailing the pain referral patterns for the capsules, ligaments, and articular tissues for the axial and peripheral joints in humans into a central database. And the conclusion is that these are neurologically innervated. They cause hyperexcitability to the peripheral afferent nerve inputs, the dorsal horns, and the supraspinal regions, which contribute to musculoskeletal pain syndromes. And our results support the clinical benefits for medical professionals to include the capsule, ligament, and articular tissues in your diagnostic protocols. Knowledge of this data by medical professionals may have significant implications in the design, diagnostic protocols, treatment, and rehabilitation strategies for patients post-surgical or post-injury. So this is an example of the data that we acquired. So this is the name of the ligament of the joint capsule. For example, we have documented from C7 to T1 all the way down to T12. We have the local pain areas, which is around the paravertebral region over the affected joint. And then we have the referred pain areas that have all been documented. From that data, we then created new pain referral pattern images for the axial and the peripheral joint capsule tissues. So these are the examples from the cervical spine to the thoracic spine, all the way down to T11 to T12. This is an example of a peripheral joint tissue. So we have the shoulder region. So we have the glenohumeral joint capsules, the costoclavicular, acromioclavicular ligamentous tissue, the local pain area, and the referred pain area. And then from that axial research information, we were able to create new images based on that research. And then we have accumulated all of that research into this textbook and into the posters for clinicians like yourself to be educated with. So with the conclusion, we now have an accumulation of data from these 3 research projects, which show the joint tissue that we're interested in, the nerve root that innervates it, the peripheral nerve that comes from those nerve roots, the ligamentomuscular connections of that ligament and joint capsule. We have the local pain referral area, and then we have the distal pain referral area. And from that, we've created images for the neurological innervations of the axial and peripheral joint capsule tissues. And we've created images for the pain referral patterns for the axial and peripheral joint capsule tissues also. So the review study identifies and consolidates information detailing the pain referral patterns for the capsule, ligament, and articular tissues of the axial and peripheral joints into a central database. It informs and supports the research, confirming it to be clinically beneficial for medical professionals to include capsule, ligament, and articular tissues in their diagnostic protocols. And knowledge of these ligamentous articular joint pain referral patterns by surgeons and rehabilitation specialists may have a significant implication into the modification of surgical procedures and the design and rehabilitation strategies for patients post-surgical and post-injury. All this data is accumulated in the textbook and in the posters that you can go to ligamentpain.com to get those. You can start using them in your practice. So again, this has been a review of the ligamentous articular pain referral patterns, implications for musculoskeletal therapists, and I have been incredibly honored to present at this conference. This is my 3rd time presenting, so once again, thank you so much to the organizers, to the sponsors, and for all of you for being here with me today. I greatly appreciate the time that you were taking out of your lives to be here, and continue on with the conference, and thank you so much for being here.
Yes, this was a presentation from Dr. Robert. Please let me know if you have any kind of questions related to this topic. You can text in chat box. We will be asking behalf of you. Yes, we'll go with another keynote speaker of the day, Dr. Ian Gutt, head of performance several and lead physiotherapist, Brittle Boxing from UK.
Hi, everybody. Can you hear me?
Yes, sir. It's fine.
Yeah, let me share my screen. Hopefully, be able to see it in a second. No, we don't need sound. Okay, can you see this okay?
Yeah, it's fine, sir.
Okay, I'll kick off then. First of all, thanks to Inovine for the kind invitation to present today. And obviously, thanks to everybody for tuning in and listening. Hopefully, you'll have a good experience. My presentation is looking at force production and tissue tolerance in both athletes and obviously considering non-athletes, but thinking about the role of this in rehabilitation. Just briefly about myself, I work in 3 distinct areas: the clinical, the research, and the education. From a clinical point of view, I work and have been for many years now, full-time in elite sports. I work pretty much in Great Britain boxing as their head of performance services. So I look after all the doctors, the physios, the nutritionists, the psychologists, and so on. So all the performance services supporting GB boxing. Also, I still maintain a clinical role as lead physiotherapist, which I thoroughly enjoy because it keeps me grounded as a clinician beyond a leader within sports. I also work with the UK Sports Institute, formerly known as the English Institute of Sport, and I am an upper limb specialist, particularly providing expertise around hands and wrists, because that's the area where many therapists in various sports, Olympic, Paralympic, but also in professional sports, scratch their heads, but also help with elbows and shoulders. I'm involved in research, actively also currently finishing some projects at the moment, but I'm always involved in diverse areas. And for many years now, I've been involved in education, either through presenting at conferences like today, which is great, working and collaborating with diverse universities in the UK and even overseas. And also I run courses, particularly on the upper limb, and I'll mention this at the end of this presentation. So first of all, one thing I like to talk about in many of my presentations, the slide, which is a simple equation. What does this mean? Well, as therapists, in my opinion, what we should be aiming to do very well is prognosis, is trying to understand what is the prognosis of somebody. And prognosis, for me, the equation has two elements, the diagnosis and the function. Now, a lot of times we do not understand what the diagnosis is. We may have hypotheses or we may be a bit blind. But one thing that we can do for sure is try and understand the function better. And today, one of the things I want to talk about, hence the title, looking at tissue tolerance and force production, is the function. Because if we have less knowledge on the diagnosis, we can increase our prognostic value by increasing our knowledge around the function. And so if we can understand better the function of the upper limb, becomes really useful. And the prognosis, what does it mean? It means knowing how long somebody could be struggling for, is trying to give some time scales, is trying to give an idea where they are currently, maybe compared to the knowledge we have, one from the literature, if there is anything, or from our own experience. So let's delve into this function and try and understand what I mean by function. Well, if you think about function, and I'll explain what that mind the gap at the top means. When we look at function, you've got the activity a person is doing. Within that activity is the tissue tolerance. So every time we do something, we lift a weight, we lift a shopping bag, we do different activities, the tissues are absorbing forces and there's a normal response to it. And obviously they've got a particularly threshold that they can withstand. Within that, some of the things we try and understand are the forces acting around those tissues, the forces exerted by us, the forces externally coming to us, but also the ranges, the mobility that we are able to do. And for me, those two then become very simplistic things, forces and range of motion, which I'll mention in a bit. And then another thing to mention, it's not always the case, but for different activities, you have to have a certain level of fitness. What do I mean by that? Obviously, if you're an athlete and you're a sprinter, you need to have a particular level of fitness. If you're a boxer, a particular level of fitness. But if you're doing certain activities, like you're moving things around over the weekend because you've just moved from a house to another, you still need a level of fitness. Because if you're not fit generally to do certain activities, that will impact locally on certain areas like your upper body. Now, if we focus on those forces and range of motion, one of the things that we need to understand is where should they be when somebody comes to see you? What is their performance requirement? And where is their current status? And then is trying to quantify what that gap is. So that's what the gap is really, is knowing where somebody should be. So if they're an athlete, where is their performance requirement? Where is their current status? And what is the gap? If it's not an athlete, they still need to perform to do a certain activity. They have a current status and there is a gap. Now, the problem is if we try and guess what that gap is. So is there a restriction in range of motion? We eyeball it with our eyes, trying to think, oh, well, yes, we have a rough idea of it. Or with forces, differences between sides, we try and eyeball it also. And we say, oh, well, it looks like there's a 20% difference or 30. But for me, it comes down to certain measurements to support. Now, I'm not saying this is for everybody, but we can use it in various circumstances, which becomes important. So if you're thinking about measuring, minding the gaps, or finding what this gap is, you can be using a hand grip dynamometer, as you can see on the picture on the left, which can be used for hand and wrist problems, can actually be used for the elbow, as the literature has shown us, particularly for your lateral elbow tendinopathies, can even be used to quantify rotator cuff strength, as certain studies have shown. You can be using handheld dynamometers, as you can see in the middle section. You can use it to provoke certain structures like ligaments, which can be injured at the elbow, at the shoulder. And again, so it becomes a provocative test, but it's giving you numbers because you're comparing side to side. And so it's not just thinking about we're measuring strength here, we're measuring force production, and we're measuring the ability of the tissues to tolerate. And if there's a pain response, then obviously you'll be able to produce less force. So you might be strong, but you can't exert it completely, or you might be weak. And also, as a result of that, your maximum is weaker than the maximum on the opposite side. You can be using weights, as you can see on the other side. For example, this is a test where we're trying to look at the shoulder cuff and look at capacity or strength. So different things. In sports, for example, this is a case study which I used for a particular boxer, and using a hand grip dynamometer, we tracked the progression of somebody from the initial injury, where they had a big percentage difference. In this case, was about 87%. And by the end of this journey, so 7-8 weeks, they managed to get within 15% as they were heading closer to another competition. So the whole aim is to try and quantify our progression. Now, if you ask me about their pain, well, I can tell you that their pain didn't change for a long period of time. So the good thing about having something measurable, like an objective measure, is because as the pain remained constant for a long period of time, we still saw progression. And that becomes very important because it's reassuring, even for the person, to say that there is a form of progression, rather than, yes, it's still painful, the pain hasn't changed, but at least, yes, I can see certain changes. But beyond sports, you can even see it in non-sporting environments. So this is a nice study that came out in 2022, so not too long ago, by Dorich and Cornwall, and it looked at the risks, and it looked at chronic, non-specific risks. So these were those risks where people don't have a clue about. So when you're looking at that equation we talked about before, prognosis equals diagnosis plus function, we don't know what the diagnosis is, and so we're trying to result on trying to understand the function. And what do they do here? I know there's a lot of writing here, so bear with me. Let's simplify it. So in the initial evaluation, they use this grip strength as part of their approach. Obviously, they did a few other things, but this was one of the most objective measures that they used. They reassessed at 2 and 4 weeks. So they had this nice plan. There's a plan, and that was one of the main things. So they measured at 0 week, at 2 weeks, and at 4 weeks. And then when they got to 6 weeks, if there wasn't any change, now they put down strength. I would have preferred to call it in force, because you're not really truly measuring strength. As I said earlier, you're measuring force. But if the force improved, you can see they had an algorithm that depends on where the force is, what they can choose, whether the pain had changed or not. And if the force hadn't improved, then there was another part of the algorithm. And one of the things I liked about this is there was a plan, there was an approach, there was an algorithm, and they tried to use this as a guidance for these chronic non-specific risks, which can become quite a headache. And one of the biggest headaches is trying to chase a diagnosis. So rather than continuously change the diagnosis, he's trying to focus more on the function, but in an objective measure, by quantifying how much the tissue can tolerate, by the amount of force being exerted. So it becomes a nice method in trying to reassure people using a more functional approach. I'm not saying you disregard the diagnosis, by the way, you always bear it in mind, but it's always making sure that you don't chase it all the time and forget about other measures which can be function. But again, beyond using open kinetic chain type tests and also beyond exerting force, we can assess tissue tolerance using other tests like weight bearing tests, where you put the weight through the upper limb. So you can see here, for example, putting the weight to the upper limb in this video, and you can get the measurement on the scale, and they can tell you how much pain they have. And obviously you can compare against sides, which can give you a nice objective measure. If, for example, you want to try and use a strategy like strapping the wrist and see whether it works, wow, you can do it straight away, and they can tell you whether it makes a difference or not. You could be taping, you could be using different types of splints. These can be really useful methods in your practice, which don't take lots of time to be able to provide you a way to reassure somebody, but also thinking about short, medium versus long-term approaches in your management. Because again, if you want to use some form of strapping or splinting, you don't want it to be a long-term, but in the short term can be really useful whilst you're doing other elements of your rehabilitation. Other things that you can quantify is range of motion. You know, the hand and wrist, for example, can be using these goniometers for the knuckles, or can be using inclinometers, or these days you've got mobiles, you've got apps, even better, they're in your pocket, and it's about measuring, so you can measure the wrist. Now, how can this be useful? This, for example, was a Formula One athlete, which I worked with, and I did various measurements. A lot of these we've already mentioned in a way. We've measured, and I'll highlight it here. There's the hand grip dynamometer, there's the weight bearing scale, which I've just pretty much shown you. And these are the range of motion. These are different things which we can measure at the wrist. And these are things which actually I teach on my courses. What you can see, there's a lot of whites here, but over here, there's a few reds. And quite interestingly, this is where then you start putting different tests together. You can see they struggled doing a hand grip in an underhand position, so in a supinated position. They were okay in neutral, they were okay in pronation, but when they supinated, there was a big problem. And when you actually look at the measurements of range of motion, you can see that the problem they had compared to anything else, and quite significantly, was supination. So the problem they had there, it wasn't that there was a weakness, they had an inability to produce force because of pain. Because when they were supinating, they had restriction, and when they were trying to force it, they had pain. And so that became a pain inhibition. But for us, it was really useful because the method to try and improve this hand grip, this force in supination, and you can imagine for a Formula One athlete, really important to be able to tolerate all those forces coming through the wrist, is by improving the range of motion. So strategies, rather than trying to improve range of motion in everything, we can be very specific. We know supination is the main problem. We don't need to focus on neutral and pronation and lots of different other things and waste lots of time. We can become very specific because we have measures that can be really useful. And this is also a reassuring picture for the person, for the athlete, and saying, look, you've got a very good picture here because a lot of things are looking good. So all we have is one area to focus on rather than many, 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 many things. And so when we're thinking about optimizing planning and measuring our impact, it's important to, first of all, with our planning, is understand what metrics can be taken. Simple metrics using cheap equipment, the better, and how to use them in the context of creating a plan. So that prognosis is understanding, okay, with the information I have here, is there a big percentage? Is there a small percentage? From my experience, that means it's going to take me longer or less. And so that helps in our understanding also to create that plan, but also create timescales so we can start measuring impact, measuring the ability. Now, it's not taking away that at the end of the day, the biggest impact is when the athlete or the non-athlete feels that they've achieved their goal. So it's always important to ask them, what is their goal from the very beginning? Becomes part of the plan. You know, it's not just about these objective measures. At the end of the day, it's about the person. But this is like going on a trip and you've planned your trip. You know, you want to go from this place to this place. It's going to take you 3 hours. But along the way, you've got these stops. And, you know, because you've got a sat nav, it's hitting the markers. And so these become your sat nav, really. They're telling you whether you're heading in the right direction. A bit like that boxer I showed you there with the trajectory and the hand grip, it's telling us it's moving in the right direction rather than not moving at all or even regressing. So think about your macro planning. And when you're macro planning, again, there's a lot of wording here. Let me just take off a lot of that wording to help you there. You can see some of the things there are the weeks that we put in there. You know, you have different stages there. You have rough time scales. But one of the most important thing at the bottom, you can see where it says completion of stages. And to jump from one stage of another, again, mind the gap is using the measures of range of motion, is using force, So jumping from stage to another and understanding whether we're hitting those timescales, because we've added objective measures to what we feel from our experience should be these normative timescales. From a macro planning, you can go into a micro planning. So this is a nice plan that we actually published in this book, Sports Physiology and Injury Management. Really nice book because it has different areas which have been actually worked through different experts. And so in my area, they asked me what I can do around the hands and wrist and boxing. And this would be a return to boxing for somebody with, for example, a bad injury of the hand, in this case, a carpal metacarpal operation. But again, if I break down, take away a lot of the wordings, some of the important features here are the intensity. So we're actually prescribing the intensity of every session, your Monday, your Tuesday, Wednesday, the volume. So how much are they doing? You can see in brackets there, you can see rounds here. So it's telling you the volume, the frequency. So you can see some days they're off, other days they're on and they're training. So you got intensity, volume, frequency, three really important areas for us to have that right amount of tissue tolerance. And then adjuncts here, again, sometimes you can use things like splints or tape or other things to just offload it structurally a bit better. But the main thing here, what you have is this graduated exposure. You are rebuilding things slowly at the right time. So it's all about right timing and adding in those three components, those three spices, intensity, volume, and frequency. So any intervention that we're thinking about also should be directed at this gap, So how do we bridge this gap? And one of the things that we need to think about is dosage. So with everything we're doing is considering dosage. Now, obviously, if we're thinking about pain, it's not as straightforward a lot of times. We know that. But again, with the information we have, we can approximate our dosage to be closer to what they have. If somebody can lift 50 kilos without any problems, and they have problems at 80 kilos, for example, why start them on 20 kilos? So dosage becomes unuseful in that situation. For muscle properties, again, there is a correct science to call it so. When you're doing strength, you're doing hypertrophy, or doing endurance, then there are different formats that you can use. So that's not a problem. However, we know for exercise-induced hyperalgesia from studies that there is no consistent evidence that you can prescribe certain dosages with certainty. Why? Because one dosage doesn't fit for everybody. And that's why using objectivity in the initial phases can be useful, so you can match that gap even better, rather than just having a formula thinking is going to work for everybody. So a couple of ideas for exercises, just so you have some ideas, really. Again, close kinetic chain type exercises for tissue tolerance. Literally could be on a frequency, just pushing through the structures. This could be useful for your hands, your wrists, your elbows, maybe even your shoulders. And then you can go into more complex things. There could be an element of force reduction that you're thinking about there. It's a lot of the pain inhibition. You could be using open kinetic strategies. So you could be doing isometrics, for example, at the wrist. And you could be doing isotonics, so concentric eccentrics, if the wrist was the problem. But then again, you could be doing things where you're still working the wrist, but this time you're moving the elbow as a joint. So again, it's not everything about the wrist at the edge of a table. Things can become very mobile, which means you're engaging the shoulder, the rest of the body. So there are lots of different things you can use, also because muscles around the wrist cross also the elbow. So it's that understanding. You could be using open kinetic exercises for stability. So again, you could compare sides. What can one lift on one side? What can they do on the other side? What is the pain provocation? These in itself become objective measures. And again, you could be loading quite nicely over here against a wall. You're trying to create a tissue tolerance, tissue adaptation. So you can see different ideas using open and closed kinetic chains. So considerations, if you're thinking about your force production and tissue tolerance, prognosis equals diagnosis plus function, as we said already. Think around that function. So think about the planning, make sure you do have a plan, you do have a way of monitoring. Within that, plan, think about, macro planning and micro planning, so long periods of time, shorter periods of time, just so that you help people reintroduce themselves at the right times. And make sure you have good objective measures, whatever tools you're using, and that you're trying to match that rehabilitation, trying to do closer to that rather than starting completely from zero or overdoing it. They can only lift or do certain things, and we've overdone it, so we've overcooked it a little bit. So my end, I'd like to thank you for your attention. Last couple of slides. If you are interested in further education, particularly on the upper limb, we do a 2-day live and in person, which we do around the world. You can find on all the slides you saw at the bottom, there are my social media, Twitter, Instagram, and LinkedIn. And these are the next courses coming up in England, Kuwait, Belgium, and so on till the end of the year. If obviously you can't join us in person, we also do an online, only looking currently at the hands and wrists, which is a live and online event, where it's a hybrid. We do 4 hours pre-recorded material, which you can see in the leisure of your own house. And then we do a live event, which the next one is on the 6th of October. We do 4 hours. We have myself teaching other modules apart from the ones you would have recorded, but also opportunity for you to ask questions, talk about your clinical cases, make it nice and interactive. Thank you very much. And I do hope that you enjoyed this presentation.
Yes, thank you so much, sir. Any questions? Any questions to Dr. Garth? So you are the last presenter of the day, sir.
Am I?
Actually, you are supposed to be the first speaker of the Congress, according to the schedule we have made. So next time we are expecting you'll be the first keynote speaker of the Congress. So we request you to join face-to-face meeting next year. We request you again and again.
Be great if I could. Be great. Actually, I'm actually on holiday today, so it was actually great to be able to do this online and take some time out of it. If we have the opportunity to do it live next year, it would be fantastic. But I do hope people enjoyed this brief but little insight. And as I said, if people want to follow me on social media, I post many things around courses, but also resources and information. So it's, again, just to make sure that people sometimes can get some free information going on.
Yes, thank you once again, sir. Thank you so much.
No worries, and all the best for the rest of the event, and all the best for the rest of the year, guys. Thank you.
This is the last talks given by Dr. Garth. Please let me know if you have any kind of questions related to this topic. If you have any kind of questions to this topic, just you can text us in WhatsApp or your chat box, or you can mail us so that we can ask a question on behalf of the doctor. Thank you once again. Yes. And what of thanks? We take this opportunity to extend our sincere most thanks to all the speakers, keynote speakers, plenary speakers, workshop, and special sessions parameters, students, delegates, general collaborators, media partners who have come from different parts of the world to join this event for support and cooperation. We also wish to express with great and session chairs and co-chairs for their minute-to-minute guidelines and support for the providing encouragement at every point of time in the organization for this event. Yesterday we have done face-to-face meeting that is in Paris. The keynote for that we once again appreciate and grateful to you, Dr. C.B. Rodi, the Imperial International School from Switzerland, Dr. Kasior from Department of Physiotherapy from USA, Dr. Mary Glenn from USA, and Dr. Dayav Shah from Mumbai, India, and Dr. Emilio Lima from Brazil. And yesterday we have more than 25 talks from face-to-face meeting with the different sessions and different topics with workshops as well. Hope this conference will continue for the next year, 2024, or else we are planning to organize this same event in the month of December 4th and 5th. If anybody are willing to join, we ask you to submit your abstract and book the slot for upcoming congress. You'll be getting the participation certificate as well booklet within couple of days. Thank you once again. Yes, if you have any kind of questions related to this conference, just you can text us. We'll be mailing officially